Hello, my dear friend. A very warm welcome and good morning to all of you. Let's learn the whole important part of PSM, which is expected to come in your January FMG exam. And before going with the regular session, I want to start with some part which we usually miss and which are coming in recent NEET and INICT exam more. And whatever come in last 5 years of NEET is going to come in FMG exam. So if you are going to give FMG exam, don't miss your last 5 years of NEET PG exam. Direct question also come from that exams to FMG. Don't miss it. It's the last time you can do it. Still you can do it. So first thing is this adoption model in which there is three things: awareness, motivation, action. If you wish, that's people use condom. Like I wish Nikhil to use condom, not me, because tibectomy is done in my case, so no need of condom. But if I want him to use it, he is aware, he is interested, he is motivated also that yes, I should use it, because he evaluated that condom prevent from unwanted pregnancy, sexually transmitted disease, and it's helping its decision making. But final thing is action. When he go into action, he don't use the precaution because he think कि क्या कहते हो कि जब बारिश में भीगना है तो छाता लेके क्यों भीगे, है ना? When you are going in the rain, why go with the raincoat, है ना? So he don't use it, but this is the point you have to remember. The mnemonic can be amma: awareness, motivation, and then action occur. Okay, but this question has already came in INICT exam. They had given the filling the blanks type of thing, and they have left the last third point empty, and they ask what is in the third point. So suppose we want people to take vaccination of corona, but before people will take it in rural area, first they will see what is the perceived susceptibility. Susceptibility means, can I get corona? Because rural people think that only urban people had it. So they first see, can I get it? Then they see whether it is just cold and cough or well, we die with corona. So severity also they see. And when they see, yes, corona can kill us, then now they are motivated. So first thing is susceptibility and severity, double S, 2S. Then we get motivated with 2S. Many of you also get motivated, so that's motivation. And then perceived benefit. Benefit means, of course, you understand, we want to think that it will help not just me, but also my family member in developing the immunity of the whole village and family, it will work. So we take it. And then we see the barrier, like going to city and taking it with money was a barrier. So that's why the government made it free for everyone. So BB, first 2S, then BB, SBB, SSBB. In between, you are motivated. Remember, susceptibility, severity, motivation, then benefit and barrier. Finally, we have some cue to action. Cue to action is like some advertisement which government do, which suddenly make them remind that yes, I have to take the vaccine. And last thing is self-efficacy in taking action. Like many rural people in village, rural female especially, they cannot, due to mean-minded patriarchal society of India, they cannot go alone for the vaccination. So if they will be empowered and they feel, yes, I can go and take it by myself, then that will be something which will make the vaccination, that will increase the chances of the female in taking vaccination. So remember, first SS, susceptibility, severity, in between you are motivated, and then there is BB, barrier and benefit. Last thing is cue to action and self-efficacy. But when they ask the middle fill in the blanks, motivation. This is known as health belief model. The third thing which has been asked and students are still confusing, because teachers has confused them, and teachers are confused because recall was confusing. The question was that in an OPD, doctor is explaining thing to the patient, but due to the language inability to understand the language by the patient, he did not understand, because of the rural background, he did not understand what doctor was saying. So which type of barrier of communication was there? Basically, doctors, they, while speaking Hindi also, they use the English word in between. So if the people are from rural background, they don't know English, then it will be difficult for them to understand. So which type of barrier was there? That was the question. Now, in PARC, it is clearly written only 4 type of barrier. First is physiological, when patient have or doctor have some problem regarding hearing, vision, things like which are physiologically wrong. If the patient cannot listen properly, or doctor cannot speak properly. These are physiological problems. Okay. Then there is psychological, mental issues. Psychological, like suppose the patient is having Down syndrome or patient is having autism and patient is unable to take the instruction properly. Other thing is, suppose the patient is depressed, is in delirium, is in mania, and he is not in listening to the doctor advice also, then also the problem can occur. So these are the psychological problems. Now, after PP, physiological and psychological, the third and most common barrier is environmental. No, that's not the most common. The most common is cultural barrier. Environmental barrier is, let's say there is fog, or let's say there is too much patients in the OPD, so the noise is disturbing the doctor-patient interaction. This is one of the commonest barrier in government hospitals because of the loud noise of other patients. Our patient do not understand what doctor is saying properly. So that can be environmental factors, like many overcrowding of OPD can be an environmental factor. But this was the answer of that question. Cultural barrier is there. Cultural barrier, example is rural-urban difference, language barrier, and then attitude, culture, custom barrier, or illiteracy. So if your patient is unable to understand your advice, most of the time it is cultural barrier. Sometimes when the patient is mentally ill, it is psychological. Sometimes when he is physically ill, it is physiological. Sometimes when there is overcrowding or fogging or some problem in the environment, like let's say nearby there is a marriage going on, so the loud sound is disturbing the OPD, then it can be environmental. Okay. So mostly answer is cultural. In that question also it was cultural, not semantic or something like that, because Park has clearly discussed this 4 barrier, and they have used the word that patient, if unable to understand what doctor is saying because of the rural urban difference, that is cultural barrier. So it was cultural barrier the correct answer. Now, a very common question these days is between health education or propaganda. Propaganda is something which is mostly forced into people's mind. It don't let them think. Like before most of the election in India, either riots occur or attack on country occur. So why those riots occur just before election? You must be thinking why it's occurring just before election. Because they want you to feel this, get this propaganda in your mind and then work accordingly. So what is the question they ask? The question they ask is, which one of the two appeal to reason, let you think for yourself? That is health education. Health education will give you the awareness that yes, because all riots are occurring mostly just before election, so that means riots are created, they are not natural. So you will appeal to reason and you will not get emotional when riots occur. You know that yes, this is political propaganda. Now, appeal to emotion. And propaganda is something which they will send message on your phone. If you can't stand for your community, you are better than nothing, like that, and they will emotional you, and then you will take those actions which are animalistic. So remember, propaganda promote our primitive desires like violence and all those things, and health education, it discipline our primitive desire. Health education discipline primitive desire, propaganda promote primitive desire. So remember this two difference first. Promote primitive desire is propaganda, and appeal to emotion is propaganda. Okay. And here it's a standard type of attitude and behavior. According to the mould use or according to the WhatsApp messages used, people behave fixed way. That is propaganda. Third point is, when it is information centered, it is propaganda. And when it is behavior centered, it is health education. This is very confusing point. We think in propaganda we get aggressive, so this is behavior. No. In propaganda, they are giving you a wrong message. Like they will give you the information that our religion is in danger. That is a wrong information they will put in your mind and you get aggressive. But here it is behavior centered health education. Behavior center means they will give you the information to stimulate, that is propaganda. But if they are making your behavior change, it will take time. You will reason and then your behavior will change. So health education mostly change your behavior through reasoning, through some logic. And here it is just information which stimulate you. There are 3 more points which you have to remember. Health education help people to think for themselves, not for the country, not for the community, but to think for themselves. That if I will go in the riot and I will die, who will take care of my children, who will take care of my country? Plus, these riots are politically created, so they will think for themselves. But propaganda will prevent thinking for themselves, and it is ready-made slogan which people follow. Propaganda is something in which people force information in your mind. Knowledge is instilled, it is forced in your mind that religion is in danger, you are in danger, and like that. They push that, and they stimulate primitive desire. And the most important confusing point is which is reflective, which is reflexive. Reflex means you hit me and suddenly I hit you. That's a reflex without thinking. Reflect means when you hit me, I think, why are you hitting me? It may be that you yourself are hidden by your girlfriend or someone in your home or your wife in the night, and you are just uh, taking that anger out on me. Or maybe I will think you are my friend, so you are hitting me. So when it is reflective, we are in control of taking decision. When it is reflexive, it occurs without using mind. So reflexive is propaganda, reflective is health education. Do remember, this is one of the new commonest question. Then there is didactic and Socratic. So didactic means one-way communication. Like on radio, Modi come and give man ki baat. So can you object him that you are just throwing big not? No, you cannot object him. Whatever any news reporter tell in TV news and other places, these are just didactic, one way. You cannot tell that you are saying bullshit. But Socratic means two-way communication. Audience can ask question, audience can ask their doubt, and they can interact with each other. So Socratic in example can be panel discussion, FGD workshop. We will just discuss these all things because they ask this question from this point and we get miss those point. This is my number. If you have anything to say or ask question or doubt, you can directly message me on my WhatsApp. If you want to abuse me directly there. Okay. So now let's come to this question of symposium and panel discussion. And they ask what is the difference between these two. So it's very simple to understand. In symposium and panel discussion, both 4 or 5 experts sit and speak on a common topic, and there is a moderator who moderate the discussion. The difference is only two. First difference, in panel discussion, there is no fixed order of speaking. Anyone can speak depending on the expert choice. They can speak without fixed order. But in symposium, order of speaking is fixed. Second point is, in panel discussion, audience can ask a question after expert had stopped speaking. They can ask a question. But in symposium, audience can ask question only at the end. So which one is better? Panel discussion is better because there is no fixed order of speaking and audience can ask question in between. So this is better. Then in FGD, in the FMGE exam, they have already asked 3 questions from this point. First 2 questions actually. First point was, how many people participate in FGD? FGD is focus group discussion. 6 to 12 people sit in a circle and discuss about the cultural barrier and other thing. Like in my MD from AIIMS New Delhi, they had given me the topic of organ donation. So I did my FGD in my thesis, why rural people do not like to donate organ or why they want to donate organ. And the real answer which came out is that rural people think that if you donate eye in this life after death or before death also, then next life will be, you will be blind or without eye. If you donated kidney in this life, in next life you will be without kidney. So because of this superstition, they say ki mitti kyun kharab karni hai. They say ki why to cut the body after death. Hai na? They call the dead body as soil, mitti. So why to disrupt the mitti? So this type of cultural barrier comes, or superstition, we can know through FGD. And in the second question which came in FGD was, is it an active discussion, passive discussion, or moderated discussion? So it's a moderated discussion. Person like me who is a moderator who sit, and the work of moderator is to let everyone speak. If only 2 people are speaking like here, rest are listening, it's not a good FGD. In a good FGD, everyone should speak. And they are sitting in a circle and everyone should speak. So remember FGD 2.6 to 12 member and moderated discussion. Then role play, you must have done it in your life also. I hope you know what is role play, but it's not that role play which you do doctor, no. Role play means in front of 20-25 audience, a team of students or doctors, they perform, and The role play is the best way to remove cultural barrier. Let's say people are not going for a snake bite to doctor, they are going to some local quack. You cannot go and tell it to them directly, otherwise they might get offended that we are doing something wrong. You cannot tell people directly. So do it in a skit way form and tell them that if you go to quack you can die and go to doctor you can be saved, like that. So it is removing the cultural barrier and it prevent people from doing mistakes. It promote good behavior. Mainly it's a skit or drama in front of 20-25 audience usually. Most common area of question is demonstration. The question they ask is, what is the best way to teach people how to make ORS? That is demonstration. What is the best method to teach people how to wear condom? That is demonstration. How to interpret and use pulse oximeter? Demonstration. Demonstration means directly doing in front of them and then asking some of them to come and do it. So it's you demonstrate how to do it. That's the very common area of question. Workshop is usually used for training of ASA worker, Anganwadi worker, health workers. In workshop, usually there is session for divided over 2-3 days. In the morning, we give them the boring theory lectures. In after lunch, when they are sleepy, we ask them to do the practical. So theory and then practical, theory and then practical for 2-3 days will train them. So workshop is that. And that's the thing from health communication. Now we should also know the topic from health genetics. So in the genetics, there is one concept of Hardy-Weinberg law, which is not being asked for recent some time, but an expected question. The only part they ask from here is how to disturb the equilibrium. Let me explain this topic. Very simple. Hardy-Weinberg law say that gene pool remain constant. If any population, in any population, gene pool remain constant. If you add dominant plus recessive gene, total will come 1. But there are 5 factors which can disturb gene pool. First factor is mutation. Of course, mutation occur, new gene will be created. Second factor which disturb gene pool is natural selection. Third is when there is migration, like Indian gene pool change when Aryans migrated to India, then our gene pool get affected. So mutation, natural selection, then migration. 3 is simple. One is government intervention. Like Hitler said that all those who are disabled and all, they are not allowed to produce children. So this changed the gene of the future generation, although in a negative way, but it changed the gene in the future generation. So that is government intervention can also change the gene pool. And last is selective breeding is the problem. Selective breeding means in India, mostly marriage occur randomly or selectively. India marriages are occurring selectively between caste, which is a very bad thing, I personally think. Because if we will all marry in the caste, then gradually our gene pool will decrease. And this has been found on a survey done on Indian gene pool that after 1300, when caste system divided India and we started marrying in the caste, our gene pool is decreasing. So do remember, selective mating, this is the question they ask. Selective mating is not good for population. It is disturbing the gene pool. Random mating do not disturb gene pool. Random mating do not disturb equilibrium. Random mating is what you should do. Random mating is what keep the equilibrium alive. So the question they ask from here is, which of the following factor do not disturb gene pool? Remember, random mating do not disturb gene pool. Which of the following factor disturb gene pool? So there are 5 factors which disturb gene pool: mutation, migration, mutation, migration, natural selection, government intervention, and selective breeding. These all disturb gene pool. Okay. The next part which we usually miss is eugenics and eutherics. Eugenics means you are doing something before birth to improve the genetics of the future. And eugenics can be positive eugenics or negative eugenics. Positive eugenics example is artificial insemination. If a mother want to have, let's say, child like Virat Kohli and all, she can go for artificial insemination before birth, of course, to improve the gene of the future. So that is positive way. Negative way is what I just told about Hitler, that he did not allow disabled and many short stature person to have children. When Hitler himself was also short stature, he did not allow them to have children. And this affected the gene pool of the future generation of Germany. So do remember, negative and positive can be in eugenics. Eugenics is improving gene by doing something before birth. But what is euthenics? Euthenics means a child is already born, let's say, with autism or Down syndrome. So here we are not doing anything before birth. We are doing thing after birth in euthenics. We are giving them such supportive environment which can make them perform really well. And this was the question in FMG exam 3 years back, that if you are giving training to Down syndrome children, it is example of which thing? It is example of euthenics. You must have watched that very good movie by Amir Khan, Sitare Zameen Par, not Tare, Sitare Zameen Par, where he was giving training to many autistic children for playing basketball, and it was helping those children in their overall growth. So do remember this point, euthenics, giving training to children so that whatever gene they are born with should be expressed completely. So euthenics is to supportive environment for better expression of gene. And eugenics, I am sure you are clear, improving gene before birth by positive way or negative way. Positive is artificial insemination, negative is of course the Hitler way. Now the last question here is prospective screening, retrospective screening. Prospective screening is done before birth. Let's say there is a consanguous marriage between relative brother and sisters, but not directly, but cousin brother. So if there is marriage which is consanguous or in a community which is very close, they can both be carrying the recessive gene, and the child can develop the full disease because of combining those two recessive genes from parents. So in these cases, we do the counseling before birth of the couple, that is prospective screening, doing counseling before birth. Retrospective genetic counseling means the child has already been born. After being born, one child is born with defect before second delivery. Now the parent want to check their gene, that is there any problem in our gene, should we produce second children or not. So prospective genetic screening is before marriage, sometime before first children. And retrospective genetic screening is, retrospective means when one child is already deformed and then we are doing the counseling, that is retrospective. Okay, so this were the part from health education and health genetics which we miss. Similarly, if any topic you are missing, you can always let me know. Let me go to the chat and see what you friends are saying. Where is the chat? Yes, the chat is saying good morning dear. Very good. So good morning, Gandhi ji. Yeah, that propaganda and all those things we are saying. Chalo. So thank you so much. Is there any question, any topic which you want to listen, learn? You can always tell. Some students are asking me to talk in English. Bro, this is just a 4-hour session. If I will use Hindi, English both, I will not be able to finish most of the course. Plus, the main problem is whenever I speak something in Hindi, people who don't understand Hindi, and there's no problem with them because I can also be taken birth in Tamil Nadu and then I can also have difficulty in understanding Hindi. So those who don't understand Hindi, they feel that they are missing some point. But I will use some Hindi in the difficult concepts, and whatever I will speak in Hindi, I will also teach in English. Plus, I have to take care of all the students because you all are equal to me. So that's why. But I will speak some important concepts in Hindi also, don't worry, especially if it is confusing. So now let's discuss the very important point for MCI exam, health system of India. In health system of India, first controversy which they ask, which you are confused and which they ask also, is the controversy in the ASA. So if you go through the 28th edition of Park textbook, which is the recent edition, in 3 places in Park, they have recent edition. They have written this line again and again in 3 places. What they have written? That ASA is at 1000 population. there was a recommendation that we need 2 ASA per 1000. In 2011, high level expert group committee gave that recommendation, but government said ki let us first give 1 ASA per 1000 now. This is also a dream, we have not yet achieved it, and they did not give fund for that, so it's 1 ASA per 1000. And recently some more states have started monthly salary for ASA. Previously it was per work salary, now they are moving towards monthly salary. Second confusion is, what is the minimum education of ASA? If you go to Google, Google will tell 10th pass, and even some teacher tell 10th pass because they are telling it from the update which is on Google. And why Google say 10th pass? Because if in Kerala government is releasing the job vacancy, they want 10th pass, but we don't have to answer based on Google or Kerala government recommendation. We have to answer based on PARC, and PARC has written on 3 places that minimum education is 8th pass. Why not 10th pass? Because in rural and tribal areas, it's difficult to find even 8th pass female many a time. So if we keep the criteria very high, we will not get the representation from the oppressed areas. So we want to keep it low so that we can have ASA from all the areas. So remember, minimum education is 8th pass, 1 ASA is at 1000 population. Then the next is, we have to understand how the rural and urban health system work. And mainly in many question exams, they're asking questions from urban health mission. But first, let's discuss our rural health mission. In rural health mission, 1 ASA is 1000. ASA report to auxiliary nurse midwife or MPW. Then ASA report to sub center, which is at 3000 to 5000 population, 3000 in hilly area, 5000 in plain area. Sub center report to PHC. PHC is at 20,000 population in hilly area, 30,000 population in plain area. So 35, 20, 30. But now the question which they will ask in your recent exam is from the topic of Arogya Mandir. Because what the BJP government did was, there was this sub-center and PHC. They merged most of the sub-center and PHC into health and wellness center. So when they use the word health and wellness center, it was good word, but it was not helping in propaganda. So they use the word mandir, which is very derogatory. We cannot use the word mandir or masjid for government health institution, because doctors should be secular and health should be secular. But they use the wrong word mandir, for which help in their propaganda, getting vote and all. So now sub-center and PSC are known as Arogya Mandir, which is same thing as health and wellness center. And this Arogya Mandir, you have to know what are the facilities they give there and what are the staff which are here. With that you should know. Okay, so first thing is about the facilities in the Arogya Mandir. What is Arogya Mandir? Sub-center and PHC. And a sub-center at 3000, 5000, PHC at 20,000, 30,000. One more thing you should know is the delivery part. PHC can be type A, type B. If the PHC is type A PHC will have 19 or less delivery. 19 या 19 से कम होगा तो टाइप बी है. जैसे ही डिलीवरी 20 पहुंच जाएगा, as soon as the delivery will reach 20, it is type B. So type B is 20 or more delivery per month, and type A is 19 or less delivery. Okay, so do remember 19 or less type A, 20 or more type B. Similarly, when it comes to sub-center, if there is delivery happening, then it's type B. So always remember, type B is better version. On type A, there is no delivery. On type B, sub-center, there is delivery. Only type B can have the delivery. Okay, type B can have the delivery. So do remember this point. But now sub-center PHC questions are less likely to come. They will ask question from Arogya Mandir most likely, because they have changed the name of sub-center PHC to Arogya Mandir. And what are the facilities? There are total 8 facilities, very easy to remember. Dental, mental, okay. After that, Whenever we read ENT, we read ophthal together. So ENT, ophthal. Then they say we will give the facility of palliative care, post-cancer pain relief care. Wow. Palliative care. This facility is not in some of the medical college also, but they say we will give it to sub-center. And then after palliative care, emergency services like trauma management and all, trauma and emergency. And there will be geriatric health, diabetes, hypertension, OPDs, and their medicine will be given, geriatric health. And last thing that they will give is yoga and meditation, क्योंकि yoga से सब होगा, है ना? Yoga is the main focus. That is the way by which they are going to give good mental and ENT health. Okay. So do focus on this 8 point. Dental, mental, ENT, ophthal is together. Palliative trauma. And then geriatric and yoga. Okay. Usually old age people do more yogas. So geriatric and yoga together. And palliative is post-cancer pain relief and trauma care. So total 8 facility. What are the staff? In the staff, there is a new staff which you definitely have to remember. That is CHO. CHO. What is CHO? CHO is Community Health Officer. This is a new post created. This post get 1.5 year of training or course. It can be an A&M, it can be a nurse, it can be any science graduate who get 1.5 year course training, and then they can work as community health officer. And what is the main work of community health officer? The main work of CHO is health promotion. It is motivating villager for yoga. Okay. So basically this post is created to collect the votes from rural area. And by teaching them yoga also, there is health promotion. Other than health promotion, in the CHO, the second work is teleconsultation, referral of patient, and data entry. But this teleconsultation, referral is something which other people can also do. And when it comes to the data entry work of CHO, this data entry is usually done by A&M. And when A&M does the data entry, it does it in the software, Anmol software. We will see the image also in the today's session. This Anmol software has a green color mother, green color child, green mother and child. And what does this Anmol software is? It is a tablet based software for data entry. Okay. For A&M data entry. That's why it is A&M Online Anmol. And when this software was released, most of the A&M and MPW all over India, they said कि हुजूर, माई बाप दीनानाथ, कितने दयालु मयालु है आप कि आपने सॉफ्टवेयर दे दिया लेकिन इसको डाले कहाँ? हार्डवेयर वा तो देबे नहीं किए, है ना? Government provided the hardware, software, but the tablet, have you seen tablet anywhere with A&M and all? Very rare. So the tablet has yet not provided. It will come soon, maybe. But software is there. We call it Anmol. So mainly data entry is also by A&M, not by CHO. But government say CHO does 4 work: health promotion, referral, teleconsultation, and data entry. So other than CHO, what are the other staff at Arogya Mandir? Arogya Mandir, one is CHO, most important. Second is the A&M. A&M is same as health worker female. Auxiliary nurse midwife is same as health worker female. And then there is MPW, multi-purpose worker, which is same as health worker male. And then the 4th staff, surprisingly, Park has written ASA also as a staff of Arogya Mandir. But actually ASA roam around in the village, she do not sit there, but still it is written as a staff of Arogya Mandir. And then in the Arogya Mandir, government say that we will also post either an Ayush doctor or an MBBS doctor. That's the planning of government. Ayush or MBBS doctor should be posted at Arogya Mandir. Arogya Mandir. Okay. Which is same as Health and Wellness Center, which is same as Sub-Center and PSC. So I hope you remember this part. Sub-Center 3,000, 5,000, PSC 20,000, 30,000. And then there is CHC, which is at 1 lakh. 1 lakh plus minus 20,000. If you subtract 20,000, it's 80,000 to 1 lakh for hilly area, because in hilly area people live far apart. So less population, 80,000, 1 lakh for hilly area. and 1 lakh to 1.2 lakh for plain area because there people live close to each other. Then CHC report to medical college. Okay, and usually questions are not coming from rural health mission but from urban health mission. So in the urban health mission, the ground level basic unit is mass. What is mass? Not that mass tufan utha de, it's Mahila Arogya Samiti, female healthy female committee. So what mass is do is, it is a group of urban female from the slum area who hold regular meeting once in a week or once in 14 day, and then report to Usha. Who is Usha? Not sister of ASA, but urban form of ASA, urban social health activist is Usha. And they have asked already in MCI exam, what is the population norm for Usha? So remember, as I said, one ASA is at 1000 and one Usha is at 1000 to 2500 population. So roughly Usha is at 2000, but Park has clearly written 1000 to 2500. Okay. Second point, that they have asked about Usha and ASA. So they can ask about mass also. At how much population there is a mass? Mass is 50 to 100 house. And government of India think that on an average, in one house, 5 people live. Of course, some house can have 8 people, some house can have 2-3 people. But if you take average, it is 5 people. So 50 to 100 house multiply with 5, it will come 250 to 500. So what is the population norm for mass? Mass is 250 to 500. USA is 1000 to 2500. Okay. Now, where do USA report? USA, which is at 1000 to 2500, report to urban A&M. Urban A&M is, one urban A&M is at 10,000 population. Then where does urban A&M report? They report to urban PHC. This question was also in MCI exam 2 years back. So one urban PHC is at 50,000 population. Very important. Where do urban PHC report? Urban CHC. And urban CHC is at 2.5 lakh to 5 lakh population. And one question in NEET exam was, can we open urban CHC near medical college or district hospital? Answer is yes. Urban CHC, if you do not find good proper land for urban CHC, it can be open near district hospital or medical college. Okay, district hospital or medical college, it can be open. Sometime in the same campus we have urban CHC and medical college both. Less serious patient go to urban CHC, more serious patient go to medical college, like that. Okay, so do remember, one more question from this part is, which of the following is not present in urban area? Is subcenter not present, PHC not present, CHC not present? Which is not present in urban area? Urban area don't have subcenter. There is urban A&M. No subcenter is there. Okay, no subcenter. And that is why in Tamil Nadu there was Amma clinic, and in Delhi there was Mohalla clinic opened, because in slum areas subcenters is not there. So to fulfill that need, they had the Mohalla clinic and the Amma clinic in Tamil Nadu. Okay, so this is sub-center which is missing in urban health mission. And do remember the population norm: 1000 to 1500, then there is 10,000, 50,000, 2.5 to 5 lakh, and we can open CHC near district hospital, medical college. Chalo. So this is the urban health mission. We already discussed it. One mass is 250 to 500 population, very expected question. USA is 1000 to 2500. Urban A&M is 10,000 population. Urban PHC is at 50,000. Urban CHC is for 2.5 lakh, but in metro city it is at 5 lakh. And then they also report to medical college. So this is our national urban health mission. So there is a confusing question from the calculation part which come, that you are a medical officer and you visit a sub center. You got the report that A&M is not working. So how many pregnancies should be present in the A&M register when you did the dhappa, है ना, when you suddenly visited the sub center, how many pregnancies should be in the register which will ensure that ANM is working, and not that dhappa goat one, है ना, it's different. So what's how many pregnancies should be there? So this type of question is very confusing because it has 3 steps of calculation, and sometimes you have to stop at first step, sometimes you have to go to second, sometimes you have to do all the 3 steps. First step is they have not written the birth rate or the population, but they have written the word sub-center. And if sub-center is in plain area, it is at 5,000 population. Why I not take 3,000? Because 85% population of India live in plain. So we take average 5,000. Second thing, birth rate is not given. So if not given, you can take birth rate of India as 20 per 1,000. For every 1,000 people, 20 new children take birth. So what is the first step? First step is calculating live birth in a year. Sometimes they just ask what is the live birth in a year. एक साल में कितने बच्चे पैदा हो रहे हैं? अब देखो, 1,000 पे 20 बच्चे पैदा हो रहे हैं, तो 5,000 पे कितने पैदा होंगे? 20 बच्चे, 20 children are taking birth at 1,000. So how many will take birth at 5,000? It's simple, it's 100. Okay, so live birth in a year is 100. You just have to multiply the birth rate with 5, you will get the live birth. First step. Second step is you have to know how much is the total pregnancy in a year. एक बात बताओ, क्या सभी जो प्रेगनेंसी होती हैं वो लाइव जिंदा बच्चे पैदा करने तक बच पाती हैं? नहीं, कुछ प्रेगनेंसी में एबॉर्शन हो जाता है, कुछ प्रेगनेंसी में स्टिल बर्थ हो जाता है। तो वो जो स्टिल बर्थ और एबॉर्शन है वो 10% ऑफ लाइव बर्थ होता है। इसी को कहते हैं प्रेगनेंसी वेस्टेज फैक्टर, जो यूएस असेंबली में एक बार पूछा भी जा चुका है कि प्रेगनेंसी वेस्टेज फैक्टर क्या होता है। 2 साल पहले पूछा गया था। प्रेगनेंसी वेस्टेज फैक्टर वो है जो 10% प्रेगनेंसी बर्बाद हो गई, उन्हीं को हम कहते हैं प्रेगनेंसी वेस्टेज फैक्टर। तो अगर आपसे कोई पूछे कि एक साल में कितनी प्रेगनेंसी होगी, तो आपको सिर्फ क्या करना है कि एक साल में जो बच्चे पैदा हुए उसमें 10% जोड़ देना है। What I was saying in Hindi was that if they ask the total pregnancy in a year, you just have to write the live birth in a year and add 10% of live birth, because some pregnancy will get wasted as abortion or stillbirth also. So you have to add that pregnancy wastage factor of 10%. Here live birth was 100, and what is 10% of 100? 10% of 100 was 10. So its total is 110. So how much pregnancy in a year? 110. The third step is calculate what is the pregnancy at any time. देखो समझो, क्या प्रेगनेंसी पूरे साल भर रजिस्टर में रहेगी? साल भर तो मां के पेट में नहीं रहती है, तो रजिस्टर में क्या घंटा रहेगी? रजिस्टर में प्रेगनेंसी सिर्फ 6 महीने तक के लिए रहती है, क्योंकि पहले 3 महीने तो रिपोर्टिंग होती है। फर्स्ट एएनसी विजिट इज एट 12 वीक, तो 12 वीक यानी 3 महीने गुजर गए, चौथा, पांचवा, छठा, सातवां, आठवां, नौवां, टोटल 6 महीने रजिस्टर में रहती है प्रेगनेंसी। अब साल भर में कितने महीने हैं? 12, और रजिस्टर में कितने महीने रहेगी? 6। तो जब हम 12 को 2 से डिवाइड करेंगे तो 6 आएगा ना, यानी जो भी साल भर की प्रेगनेंसी है उसको जब आधा कर दोगे तो मिलेगा कि रजिस्टर में किसी भी समय जब आप धप्पा बोलो तो कितनी मिनिमम प्रेगनेंसी रहनी चाहिए। तो वो क्या निकल के आएगी, सोचो आप खुद ही, क्या आंसर आएगा? व्हाट इज द प्रेगनेंसी एट एनी टाइम in ANM register? So when they ask pregnancy at any time in ANM register, you have to do yearly pregnancy by 2. And that's what I was explaining in Hindi, why we are doing yearly pregnancy by 2. The reason is that pregnancy never remain for whole 1 year in the register. The first ANC visit is at 12 week, and then delivery occur at 9 month. So first 3 month is gone in 12 week, then 4, 5, 6, 7, 8, 9. Total for 6 months only pregnancy remain in the register. And in a year there are 12 months. So half of 12 is 6. That's why we are doing yearly pregnancy by 2 to get pregnancy at any time in ANM register. And in our case, yearly pregnancy was 110. So 110 by 2 is 55. So how much pregnancy minimum should be there in A&M register at any time when you suddenly wasted it like dhappa and all? So that will be 55. Minimum pregnancy at any time should be 55. But if they ask pregnancy in a year, answer will be 110. If they ask live birth in a year, answer will be 100. Like that, you have to look at the question carefully before answering. So let's answer this question. This was the real MCI question which came 4 years back, that if birth rate is 25 per thousand at a sub center, what will be the number of pregnancy registered in a year? In a year, how many pregnancy? So first step was live birth in a year. How to find live birth in a year? Simple. You just have to do birth rate multiply by 5. What was the birth rate? 25. 25 into 5, 125. So live birth in a year is 125. X, है ना? Second step is calculating pregnancy in a year. In a year they are asking. So when they ask pregnancy in a year is equal to live birth plus 10% of live birth. So our live birth is 125. And if you add 10% of 125, 12.5, it will become 137.5. Now, can you have 0.5 children delivered? No, 0.5 child cannot come out. So we can roughly say it 138. So pregnancy in a year is 138. But many of the students who are 69 lovers, they raise their hand and they say that no, sir, answer is 69. Why they answer 69? Because they have gone one step ahead. They calculated pregnancy at any time. Pregnancy at any time is 69. Why? Because pregnancy at any time in A&M register, this we calculate by dividing yearly pregnancy with 2. Yearly pregnancy with 2. Yearly pregnancy is 138. 138 by 2 is 69. But here the answer is not 69. Here answer is 138 because they are not asking pregnancy at any time. They are asking pregnancy in a year. Okay, I hope it is clear. Chalo, the next question is, this was NEET question, surprisingly NEET 2024 question, है ना? Which is not done in newborn care. Of course, we do not give bath with warm water to newborn. सोचो कोई बच्चा अभी पैदा हुआ है, उसको ठंडा पानी से नहा दो, कितनी गंदी गालियां देगा, बचपन से ही MCBC कर लेगा, है ना? So this is not done up till 1 week. We do not make child to have bath in warm water, usually up to 1 week. Rest of course we do. Now, one question which I want to tell is, this is there in the next part, I think, which is not a target of NSSK. This is a MCI question 3 years back. They have asked, what is NSSK? This program is known as Navjat. Navjat का मतलब होता है neonate. Newborn, neonate means less than 28 days is usually neonate. So Navjat, S for Sishu. Sishu means child who keep on doing susu, that is Sishu. And second S is for Suraksha. Suraksha means safety. And last is Karyakram, which you keep making. Karyakram means program. Okay, so what is this neonate child safety program? Navjat Sishu Suraksha Karyakram. This is Navjat Sishu Suraksha Karyakram has mainly focusing on training of doctor and nurses so that we can prevent neonatal death. But NSSK has 4 things as priority, and this 4 thing we can remember if you listen it as a story. देखो बच्चा पैदा हुआ, पैदा होते ही हम क्या करते हैं, पहले तो क्लीन कॉर्ड कट करते हैं, क्लीन कट देते हैं, क्लीन सरफेस होता है, क्लीन हैंड होता है, सरफेस हैंड क्लीन कट, देन हम लोग कॉर्ड को क्लीन रखते हैं, स्टंप को क्लीन रखते हैं, और हम लोग उस पर टाई कुछ नहीं करते हैं, और वो कोई टाइंग नहीं यूज करते हैं, क्लीन क्लैंप लगाते हैं. तो क्लीन कैंप, क्लीन कॉर्ड, क्लीन कट, क्लीन हैंड, क्लीन सरफेस से we prevent infection. पहला काम. After preventing infection, we rub the child and make him warm. So we prevent hypothermia. If we are able to prevent infection and hypothermia both, then we give the child for breastfeeding. If not, we do neonatal resuscitation. So you can remember it like a story. First prevent infection and hypothermia. If both are done, do breastfeeding. If not done, do neonatal resuscitation. So this is the 4 point of NSSK. First point is prevention of hypothermia. Second point is prevention of infection. Third point is exclusive breastfeeding. Last is neonatal resuscitation. These are the 4 points of NSSK. Do remember this 4 point. Which is not done, not a target of NSSK. Pre-investigation of newborn is not a target of NSSK. And this question has also asked, in which program we have pre-investigation for newborn. Pre-investigation of newborn is in JSSK, Janani Shishu Suraksha Karyakram. This image-based question has came in NEET 2024 exam, where there was a yellow mother and yellow child. This yellow mother and yellow child is JSSK, Janani Shishu Suraksha Karyakram. Janani means mother, Sisu who keep on doing susu. So because of the susu urination, the logo is also yellow. You can remember like that. If there is Janani Shishu Suraksha, the logo will be yellow due to yellow urination of child. And in JSSK, there is free, 3 things are free. Free investigation, treatment, drugs, C-section, blood, they all are free. Second is free food. Free food is of course 2 mother and 1 attendant for 3 days if it is normal delivery and 7 days if it is cesarean section delivery. And third thing which is free ambulance. So free food, free ambulance and free investigation and treatment are the 3 components of JSSK. So now, which is not a target of BFHI. What is BFHI? Baby Friendly Hospital Initiative. So this is a WHO program, and WHO do not focus on prevention of infection. Prevention of infection is not a target because WHO is taking the guidelines from US UK, and US UK hospital in neonatal ward infection is not a major problem. So they have removed that prevention of infection part. Plus they think that if the child is breastfeeding well, the breastfeeding will give the immunity and prevent the child from all kind of disease. Okay, so that's why they have removed infection. Early discharge, prevention of hypothermia, breastfeeding on demand, these all are target of BFHI. Early discharge means mother is going away from hospital quickly, and this can happen only if the child is breastfeeding well and only if there is no postpartum hemorrhage in excess. So early discharge is considered as a good news in developed country, because if early discharge is there, it means there is no complication. Which is not present in urban area, as I said, sub-center is not present in urban area. Then which is not correct for urban CHC? Urban CHC not present near district hospital is not correct. Urban CHC can be present near district hospital. So not present is not correct. It's a double negative thing. This was a NEET PYQ. So we have done the question from health system. Now let's discuss some important health program. First is Suman. Suman. Suman stands for Surakshit Matritva Aswasan, Safe Motherhood Assurance. It started in 2019. And we will discuss it. There is one more program which is similar to Suman, that is PM SMA. PM, you know, not particulate matter, Prime Minister, of course. SMA is the another program. This PM SMA started in 2016. And if you look at the full form of PM SMA, they can ask the full form. S stand for Surakshit, safety, safe. M stand for Matritva. A do not stand for Aswasan. A is for Abhiyaan. So this is the only difference in the full form. In PM SMA, it is Prime Minister Surakshit Matritva Abhiyaan. This is PM SMA. And in Suman, it is Safe Motherhood Assurance. So what is Abhiyaan means? Abhiyaan means mission. Okay, so how to remember these two full form? It's very simple. As soon as the BJP government came in power in 2014, of course, the first program which Prime Minister launched for mother was a mission, PM SMA. They started with mission. In next 3 years, nothing happened. So they turned Abhiyaan or mission into assurance. All is well, all is well. Started with Abhiyaan, ended with Aswasan. Started with assurance, mission, ended with assurance. Okay. So this comedy mnemonic can help you remember it. Plus it's the reality also. because you will learn why PMSMA was not able to bring any change. I will just discuss it, why it was a mostly useless program. We will discuss it. So remember, PMSMA and Suman have the same full form, only last A is Abhiyaan in PMSMA and Assurance in Ashwasan in Suman. So Suman is an umbrella program under which 5 things come. First is, let's discuss PMSMA first. Then we have JSSY, Dakshata, JSY, Laksh. Okay, one by one we will discuss this program. Let's discuss this. First of all, let's discuss this PMSMA. As I was saying, Pradhan Mantri Surakshit Matritva Abhiyaan, Safe Motherhood Mission was PMSMA. In this program, government said that on the 9th day of every month, there will be free ANC checkup, investigations and medicine in the government hospital. तो भाइयों और बहनों, किस दिन ले जाओगे माओ को सरकारी अस्पताल? On which day you will take the mother to government hospital? On 9th. Suppose I am the mother, as you can see, and you missed taking me on 9th. Then what you can do? Then you can take me on 10th or 11th or 12th, because we just read that in JSSY, these all facilities free for any day of month. आप महीने में किसी भी दिन जाओ, सरकारी अस्पतालों में जांच और चेकअप और सारी चीजें मां के लिए हर दिन मुफ्त है. तो सरकार ने 9 तारीख को क्या दिया? बाबा जी का ठुल्लू, ऐसा चीज दिया जो ऑलरेडी महीने भर फ्री मिल रहा था. गवर्नमेंट गिव समथिंग फ्री ऑन 9th, which is free under JSSY on every day of the month. So actually government gave nothing, but they launched this program saying that we are doing something great. So do remember, on the 9th day, we have to take the mother under PMSMA, and PMSMA do not have money for ambulance or food. Only the third component of JSSY is covered. All the thing in the hospital, inside the hospital will be free, like investigation, checkups, treatment and all. Second thing which PMSMA said is, on 9th, which day? 9th, private ops gynae doctor can go to government hospital and can do some ANC checkup voluntary services. And this is actually happening. One of my government gynae friend Divya said me ki we do go on 9th in government hospital with lots of our visiting card. And the poor patient who come to government hospital, we give them our visiting card and ask them to come to our private OPD. So what if government is not helping poor patient? At least it is helping private doctors. So do remember, this is private ops gynae people who are going on 9th for their advertisement and for doing free ANC checkup. Actually, there is one more thing in PMSMA, that is this red, blue, yellow, green. They have divided pregnancy into 4 categories. Red is for high risk. Blue is for all the pregnancy with hypertension issues like preeclampsia, eclampsia and all. Yellow is pregnancy with any comorbidity like hypothyroidism, let's say sickle cell anemia, SLE, all any other comorbidity is yellow. Diabetes is also yellow, but hypertension is blue, and green is for normal. So the 3 work in PMSMA is 9th visit, private ops gynae will go there, and classification of pregnancy. This is PMSMA. But the main question which nowadays they ask is from the first program, that is JSY, Janani Suraksha Yojana. Janani means mother, Suraksha means safety, Yojana means program. And earlier in JSY, only one work was done. That is, earlier only money was given after delivery in the hospital to mother and also to ASA or USHA. Okay, money is given after institutional delivery to the mother and ASA or USHA. Incentive is given to ASA USHA also for promotion of institutional delivery. So it is given to, money is given to both, ASA also, mother also. And how much money is given? That's the first thing we should know. The money which given depend on whether the mother is coming from low performing states or high performing states. So first thing, this question has came in NEET exam. The question in NEET exam was from urban MP. Mother came and delivered. How much money to ASA USA? how much money to mother? So this was the question came, and do remember, first thing is, whenever they talk about Usha, urban area, Usha always get 400 rupees. It doesn't matter low or high performing. ASA always gets 600 rupees. So one thing is sure, because she is from urban area, Usha will definitely get 400 rupees. That's 100%. Only thing now you have to remember is about mother. ASA USA is fixed, 400 urban area, because urban area traveling and all is easy, and rural area 600 rupees. Now to remember the mother, we have to know the list of low performing states. Low performing states are those states in which infant and maternal death are very high. And of course, which state has highest maternal and infant death? My state, United States of Bihar. And in ragging, when they used to ask it, where are you from? I used to say, United States of Bihar, very similar to USA, at least in terms of the gun use and all. So in the low performing states, first name is of course United States of Bihar. Then there is two neighbor of that, UP and MP, and their forgotten brother. Brother of Bihar, of course, Jharkhand. Brother of MP, UP, Uttarakhand. We have a UK also in India. And brother of MP is Chhattisgarh, my favorite state actually. Chhattisgarh. So 6 state is simple to remember. Remaining 4 can be remembered by the mnemonic Roja. Roja jane man, tu hi mera dil. What is our? Rajasthan. O is for Odisha. J is for Jammu and Kashmir. And A is for Assam. Rajasthan has done a lot of good thing in terms of health, and there is they are opening now 1 medical college each district, and the insurance money is 5 lakh in the rest of the India, but there it was 20 lakh one time. So and Rajasthan is the one who started free medicine for all along with Tamil Nadu a long time back, but still there is a long way to go. So Rajasthan also come in this state. Remember 6 and then Roja. So on all these 10 states, because they are low performing should get more money. So because they are low performing, mother will get 1400, and half of that 700 will be to the mother in high performing states. In the urban area, mother get 1000, and in the high performing states, they should get half of 1000, that is 500. But remember, mother never get less than ASA, so it is 600 here. So you just have to remember these 4 numbers: 1400, 700, 1000, 600, and you can remember the whole table. Now let's come to our NEET PYQ. The question was that if mother is from urban MP, how much money is to Usha? Usha money was 400, remember, urban area. But in which part Madhya Pradesh belong? Low performing or high performing? Of course, MP is in low performing. So how much money to mother? In urban area, 1000. So answer is mother will get 1000 and Usha will get 400. If they ask about rural part of Bihar, mother 1400, ASA 600. Rural part of Bihar, 1400. Urban part of Bihar, 1400. Rural part, 1400, 600. So like that, you have to focus on rural, urban, low performing, high performing, and you can answer. And always remember ASA 400, USA 600. Why this 400, 600 different? Because when ASA gets 600, 300 is for accompanying the mother and 300 is for ANC visit. So in rural area, for accompanying, they have to travel far, so more money. ANC visit also there far, so more money. In high performing states, the money we give is only up till 2 delivery. But in low performing, we give money for all the deliveries. Okay. So when USA gets 400, it is also divided into 200, 200. 200 for ANC and 200 for traveling. So this is the distribution of money in JSY. But as I said, in JSY, it's not just the money. There are actually, JSY has 6 work. The first work we already know is the money. Money given for delivery in hospital to mother and ASA. But there are 5 other work which can be remembered as a story. Okay. So in that story, एक अंधेरी रात थी है ना, there was a dark night and it was raining heavily and I was holding one lamp in my hand, and my dear friend Salu came there. Salu, or let's take Yes. Dr. Yes came there and he made me pregnant, and he turned off the light and did something. So I'm a pregnant mother. The first thing which I need is definitely the nutritional support for having healthy pregnancy. So in a JSY, they celebrate Village Nutrition Day. Village Nutrition Day question has came already in MCI exam, is celebrated how? It is celebrated once a month. Once in a month they have VND, Village Nutrition Day. Mamta Divas they call in Hindi, on which Anganwadi and other people, they prepare food and they teach the mother how to prepare high protein food, and um, they eat it together also. So this is first thing which as a mother I need. After nutrition, of course, I need iron folic acid tablet also for healthy pregnancy. But the rural area hospital was not having iron folic acid tablet at that time or calcium tablet at that time. So I can also go to private hospital. This is the second part of JSSY. We call it Vande Mataram program. What is Vande Mataram? Very simple thing. Private doctor can keep all the thing which ASA distribute, like private doctor can have the IFA, calcium tablet, condom, OCP, malaria detection and treatment kit, and drugs for common diseases like paracetamol, cough cold syrup and all. So these are the things which ASA distribute. Those things private doctor can also keep. They just have to keep a logo of Vande Mataram over their OPD, and they can keep and distribute this thing. So first I need nutrition, Village Nutrition Day once a month. Then I need IFA tablet and calcium. Vande Mataram scheme provided it through private doctors. Then I came to know that my boyfriend who came on that night, it was very dark, so I don't remember him very well. He is now cheating with me by doing this gulu gulu with other girl also. So now I went for abortion, and this provide safe abortion services also. Okay. Other than safe, I went for safe abortion, but suppose I died in that abortion. So after safe abortion services, if any death occurred, or let's say death occurred in naturally also, then that is one thing we do. We do verbal autopsy. Usually we do autopsy with knife and all, but here we ask question and we came to know cause of death of mother or child. Because if we know the cause of death of mother or child, then we can take some corrective action. Okay. So this is the Village Nutrition Day, Vande Mataram program. Then we went for safe abortion services. We also went for verbal autopsy. Okay. And money is also given under it. One more thing is there which I am missing. What is that one thing which I am missing? Do you remember what is that one thing which I am missing? If you know, please tell me. Anirudh is saying, khatta khana hai kya aapko? Yes, Anirudh. Please give me, but don't give me kala khatta. Just give me khatta aam and all. I will have that. Okay. And Nitesh is saying, कैसा लग रहा है सर आपको? आप it's feeling good. बस कभी कभी जी मचलता है, उल्टी आती है, otherwise it's all good, है ना? तो वैभव कह रहा है बहुत बुरा हुआ. नहीं नहीं, that gulu gulu he did and all was very bad. Yeah, I agree. What is that one thing I am missing? Of course, it can be tracking of pregnancy, tracking of high risk pregnancy, which is done by Anmol software. That can be one point. But I'm missing the 1/6 point, which is also in JSY. So this was MCI question all through. VND has asked separately also, plus they asked which is not done in JSY. So these 5 are done. Maternal and child tracking is there, but MCTS they call maternal and child tracking system. But I'm not sure about that 6th point. I will remember it for sure in between, and I will come back here. So remember, JSY was earlier only for money, but now it do many other work. After JSY, there is this, of course, JSSY, in which we already discussed Janani Shishu Suraksha Yojana. We give 3 free things. What are the free things we already have discussed? Free ambulance, free medicines, and free food. After GSSY, this is PMSMA. We already discussed it, that on 9th day of every month, free ANC visit, plus private doctors can go there, and plus there is classification of pregnancy. Now let's discuss this last program, Laksh. Laksh focus on improvement. This is a very common area of question. In the Laksh logo, you will find a black color mother, black color child. So Laksh is focusing on the improvement of services. And where we are trying to improve the services? In labor room, maternity ward, and maternity OT. Okay. So this is the question which has been asked also, that Laksh focus is on only on labor room, maternity ward and maternity OT, so that delivery can be safe. That is Laksh. Then the next program is Dakshata. Dakshata is a Hindi word which means highly skilled. Laksh means aim. So our aim is to improve labor room and all. And Dakshata is highly skilled. Highly skilled means we are giving training. This under this program only one thing is done. Training is given to doctor and nurses so that we can make them highly skilled and decrease the delivery related complication and mother death should be decreased. So when we are giving training to decrease maternal death, we call it Dakshata. And if we are giving training to decrease neonatal death, we call it NSSK, Navjat Sishu Suraksha Karyakram. So here the training is to decrease delivery related mother death. Delivery related maternal death is our main focus. Of course, if we will give training for delivery related complication prevention, it will also prevent neonatal death. लेकिन मां को मरने से बचाओगे तो दक्षता है, उसके लिए ट्रेनिंग दोगे तो बच्चे को मरने से बचाने की ट्रेनिंग दोगे तो नवजात शिशु सुरक्षा कार्यक्रम है. Maternal death prevention by training is Dakshata. Neonatal death prevention is NSSK. Now let's answer this question. A poor female, suppose like me, who is pregnant and who don't have money to go to hospital for delivery, which program will help her? Will JSY or JSSY or PMSMA or Laksh, which will help her? Of course, I hope you know the answer. JSSY will help her, not JSY. Because in JSY, money is given after delivery. So it will not help this mother because she need ambulance also to the hospital and all. Now suppose I ask that poor female don't have money to go to the hospital on 9th. Then which program will help her? Still the answer will be JSSY. Because PMSMA do not give the money for ambulance and she don't have the money to go to hospital. But in exam, if they ask on 9th a mother want to go to hospital for free NC checkup, which program help? Better answer will be PMSMA. So PMSMA can be the answer if they say on 9th ANC treatment is needed or ANC checkup is needed. That is PMSMA. Okay, but here it was JSSY. Chalo, what is Vande Mataram? We already discussed. Private doctor can keep those things of Astha and they just have to keep a logo, then they can distribute it to needy females. Very good. You are trying to help me by adding that point of reduce stillbirth and all, but that is not JSSY, JSY target. JSY target, let me go back to the movie. ANC registrations can be there. Nutrition, I need the checkup. I will come to that point. Let's focus here. One more program is Pradhan Mantri Matru Vandana Yojana. Pradhan Mantri, you all know, Prime Minister. Matru means mother. Vandana means worship. So it's Prime Minister worship program. And if you, I will show you the logo of all mother-child program right now. In all those logo, in this logo, PM Matru Vandana Yojana, mother and child both are incomplete. Both are half-half. Why? Because this program is also half. Government said that we will give 2,000 rupees when mother will come for first registration at 12 weeks. Then they say we will give next 2,000 rupees at 6 months of pregnancy. And then they say we will give the last 2,000 rupees at 6-week vaccination after delivery. Previously, the amount was 5,000. Now they said, let's make it 6,000. So why I said that the logo has both mother and child incomplete? Because The program is also incomplete. Have you seen in any state money being given before delivery? Of course not. So it was launched, this program was launched and then never landed, because government said for worship we need emotion, not money. So the government gave full emotion but no money yet. I hope it will come soon. So do remember the 6,000 and the timing, 12 weeks, 6 months, and then 6 weeks after delivery. Let's see all the logos of this mother-child program together so that we don't confuse. A very common question these days is from the question of Anemia, Mukt, Bharat and all. We will come there also. But first, let's discuss mother and child program logo. Yes. So this is, where is all the mother and child together? Yes. So we can have some mother child here, some here and there. Yeah, here is all mother and child. Yes, we got it together. Yes, see it here. This is the logo of Pradhan Mantri Matru Vandana Yojana, half mother, half child. Because the program is launched, never came back. So this is P Matru Vandana Yojana, in which 6,000 is given. Previously it was 5,000, now it is 6,000. Okay. Next is this yellow program which came in NEET 2024 also, JSSY, Janani Sisu, who keep on doing Susu, so the color is yellow. JSSY, which was also helping poor female if they don't have money to go to hospital. Then the black one is the Laksh. They can just give this image also. Laksh is for improvement of facility in labor room and all, you know that. Then this white color is baby friendly hospital initiative. White color means foreigner. So this is WHO program to promote breastfeeding. Indian program to promote breastfeeding is known as Ma, mother absolute affection, which do not have any logo, but there's Ma. So BFHI is foreigner. Then yellow color mother, yellow color child is UNICEF. And do remember this point which can come in this exam, that UNICEF also give fund for seed and manure of applied nutrition program. See, actually this applied nutrition program thought that in Anganwadi and government school, if we give seeds and fertilizer, they can grow their fresh vegetable and children will get fresh vegetable in their food. Of course, this program never worked, because if vegetable and fruit will grow in the school, first of all, children will not let them grow. But if they grow also, who will eat it first? Of course, teacher. You can see this. So it never worked, but this was one target of UNICEF. Do remember, who gives seed and manure for applied nutrition program? UNICEF. UNICEF main focus is in mother and child, and its headquarters is in New York, and it focus on GOBI FFF, growth charting, ORS, breastfeeding, immunization, family planning, female education, and food supplementation. So because food supplementation is one priority, so it is funding seed and manure of applied nutrition program. This is blue color logo. Finally, we have one more logo, green color mother, green color child. This came in MC exam 2 years back. This is Anmol, tablet based software for A&M data entry. And this is different. This is mobile academy. Asa will get training on phone. She will listen to phone and she will get trained. Okay. So this is different thing, but let's revise all the 6 program. One more program has mother and child in it. This is ICDS program. What is ICDS stand for? Integrated Child Development Scheme. They said, why not mix food and education, so that if children will not come for education, at least they will come for food. And under ICDS, we have Anganwadi and midday meal. But I hope you know, midday meal is no more. Midday meal is now known as PM POSHAN. So midday meal is changed into PM POSHAN. There is 3 questions which can come from this part and which has been came also. Let's discuss this and then I will revise the logos. First revise the logo, then I will come to PM POSHAN all. In the logo, let's see it all. If I say red color mother, red color child, that is Anganwadi ICDS. Yellow color mother, yellow color child, that is JSSY, Janani Suraksha Yojana. Green color mother, green color child, that is Anmol software, tablet based software for data entry. Then blue color mother, blue color child, that is UNICEF. White color mother, white color child, that is baby friendly hospital initiative. Black color mother, black color child, that is Laksh. So total there are 6 programs with mother and child, and just by the color you can remember it. We have revised it here also, and you can easily remember it. Okay. So this is Mobile Academy, ASA training on phone. You can see the logo. Now let's discuss this point what I was saying, and through which a lot of questions come. Now, Government of India has done one new work. What they have done is, they are saying that Anganwadi was different, school was different. So many students, they go to Anganwadi, but they don't go to school. There is a dropout. So to prevent dropout from Anganwadi, what government has done, a new work which government has done is, they have mixed Anganwadi into school. They said Anganwadi either should be connected on paper or they should be in the same campus with a school, so that dropout is not there. To prevent dropout from Anganwadi, what they have done, pre-primary is known as Bal Vatika. They call it Bal Vatika. Pre-primary is including nursery and kindergarten and all. Pre-primary is mixed with other school, plus school is there. They are together. Pre-primary and school are together. Basically, pre-primary is 3 to 6 year. Bal Vatika children are of age 3 to 6. And then first, second, third class is there as primary, and then we have this proper schooling after third. But what is the point in PM POSHAN is, previously midday meal was only for school children, but now because school and Anganwadi, they are together, so midday meal or PM POSHAN, now it do not just cover school children. PM POSHAN is also covering Anganwadi children. Along with school children, preschool children will also get the meal. Preschool children also get meal. And what meal they get? Which one is half and which one is 1/3? In the rural part of India, mostly the children are getting rice. So from the rice, they get the calorie, but not the protein. So they need in the school more protein, less calorie. So the government is giving half protein, more protein and less calorie, because calorie they can get at home, but not protein. So in PM POSHAN, half protein, 1/3 calorie is given. And the new thing which has done is, it is not only for school, but also for preschool children. Why this new thing has done? Because now Anganwadi is merged with school. So it is, Anganwadi is also with school, midday meal is also for both Anganwadi and school. And why it is done? To prevent dropout from the Anganwadi. So dropout after Anganwadi, we have done this. And what was the purpose of midday meal? Main purpose of midday meal was to prevent dropout of adolescent girl, because maximum dropout occur in adolescent girl age. And main reason of dropout is that many villages don't have a school, so female has to travel to other villages, and then the family members, mostly the husband, mostly the father and the brothers, they say ki it is not safe for you to travel, so stay in the home. And that is the reason why most of the girls are leaving school, because government schools are not there in every villages. Plus, I came to know that in the last some 5-7 years only, more than 5,000 government school has been closed in UP also and other states also. So that will further decrease the education level in those villages. It should not be done, especially for girl child. We need school in every village. So do remember, main purpose is to prevent dropout from adolescent girl. Chalo, so we have read all the mother child program logos and midday meal separately. Now let's read this program, POSHAN, very important program. In NEET, MCI, INICT, everywhere, you will get the question from Anemia Mukt Bharat and all. And Anemia Mukt Bharat come under POSHAN. So POSHAN full form is Prime Minister Overarching Scheme for Holistic Nutrition. PM is Prime Minister, O for overarching, S for scheme, H for holistic, N for nutrition. But what does A stand for? Nothing. It was just coming in the rhyming, because if you remove A, it will become POSHAN. So it is POSHAN, but A is silent, and A doesn't have anything. Prime Minister overarching scheme for holistic nutrition. So in the POSHAN, there is 5 programs. 3 programs are with A: Anganwadi, Adolescent Program, and Anemia Mukt Bharat. 3 are with A, and 2 have POSHAN written under it. So you can simply say what are the 5 programs. 3 with A, 2 have POSHAN. So Anganwadi we just discussed right now, that in Anganwadi children start going since 6 months of age they can go, because before 6 months they are just getting mother milk, so no need of supplementary nutrition. Until which age children go in Anganwadi? Till 6 year in their school time. Anganwadi is for up to 6 year, not just 5 year. It is for up to 6 year. And do we have adolescent girl and adolescent boy going to Anganwadi? We have adolescent girl going to Anganwadi, but not adolescent boy. Why? Because villager think if boy and girl both came to Anganwadi, they will make Anganwadi Tinderwadi. So they have it for only for adolescent girl. Then of course pregnant female and lactating female come to their Anganwadi. Adult female also come there. But do we have old age mother coming to Anganwadi? No. Because if they will come, how this female will do the chit chat from their hut, how they will make jokes on their mother-in-law. So old age are not coming to Anganwadi. Similarly, there is a program RMN-CHA plus N. This RMN-CHA plus N, R is for reproductive, M is for maternal, N for neonatal, C for child, H for child health, A for adolescent, and N is to end for nutrition. So they ask this question also in NEET. They have already asked just last year, which age group is not included in RMN-CHA. So in RMN-CHA plus N also, and in Anganwadi also, both of it does not include old age. They don't include old age people. That's not the focus of RMN-CHA plus N. Okay, it's reproductive, maternal, neonatal, child health plus adolescent health, and focusing on their nutrition also, but not on old age. Chalo, so Anganwadi is done. PM POSHAN, we discussed that it replaced midday meal. This has also been discussed. What is Nikchhay POSHAN? See, Nik means no, and Chhay means loss of body. Chhay rog we call for TB. Chhay, loss of body. So Nikchhay means no TB. For no TB, we are giving POSHAN. POSHAN means nutrition. So for this, earlier government was giving 500 rupees per month. Now the government gave 1000 rupees per month. And this is not for serious patient or less serious. It is for every TB patient. Why are we giving this money? For supplementary nutrition, so that they can have some egg or some proteinaceous food from this money. For supplementary nutrition, government is giving 1000 rupees per month nowadays. Okay. Then there is adolescent program. We call that program RKSK, Rashtriya Kishor Swasthya Karyakram. Kishor means adolescent, and adolescent means those who are between 10 to 19 years. In this Rashtriya Adolescent Program, National Adolescent Program, there is 2 work which government do. One is adolescent reproductive and sexual health, where female school teacher give them sex education. On menstrual hygiene and sex education work is under sexual health. Then other is adolescent friendly health clinic, where government said we should have separate OPD for adolescent, 1 day per week at PHC, 5 days per week at CHC, separate OPD for adolescent. That is 2 work under RKSK, adolescent friendly health clinic and adolescent reproductive and sexual health. 1 day OPD at PHC and 5 day OPD at CHC for adolescent. Last most important program is Anemia Mukt Bharat, which we have to read in detail. So in the Anemia Mukt Bharat, let's also discuss what is the target of POSHAN Abhiyaan. That's a question which I am expecting. So to remember the target, a student in Mumbai, he gave me a very good mnemonic, lusty. Lusty. because the target is reducing everything by 2%. So it is less T. T means 2%. What we have to reduce by 2%? L stand for low birth weight. U stand for underweight. And S is for stunting. So low birth weight, underweight and stunting all should be reduced by 2% each year. This is the target of POSHAN. In the past, in MCI exam, they have asked what is the target of Anemia Mukt Bharat? And target of Anemia Mukt Bharat is to reduce anemia each year by 3%. So anemia reduction is by 3% and low birth weight, underweight and stunting reduction is by 2%. Okay. Then I will discuss this part, POSHAN Abhiyaan, Nikshay POSHAN, Anemia Mukt Bharat. But let's have this question first. This is again a PYQ of MCI exam, which is not included in Global Hunger Index. So Global Hunger Index can be remembered by this mnemonic, fuck US. And friendly US also you can use. So why this mnemonic? Because in Global Hunger Index, the 3 target is F stand for under 5 mortality. Reduction of under 5 mortality. And US is the same which we have in Lusty. U stand for undernourished. S stand for stunted. Low birth weight is replaced by under 5 mortality. So only thing is L is replaced by F. And LF. Yani low birth weight is replaced by under 5. So which is not a target of Global Hunger Index? IMR is not a target of Global Hunger Index. IMR also not a target of Sustainable Development Goal. In Sustainable Development Goal, they keep asking again and again, what is the target for MMR? MMR target of Sustainable Goal is less than 70 per lakh. This is the target of SDG for MMR, less than 70 per lakh. And what is the target of India for IMR? India target for IMR is less than 30 per thousand, which we have achieved according to the fake data by our fake government of India. We have achieved this target already. So this was the only question which came from this data. Many students also they ask, and many teacher also they keep teaching the current IMR, current MMR, current under 5 per this much is the data. But in last 20 years, they have never asked what is the current IMR, current MMR of India. This question never come. So don't burden yourself by remembering those bullshit data. What is current IMR, current MMR? They can only ask you the target, not the current. They have never asked, and they will never ask, because the current data is always copy pasted from last year mostly. So it's not the real data. That's why they don't ask also. Remember, MMR should be 70 and IMR should be less than 30 per thousand. This is what is the requirement that they ask. When we will talk about SDG, if time will be there, we will discuss SDG target. Let's discuss it here only. SDG has main focus on 4 targets. You just have to remember 3 number: 70, 12, 25, 70, 12, 25. Second target of SDG is that we have to reduce stillbirth. No target for stillbirth. Stillbirth should be single digit, less than 10. But the target of SDG is neonatal mortality rate should be less than 12 per thousand. And under 5 mortality rate should be less than 25 per thousand. So actually it's so easy to remember. Under 5, 25, 5 into 5, 25. And if you do half of 25, it's 12. So under 5 should be less than 25. Half of 25, 12 is neonatal. And MMR target is less than 70 per lakh. 70, 12, 25, 70, 12, 25. Then they say that cardiovascular death should be 1/3 and accidental death should be half. But the target of accidental death half was for 2020. And in 2020, Corona came, so actually accidental death became half. So remember, only one target of SDG was fulfilled, accidental death to half, and that only fulfilled for 1 year, 2020. So accidental death half, cardiovascular death, premature cardiovascular death before 70 years should go by 1/3. Neonatal mortality less than 12, MMR less than 70, and under 5 less than 25. These are the 5 target of SDG, but mainly focus on MMR target less than 70. Okay. And in the Global Hunger Index and SDG, both IMR is not a target. Okay, sure. So now let's talk about Anemia Mukt Bharat in better way. We know the target of POSHAN, and Nikshay POSHAN, we already know that government is giving 1,000 rupees per month for welfare. Now let's talk about Anemia Mukt Bharat. So what is the target of Anemia Mukt Bharat? To reduce anemia each year by how much percent? 3%. And Anemia Mukt Bharat has 6 into 6 into 6 strategy. कुल मिला के बड़ा ही छक्का प्रोग्राम है. It's a very sixer program. All the 3 sixes are there. So they ask, what are these 3 6? So do remember, first 6 are the people who will be benefited, beneficiaries, those who will get the benefit. Second 6 are the 6 intervention which we do, है ना? And last 6 into 6 into 6, and last 6 is the institutional mechanism. So they have asked this question already, that which of the following is not included in 6 into 6 into 6 strategy. So you have to remember, beneficiary, intervention, institutional mechanism. These 3 are included in 6 into 6 into 6. Main thing is from the dosing of iron folic acid. And you have to remember only 3 doses. First dose, let's focus on 5 to 9 year children. These 5 to 9 year children are usually pink children. So they get pink tablet. And if you subtract 5 to 9, it's 4. So the tablet dose is 45 milligram iron and 400 microgram folic acid. So always 4 and 4, 5 to 9 year. Pink tablet, 45, 400. Then this was the question in last NEET exam, and INICT also have asked it already, that adolescent boy and girl, they get blue tablet. Because remember your time also, 10 to 19 year was the time when you watched blue film for the first time. So that is the time when the government also give blue tablet. And in the blue tablet, there is 60 milligram iron and 500 microgram folic acid. And the good thing is, all other 3 group, adult, pregnant and lactating, they get the same dose, 6500, 6500, 6500. They all get the same dose. So only 2 doses here you have to focus, 45, 400, 6500. Last thing is for 6 months to 5 years. They are very small children. So we have to give them low dose. And to make the dose low, we can divide it into 2. So 6 months to 5 years, they are the only group who get it bi-weekly, twice a week. Bi-weekly, 20 milligram iron plus 100 microgram folic acid. This is given in the form of 1 ml IFA syrup. Okay, so it's so easy to remember actually. If you see, if you multiply 20 with 5, it will come 100. So 6 months to 5 years, 20 into 5 is 100, 20 and 100. And only low dose bi-weekly is given in up to 5 years. Rest these 3, pink, blue and red for adult female. These all 3 can be remembered by the mnemonic PBR. Just like we go to watch movie in PVR. And some people also go there to do some gulu, intelligent people. So how many times in a week movie are released in PVR? Of course, movie are released once a week. So similarly, this PBR tablet is given once a week. Pink, blue, red is given once a week. But in adult female, we give it once a week. But in pregnant and lactating female, do you give tablet once a week? No. If you will give it once a week, they will throw it at your face. What we will do with that? So in pregnant and lactating female, we have to give 1 tablet per day for 180 days before and after delivery. So remember, after delivery also we have to give the tablet for 6 months. And before delivery means we do not give iron folic acid tablet in the first 3 months. We only started from 4 months and then continue till 9 months. So that is 180 days before delivery. In the first 3 months, we only give folic acid, no iron. Okay. Do remember this question has been asked that if HB is 7 or 8, will you start iron from first trimester? No. We start iron from after 12 week, not before 12 week. We cannot start iron before 12 week. We start folic acid, but not iron. Second benefit of, so there are two type of question from this Anemia Mukt Bharat. Actually 3-4 type of question. One is the target of Anemia Mukt Bharat, how much reduction of anemia? 3%. Second is 6 into 6 into 6. Third question is from the dosing. I hope you remember the dose of iron folic acid. The fourth and last question is, what are the various intervention which is done? What are the 6 intervention? So first intervention we discussed IFA. Second intervention is albendazole. Albendazole is given 200 ml, 200 milligram or 5 ml half bottle if the age is less than 2 years. If the age is more than 2 years, we give 400 milligram or 10 ml full bottle. We said to the mother, take the full bottle in the night. Main thing is the timing when we give it. Because this albendazole is not given for treatment. For treatment, we give it today and after 14 days. This is for prevention. So we give it twice in a year. And the time of giving it is, first tablet is given on 10th of February. Second tablet is given on 10th of August. So 10th August is 5 days before Valentine's Day. 10th August is 5 days before Independence Day. And 10th February is 4 days before Valentine's Day. This question has been asked. This is the National Deworming Day. And it's very easy to remember. What comes 4 days before Valentine's Day? Is it Hug Day? Love Day? No. What is that? 4 days before Valentine's Day. That is Teddy Day. So, if you met any girl or any boy on 10th February, you will give him 1 tablet of albendazole. And the boy or girl will ask you, क्या इरादा है, गोली खिला रहे हो, क्या प्लान है? So you will say कि ये तुम्हारे कीड़े मारने के लिए ना. If they will ask you, why are you giving me a tablet? This is to kill your worm. And remember to give your teddy 1 albendazole on this 10th of February. This is National Deworming Day. Okay, never forget. So this is the second benefit. The third benefit is behavior change communication and delayed cord clamping. What do you mean by behavior change communication? It's simple thing. In the Anemia Mukt Bharat, the logo is solid body, smart mind. So even before this program, if we want the mother to take the tablet, we used to say that if you take the tablet, your child will come first. So mother will take it for a smart mind of their future child. And every child has the dream that they should be able to kick out all the other children of the street. Every children want to have solid body. So we'll say that if you take iron syrup, you will have solid body. So solid body smart mind is the logo of the Anemia Mukt Bharat program. And this logo, if you tell to the patient, it can change their behavior and they can take the tablet. So this is the third benefit. Other 3 interventions can be remembered by the mnemonic DFF, double FF. First D is digital hemoglobin measurement. F is fortification of food with iron and supplementation with iron rich product like green leafy vegetable. So, and last F is focus on other cause also, like malaria can cause anemia, fluorosis, high fluorine in water can cause anemia. So focus on these cause also. So what is this DFF? First D intervention was digital HB measurement. Second F was food fortification, adding iron folic acid in the food, fortification or supplementation. And last F was focus on other cause also. DFF was these 3 intervention. The remaining 3 was iron folic acid, albendazole, and behavior change communication and delayed cord clamping. So these are the 6 intervention. Now here I want your focus on one topic from which 2 questions came in NEET exam last year only. The topic was of fluorosis. As I was saying, if fluorine is high in water, that can also cause anemia. So let's read 3 things about fluorine. First thing, in MCI exam 6 years back, they have asked, what is the dose of fluorine in normal water? So the dose of fluorine in normal water is 0.5 to 0.8 milligram per liter. And why this is so easy to remember? Because if you look at the dose of chlorine, chlorine is also almost the same 0.5 to 0.7. So chlorine and fluorine dose similar, almost similar. And there was one question in MCI exam 2 years back, that what is the amount of residual chlorine and what is contact period. Residual chlorine means minimum chlorine which should always be in the water. So what is the amount of residual chlorine? How much chlorine should always be there in the water? You can see it very well. Residual chlorine should be 0.5. At least 0.5 chlorine should always be there. And to keep this 0.5, we should have a contact period of 1 hour. In this 1 hour, bleaching powder which we put in water for chlorination will release different ion and they will do dishum, they will kill the bacteria. The question is, what is the most important ion of bleaching powder which kill maximum bacteria? So the most important ion is HOCl minus ion. We call it hypochlorous. देखो, जिसमें रस है ना, रस means juice. है ना, रस is a word for juice. So the one with rus or juice, one with 1 minus, they will kill maximum bacteria, 80% bacteria. So hypochlorous ion is most important ion. Residual chlorine is 0.5. Contact period is 1 hour. Okay. Let's talk about fluorine here first. If the fluorine is more than 10, it can cause brittle bone. Brittle bone means pathological fracture. Bone can break, है ना? Baba can come and say कि डॉक्टर साहब सुबह टट्टी पे बैठ रहे थे, हड्डी चटक गया. टट्टी से उठ रहे थे, हड्डी चटक गया. टट्टी नहीं, हड्डी चटक गया. So if you are the orthopedician, what advice will you give to this person? खड़े खड़े करो, ऐसे ऐसे. Usually student answer use western toilet, but no. If you will use western toilet, at least he will sit somewhere. So that's not a permanent solution. The permanent solution is we have to remove this extra fluorine from the water. To remove this extra fluorine from water, we call this process as defluoridation, removing extra fluorine from water. And this was the question in NEET last year only, how we do defluoridation. Defluoridation is done by adding lime plus alum, mainly these two, and then we can add one more bleaching powder. And this is the sequence of adding it also. First we add lime, then we add alum, then we add bleaching powder. So this can be remembered by the mnemonic lab. Lime, alum, bleaching powder we add. If we add these three things, chuna, phitkiri or bleaching powder, I don't know the Hindi. If you add these three things in this sequence lab, extra fluorine will go away. This technique is known as Nalgonda technique. Because this 2 question came in last NEET, it's very expected to come in your exam. This Nalgonda technique, lime, alum, bleaching powder you have to add. So if you remove the fluorine from water, it will decrease the problem of brittle bone. Second problem with high fluorine is, if the fluorine is more than 1.5 also, it can cause dental fluorosis. आपने भी अपने कुछ दोस्तों में देखा होगा कि दांत के ऊपर सफेद सफेद लेयर जम जाता है. अगर वो सूखे वाले एरिया से आ रहे हैं तो ज्यादा चांस है. If your friend are coming from drought affected areas, then they can have white deposition on their teeth. That is due to high fluorine. We call it dental fluorosis. Image based question on dental fluorosis has already came in MCI exam. Do remember, they can give an image of white plaque on teeth, dental fluorosis. And third thing which can occur is anemia. So anemia, dental fluorosis, and this brittle bone occur if fluorine is high. If fluorine is high, then this problem. But if fluorine is low, then what problem will occur? If the fluorine is less than 0.5, दांत सड़ जाएंगे, then there will be dental caries. And that is why we should brush our teeth twice, because most of the water which we are drinking is without fluorine. At least toothpaste will have fluorine. So if you brush it twice, you can get the fluorine from the toothpaste. Okay. So do remember, dental caries less than 0.5 fluorine, more than 10 fluorine brittle bone, pathological fracture, more than 1.5 anemia, dental caries. And how to remove it? By lime alum bleaching powder. Okay. So these are the things, 6 intervention, 6 into 6 strategies, and of course fluorine I added extra, but I hope Anemia Mukt Bharat is clear to all of you. Now, after knowing all this program, let's do some question. As I said, this question can come that if a female have HB of 9 at 20 week, what is the treatment given under Anemia Mukt Bharat? So students say this is there is no option like B, this typing error. There is 2 option here, A and C. Okay, 60 milligram plus 500 once a day, or 60 milligram plus 500 twice a day. What do you think? Once a day or twice a day? What is correct? In Anemia Mukt Bharat, for pregnant female, we give it once a day. But once a day is for female, for pregnant or lactating female, whose hemoglobin is normal. If hemoglobin is more than 11 in pregnancy, we call it non-anemic. So for non-anemic, we give once a day. Here she is having anemia. If someone is having anemia, then we have to treat it. And for the treatment, we have to give 60 and 500 twice a day, not once a day. So remember this point. If they focus on HB, and what is the cutoff of HB? Cutoff is 13, 12, 11. If HB is less than 11 in pregnancy, we call it anemia. Less than 12 in female, we call it anemia. Less than 13 in male, we call it anemia. This is WHO definition of anemia. So 13, 12, 11. If any one of you have hemoglobin less than 12 and you are a female, mostly female have low chances of HB because of menstrual loss, of course, you should take iron tablet daily. It will make you less irritable, more focused, hair loss will be less, absorption of vitamins will be better, and your mood overall will be better. Plus headache and calf muscle pain will be reduced. So please do take 1 tablet of iron, especially ferrous fumarate will cause less toxic gas problem and all. And take it with breakfast every day. And you will find in 3 months, your all these symptoms has gone. And the improvement is start offering very soon. So do take 1 tablet if your hemoglobin is good. 2 tablets per day if your hemoglobin is less than 12 if you are a female, less than 11 if you are a pregnant female. So do remember, HB 9 to 11 is mild anemia. Anemia is a topic from which a lot of questions come in Ops Gynae also, Patho also, PSM also, so we should know. For mild anemia, what is the treatment? 2 IFA tablet per day. This is the treatment for mild anemia. Then if the hemoglobin is between 7 to 9, we call it moderate anemia. And if moderate anemia came early, before 24, 26 week, then we have to give 2 iron tablet. But if moderate anemia came very late, moderate anemia came after, let's say, 28 week. So there after 28 week, we don't have much time to do intervention. So in this case, what we give, this is the question which I am asking here. The question is, a female is coming with hemoglobin 8. So she has moderate anemia and she is coming at 34 week. So she is coming late. Which out of 4 intervention will you do? Already a PYQ. Will you give 3 tablet of IFA? No, never. We never give 3 tablet of IFA. Will you give injection iron dextrose if not responding to IFA? Yes. We can give injection iron dextrose. We can also give IV ferric carboxymaltose. But the problem is, in the option C, there is a problem. We have said ferric carboxymaltose and IFA. If you are giving IV ferric carboxymaltose, why to give oral also? Body will not absorb oral plus iron both. So when we give IV, we stop oral. And IV blood transfusion we do if hemoglobin is less than 7. We call it severe anemia. So in severe anemia, we do blood transfusion. In mild anemia, we give 2 iron tablet of which dose? 60 iron and 500 folic acid. We give this thing for mild anemia, 2 a day. For moderate anemia, we give two things, IV iron dextrose or IV ferric carboxymaltose. And we never mix both the thing. Either one of this we give. And we never mix oral and IV tablet. So mild anemia, 2 tablet, moderate anemia, iron dextrose, ferric carboxymaltose, severe anemia, blood transfusion. This is the anemia treatment which we should know. If you are the medical officer in charge of a PHC, out of the 4, which one will you give? Will you give only ferrous sulfate, only vitamin B12, folic acid, only folic acid, or will you give everything? Answer is we will give everything. We will give ferrous sulfate, folic acid, vitamin B12, vitamin C, everything, because everything help in reducing anemia, and especially vitamin C tablet. Vitamin C is ascorbic acid. Why we add ascorbic acid when we take iron tablet? Because if you take iron tablet has ferrous sulfate or ferrous fumarate Fe2+. When this Fe2+ get acidic environment, it turn into Fe3+, ferric. And this Fe3+ absorbed by body. So we need acidic environment. And that is why we say that take iron tablet either empty stomach or just with breakfast, not with full meal. And this was the question in MCI also. Do we take iron tablet with milk or tea? Never. Because milk and tea decrease acidity. And that's why most best answer is take iron tablet with lemon water, because lemon water has ascorbic acid, which will help in absorption of iron. Okay. So never take iron with calcium or milk or tea. Now, very important is to discuss Ayushman Bharat, because again and again question do come from this part. Ayushman Bharat has previously 2 components, but now it has 3 components. What are the 3 components? Very important area. One was Health and Wellness Center, which is no more. Now it become Arogya Mandir. And we have discussed the detail of Arogya Mandir with 8 benefit and 5 staff. Second is PMJ, Jai Ho PM Ki, Pradhan Mantri Jan Arogya Yojana, People Healthy Program. And the third component is School Health Program. School health is also included in this Ayushman Bharat. And do remember, School Health Program also come under PHC, because PHC give training of teacher for screening of a student. Remember this question, very frequently they ask and confuse us, that in a school health program, who does the screening? Teacher does screening or doctor does screening? For low vision of children, always remember, it's the teacher who does the screening. And where does the teacher get the training for using Snellen chart? He get the training from PHC. That is why a school health program is coming under PHC Vision Center. And why it is also coming under Ayushman Bharat. Why? We will discuss. The reason is, this is a new thing which they can ask. In the school health program, new thing which has done in, on Tuesday, every Tuesday, they will celebrate Health and Wellness Day. They can ask which day is Health and Wellness Day? Tuesday. So, on this Health and Wellness Day, there will be 1 male and 1 female teacher. This 1 male plus 1 female teacher are known as Health and Wellness Ambassador. Ambassador, if you remember, was an old car, big car, white color. For government people, they were the old car. So ambassador is big thing, they are the teacher. And on the Health and Wellness Day, they will also have 1 male and 1 boy and 1 girl student as Health and Wellness messenger. So messenger are small children, ambassador are big teacher. And on Tuesday, in the school health program, they will teach and train the student for yoga and meditation, because yoga se sab hoga. So, because Health and Wellness Day is in a school health program and Health and Wellness Center is in Ayushman Bharat. So now Ayushman Bharat also include a school health program. And remember one more thing, in the school health program, the new thing that they have done is, this is a school health program we are discussing. In this school health program, On every Tuesday, every week, health and wellness day will be there. Plus, they will also give iron folic acid tablet to adolescent and children also in the school. But one more thing which they do every month or fortnight. Fortnight means twice a week. 14 दिन में एक बार को fortnight कहते हैं. So every fortnight or every month, they do two more things nowadays. One is thematic assembly. This is a new thing which they can ask. Thematic assembly. Update, you can say. Thematic assembly means one day assembly will have one specific theme, like theme of menstrual hygiene, theme of drug addiction, theme of the social media addiction. So this thematic assembly will be once a month or once in every 2 weeks. One more thing is question drop box. They, in the school health program, the government said that many students, they have problem and question regarding their body, also regarding their love breakup, regarding their exam pressure, regarding their parents, which they cannot come and ask openly. So they had make a drop box where they can put their question without writing their name and roll number. And every 2 in a week or once in a month, those drop box will be opened and their question will be answered either in the assembly, or if it is too personal, it will be answered person to person. So these two things are done month or fortnight. But one more thing is done quarterly. Quarterly means every 3 months. Quarterly, in a school health program, there will be Adolescent Health Day, AHD. Adolescent Health Day means on this one day in 3 months, full afternoon, half day, only adolescent topics will be discussed among them. And like all the topic regarding adolescent will be discussed once in 3 months. And they might get some sex education, they might get knowledge about menstrual hygiene, drug overdosing, drug addictions, and social media over addiction and all those things. So remember, there are 3 things which is done under school health program new. And I'm sure all the students who are listening, this might be new thing for many of you, that it's not only health and wellness day on Tuesday. It's also in a month, drop box will be open and their query will be answered. And there will be thematic assembly on some good theme like hygiene and other. And quarterly, every 3 months, Adolescent Health Day will be celebrated. So these are the new thing in school health program under Ayushman Bharat. And Ayushman Bharat have Health and Wellness Center, which we already discussed, Arogya Mandir. Last thing we have to discuss is PMJ, Pradhan Mantri Jan Arogya Yojana. So this is Health and Wellness Center discussion, and these are the 8 facilities. If you have not written it well at that time, you can write it from here. Now, these are there. Let's talk about PMJ. What is PMJ? The logo of this program and Ayushman Bharat program also have one pot with 5 leaves. This same 5 leaf is also in marijuana plant. गांजा के खेत में भी 5 पत्ते उगते हैं. तो सरकार क्या कहना चाह रही है? गांजा फूको. What the government want to say? Smoke weed? No. Government want you to remember the 5 lakh money which is given here. So the health insurance is of 5 lakh. That's why the logo have 5 leaf. 5 lakh per month health insurance. For no, this is not 5 lakh per month. This is why I write it actually. This is 5 lakh per year per EWS family. For one family, the insurance is 5 lakh in a year. And this health insurance will work only when you are admitted on a bed. If you want to use this for OPD cost, like doctor consultation cost, it will not be covered by the card. If you want to use it for medicine purchase, it will not be useful. If you want to use it for investigation, it will not be so useful. But when you are admitted in the hospital, in both private and government, then after getting admitted, this card will work. Okay. And this card work in secondary and tertiary level. Because primary level is PHC and subcenter, which is mostly free. Primary level is Arogya Mandir, which is free. So it is for secondary, tertiary level, government, private, both. And it is not for BPL family, it is for economically weaker section family. So remember, EWS family, 5 lakh per year insurance. This is PMJ. One more question which come is, Ayushman Bharat, is it a central government program or a state government program? What do you think? Do remember this Ayushman Bharat, it is funded by both. Hai this is, there is actually 2-3 program which has combined funding. Do remember this part. Ayushman Bharat, ESI plus this Food Safety Standard Authority of India. All of these 3 programs have both state and central government funding. In Ayushman Bharat, central government gives 60 to 70%, state government gives 30 to 40%. So it's have funding of both state and central government, all these 3 programs. Food Safety Standard, ESI and Ayushman. In ESI, the funding by central government is 7-8. Majority funding is central government. And the funding by state government is 1-8. Okay, so they have asked it. Remember, Ayushman is not the center, it is center plus state funded. Okay, there a question. Very good. Very good. So yes, very good. You are very well continuing with the session, and you are replying also very actively. That's good. And I'm also feeling that I am giving you a information packed session where questions which has came in recent 5 years, most of the topics are getting discussed. So it's useful. It's useful. The session I feel is useful for you. So this is Ayushman Bharat. Now let's talk about after Ayushman Bharat, this one small confusing programs which they ask again and again. Indradhanush scheme, Mission Indradhanush. These are 2 different things. Indradhanush scheme means the government wants 7 day, 7 day, 7 different color bedsheet. Where? In Vaibhav bedroom? No. In government hospital. 7 days, 7 different color bedsheet in government hospital. And because 7 color are also in rainbow Indradhanush, so they call it Indradhanush scheme. 7 days, 7 different color bedsheet. You can see such scheme in ESI hospital. Then Mission Indradhanush was an old program which was for 7 vaccine preventable disease. They are not going to ask it anymore because this program is obsolete, old. Now we don't have this program. Now the recent program is Intensified Mission Indradhanush 5.0. So under Intensified Mission Indradhanush, we cover all the vaccine. Under Mission Indradhanush, we had only 7 vaccine. 3 are those which are given at birth. OPV, BCG, Hep B, I hope you all know. These are given at birth. And for these 3 vaccine, ASA don't get paid. Why these 3 vaccine ASA don't get paid? Because these are given at birth. And ASA payment is not for vaccination. ASA payment is for motivation. And at birth, mother and mother-in-law both are in hospital. So whom the ASA will motivate? Sasurji and father-in-law. Kisko motivate? There is no one to motivate. So ASA don't get paid for these 3 which are given at birth. Then the other 3 vaccine are diphtheria, pertussis, tetanus, and last 7th was measles. I want to discuss one very important point here, that ASA and Anganwadi, they both don't do 3 work. What are the 3 work not done by them? First of all, actually it's 4 work. ASA and Anganwadi don't measure birth weight. Who measure birth weight? ANM. They don't conduct delivery. Therefore, they don't measure birth weight also. Theoretically, they don't give vaccine also. They just act as motivator and they get paid for it also. And they don't make malaria slide. So these 4 work not done by them. So this question has been asked in MCI exam already. Who make malaria slide? I am sure you all know. Malaria slide is made by multi-purpose worker MPW, which is same as health worker male. Now the question was, how do MPW make the slide? Do he made it by active surveillance, passive surveillance, and sentinel surveillance? And this surveillance question is coming in INICT also, NEET also, last year only, before last year also, and in MCI also. So we have to know the question of surveillance very well. Very important topic. So MPW, what he do? He visit every house in the village once in 2 weeks. And whenever he go to any house, he asks, "Ghar mein kisi ko bukhar hai kya? Does anybody have fever in the house?" And if anybody say, "Yes, I have fever," he will take the blood sample and he will make 2 blood smear. So health team is going and searching for hidden case. This is known as active surveillance. जब कभी हम जाके छुपे हुए केस को खोजते हैं तो इसको कहते हैं एक्टिव सर्विलेंस. एक्टिव सर्विलेंस किसके लिए होता है? हिडन केस के लिए. और here when MPW will make malaria slide, there is 2 malaria slide which is made. One is thin blood smear, other is thick blood smear. The question they ask from this part is in patho actually. The question is, which blood smear tell about species of Plasmodium? Thin or thick? What is your answer? Which blood smear tell about species? And how do we dye them? Do we use acridine orange or Gayamza or Buffy coat? What do we use for measuring them? शुक्रिया मेरी प्यास बुझाने के लिए. आ जाओ. Very good. Correct answer by Dr. Doom 99 and Gorisa 1620. Thin blood smear. This is the one which detect species, because thin blood smear means you put one slide with blood and rotate the upper one very close. So because it is very close, it is thin. And in thin, you can see the fine detail. So thin blood smear tell it is Vivax or falciparum. Now, what is the staining which is done? So the best staining is Gayamja staining. We can do acridine orange also, but Gayamja staining is best. Second question from this part is, if you found headphone-like gametocyte, is it Vivax or falciparum? Headphone. Remember, if you found this headphone type gametocyte, or if you found banana shaped gametocyte, banana and headphone both are suggesting falciparum. Falciparum. And if you found a gametocyte with a nucleus and with dot, this is Vivax. Okay. So falciparum is both headphone and banana. And how we detect it? By thin blood smear. Thick blood smear has more blood. So thick blood smear is more sensitive. Thick blood smear is what will have more blood. It can tell only whether Plasmodium is present or absent. Thin will tell the species. So remember this part. This is active surveillance, which we do for hidden case. Okay. Now, the next part which I wanted to emphasize is, this was the question in NEET exam just last time, that a patient of cancer is reported at hospital, of course, in the cancer registry. So which type of surveillance is it? Because of cancer, patient is coming passively. खुद से अस्पताल आ रहे हैं, हम लोग जाके नहीं खोज रहे. They are coming hospital by themselves. We are not going and searching them. So this is which type of surveillance? Passive surveillance. When they come by themselves, this is passive surveillance. When we go and search for hidden case, like in MPW, we call it active surveillance. And if you mix active plus passive, we call it sentinel surveillance. So sentinel surveillance is the best surveillance. Sentinel surveillance is for all case who are coming or who are hidden also. Okay, so do remember, cancer registry patient of cancer reported to hospital inside cancer registry. So cancer registry or patient coming is passive. When we are searching is hidden, active, and total is sentinel. All this too has came. One more question which came in NICT from this point was that during Kumbh Mela, there's a team of doctor who is visiting the camp, collecting the stool sample and other things. What is the purpose of this visit? Do they want to treat? Do they want to know the cases of diarrhea? What is the purpose? So the purpose of that visit of team of doctor to different camp was sentinel surveillance. And they were actively going also, plus some patients will come to them also. So remember, in Kumbh Mela, that team of doctor which was roaming around and all, the purpose of them was sentinel surveillance. For sentinel surveillance, team of doctor was going to different camp. Team of health workers going to camp. So that was for sentinel surveillance. Active surveillance is malaria MPW, passive is cancer registry, total is sentinel. Okay. Chalo. Now, remember, Mission Indradhanush is gone. Now we have intensified Mission Indradhanush 5.0, which include every vaccine of India. Now let's discuss this three things, Ujjwala and Ujjavala. We think we know it, but we under exam pressure we get confused. But it's actually very simple. If you see, when we write Ujjavala, in Ujjavala, there is a jaw. Jabda hai Ujjavala mein. See, there is a jaw in Ujjavala. And what is the purpose of jaw? Jaw catches food, chew it, and bring it to the stomach. Similarly, Ujjavala, jaw is there. So the purpose of jaw is to catch those children who are being trafficked and bring it to their home. Okay. So Ujjavala is to prevent child trafficking and help in their rehabilitation. Prevent child trafficking and their rehabilitation. And the logo of Modi's distributing cylinder you must have seen in many petrol pump, that was Ujjwala. Ujjwala is LPG cylinder with one-time gas. Only one-time refill is there. Same as Reliance Ambani has distributed Reliance Jio SIM with one-time refill. So that you will refill it and Ambani will earn money. Similarly, government is giving LPG cylinder with only one refill. So that next time people will refill it and government will earn money from there. So LPG cylinder with one-time gas for which family? BPL or EWS? This is for BPL family, not for EWS family. Okay. So this is Ujjwala, this is Ujjavala. I think you will never confuse here. Now, similarly, there is one more Ujjavala which never being asked. It will never be asked. This is subsidized LED light. Government distribute subsidized LED light. Okay. By government. So that's why it is brightness Ujjala. They will never ask it. They will only ask Ujjwala or Ujjavala. But there is one more confusing program. I hope it will be very soon coming. Yeah. PM POSHAN we have discussed. Before going into other part, let's discuss this one part. What is this Nishchay? Nikchay. We already have discussed Nikchay POSHAN and Nikust. And one more thing you can discuss is Spurs, not Spurs Gupta, just Spurs. So what are these things? I hope it's very simple and you know. Nishchay is a Hindi word which means to be sure of, pakka hona. This is a UPT kit, urine pregnancy test kit by ASA. Okay. What is Nick? Means no. Chay, I already told, loss of body, TB, no TB. So in Nick Chay, what we do, private and government, both report and follow up TB cases by online or offline reporting. So you can report the cases online also, TB cases, and you can personally go and report also, or paper also can be used for reporting. But NICHAI will collect the report from both private and government about all the TB cases. So NICHAI is for TB, NICHAI is for UPT. A student said ki sir, in out of these two, S is coming first in NICHAI, and S is for sex. Sex lead to pregnancy, which need UPT kit. So NICHAI with S coming first is for UPT kit. NICHAI is for TB reporting by private and government both. NICHAI POSHAN we already discussed. For TB patient POSHAN, how much money now a day? 1,000 rupees per month. Earlier 500, now it was 1,000 rupees per month for TB patient food. NICUST is the word for leprosy. So NICUST is leprosy multiple drug therapy, MDT, for leprosy patient. And what is SPURS? In leprosy we will discuss about it. SPURS is healing touch. This is a program where Sapna is the mascot. Sapna, I will show you the image also probably, is a girl with two choti. है ना, दो चोटी वाली जीजा जी की साली नहीं. This is Sapna, okay, with two choti in English, I don't know what they call it. Pony, with two pony. है ना? That is Sapna in SPURS program mascot. And what is this SPURS program? In SPURS, basically, we are increasing community awareness about leprosy patient. Increasing community awareness about leprosy. What we want to know about leprosy patient? First, how to detect early. Second, we want to know what is the treatment so that patients should detect early and go for treatment. And third is acceptance. As soon as someone develop leprosy, patient throw them out from the community. Government say that if they are on regular multiple drug therapy for 2 months, then they stop spreading it to other member and we can accept such people in the family. So we should not throw them out, we should accept them. That also we teach in SPURS program. Okay, so SPURS is for community awareness on early detection, early treatment, and community acceptance of leprosy patient. Mascot is Sapna with two pony. Okay, chalo. So that is there. PM POSHAN we already discussed, it replaced midday meal. And now we can see some other logos which they ask again and again. Let's quickly have it. One is this Skill India, Kausal Bharat. You can see screwdriver and pen in the same hand, so that if you don't get job by pen, use screwdriver. Okay. So under Skill India, what government is do? Government is giving free training to start business. And along with free training to start business, government is also giving low interest loan. So this two work is done under Kausal Bharat Skill India. Then this is Atmanirbhar Bharat, a bird with big wing but still not flying. That's India. So in Atmanirbhar Bharat, government is focusing on decreasing import, and government is also focusing on low interest loan. So these two are in Atmanirbhar Bharat. Then we have Sankalak, not Kalank, Kalak. Even the Hindi speaking people don't know the full meaning of Sankalak. It is compilation, not video, just compilation. What is compilation? Sankalak means? Sankalak means compilation of National AIDS Registry data. This National AIDS Registry data which we are compiling is from 2017 to 2019-20. So 2017 to 2020, they are just compiling the national AIDS data. This is known as Sankalak. If they make the logo small, pink logo but small, pink. If it is pink, it is breast cancer awareness. If it is red, the same logo red, that is NACO and National AIDS Control Organization. And if they elongate the tail, make the tail longer, that is Sankalak. Next is, TB harega, desh jeetega. This was the TB elimination program, and according to this, India will eliminate TB by 2025, which is gone, and we have not. And SDG will eliminate it by 2030. Sustainable Development Goal say we will eliminate TB, HIV by 2030. But India said 2025. Nikshay, we already said, reporting program for TB patients. POSHAN is nutrition. We discussed about it. Under this program, we give a lot of things. We also have 2-week awareness. This is the ASA distributing UPT kit, Nischay. Then we have the Anemia Mukt Bharat. Remember, the goal of Anemia Mukt Bharat is to reduce anemia each year by 3%, not by 2%. Anemia Mukt Bharat 3%, POSHAN Abhiyaan whole 2%, Lusty, low birth weight, underweight, stunting, all by 2%. That is POSHAN. This is the 6th intervention and 6th institutional mechanism by which we implement this program. Then they have not asked about institutional mechanism yet, but still, if you, and it's difficult to read, I hope you can read. It's not so tough to remember this institutional mechanism. First is, we will have National Anemia Mukt Bharat Unit. Institutional mechanism यानी वो तरीके जिससे हम अनीमिया मुक्त भारत को अप्लाई करेंगे पूरे भारत में, है ना. The method by which we will apply is institutional mechanism. First is National Bharat Mukt Unit. And when you have National Bharat Mukt Unit, that will be the center of excellence. This is second point. And that will be having national dashboard, national data. So center of excellence will be the Bharat Mukt and National Bharat Anemia Mukt Unit. And they will have the national data. So 3 things in one you can remember. National Anemia Mukt Bharat Unit, which is center of excellence, which has national dashboard data. 3 point done. Then see the trick of the government. It is intra-ministerial coordination, 1 point, and convergence with ministry, another point. So coordination and convergence are the same thing. So 3 plus 2, 5 done. Last thing you have to remember is strengthening supply and logistic chain. This one you have to remember separately. You have to supply IFA tablet properly on time. So supply logistic chain should be maintained. This is the 6th work institutional mechanism. And remember the 6th intervention: IFA, albendazole, BCC, and double FF. Distal HB measurement, food fortification, food supplementation. So I hope you remember Anemia Mukt Bharat. This is the logo of Kilkari. See, the diaper is full. Soon the Pichkari means squirting will also come. This is the program in which mother will get recorded messages on phone. She will listen to the phone and she can take care of the kid. सारे pediatrician जाओ तेल लगाने, है ना. No use of pediatrician anymore. Just phone messages which will tell the mother how to take care of the child, and she will take care of the child. So this is known as Kilkari. Kilkari is the first child cry. So they call it Kilkari. This logo once came in MCI exam. This is the logo which you see on silk sari and gold jewelry. It is for Bureau of Indian Standard, BIS. Okay. This is the logo of Ministry of Health and Family Welfare. Arogya Sukh Sampadam, Padam Padam. That means in good health lies all happiness and wealth. So this is MOHFW, not Ayush. This is MOHFW Ministry logo. This is the logo of death and birth. And let's discuss 3 more extra question here. First thing, what is this red thing coming out? This is the life coming out, birth, and the black is the death they have shown in this logo. Their registration of birth and death should be done within how many days? Should be done within 21 days. We should register birth and death. Now the question is, where will you register birth? Where will you register marriage? First tell. Marriage registration has been asked in MCI exam. This is something, marriage registration, which we do at sub-center. Where do you register birth and death? Birth and death are registered at PHC. Because PHC has MBBS doctor, so they can trust there more. Marriages are registered at sub-center, but birth and death register at PHC. Okay. This blue color logo is for diabetes awareness. Blue circle, diabetes awareness. This is the logo of ESI scheme, and let's discuss 4 points of ESI scheme separately. ESI stands for Employee State Insurance Scheme. First point you should know is that this was the question which came in MCI exam last time, that a patient has 25% burn. If he have 25% burn, will he get 90-day leave or 2-year leave? Will he get sickness benefit? This sickness benefit is 91-day leave. भाई दूसरा वाला पेन है क्या निखिल, देखना तो 91-day leave with 80% salary. So this is sickness. But when they talk about, thank you, when they talk about extended sickness benefit, this extended sickness benefit is for 2 years with, yes, the salary part is something which I also get confused. Here, in normal sickness benefit, 70% salary, but extended sickness, 80% salary. Why more salary? Because in extended sickness, they are more sick. In normal sickness, they are less sick. So when they need more help, the salary will be more, 80%. And this 25% burn, any burn more than 20% burn will come under extended sickness benefit. So they will get 2 year leave with 80% salary if they have 25% burn. If they have leprosy, if they have TB, empyema, there are 34 diseases registered under it. For all of them, they get extended sickness benefit. Okay. Empyema also. This one question also came. TB, empyema, leprosy. And one question is more than 20% burn. So all the serious disease, if they write, they will have 2 year leave with 80% salary, extended sickness. But to confuse you, they can create an option of enhanced sickness. Remember, extended sickness is for 2 years. Enhanced sickness is for cutting your wire, तार कटवाने के लिए. It is for tubectomy or vasectomy. And which one is needing short leave? किसको कम छुट्टी की जरूरत है, वैसेक्टमी को या ट्यूबेक्टमी को? Of course, vasectomy need less leave क्योंकि ऑलरेडी नीचे लटक रहा है, क्या करना है, बस काटना ही तो है. 1 centimeter of vast difference is cut in vasectomy and resealed, and it is already hanging down, so easy to do. 7 days for vasectomy. And for tubectomy, how many days? Tubectomy we give it for 14 days. And in vasectomy and enhanced sickness benefit, we give 100% salary because enhanced sickness benefit, you are cutting your wire for the country. So more benefit here. For tubectomy 14 days and for vasectomy only 7 days with 100% salary. Now let me ask you one very confusing question from here. What is the duration of maternity benefit? This was a question being asked already. Option A, is it 20 week, 24, 26 or 28? Second question I want to ask, but I want to see your answer in the group. So please do reply, my dear friend. What is this maternity benefit for? What is the duration? Second question is that we do random blood sugar done at sub-center in pregnancy. Best at which time we should do random blood sugar in pregnancy? Okay. Best time to do it. Option A, is it 12 week? Is it B, 20 week? Is it C, 28 week? Or is it D, 34 week? So answer both of the question, but start with the first one. 6 months is not the option, dear. My friends are replying 6 months. 6 months उन्होंने option दिया ही नहीं इसीलिए. Because we remember 6 months, but we get confused in the week. Answer in week, my dear friend. Don't answer in month. So most of you, including Parul Patel, then Krishna Kant, then Subham Patel, Vaibhav, Dr. Doom, Patel Raj, all of you, Deepak Kumar, Nitesh Kumar, all of you have answered it correctly. 26 week, very good. It means your preparation is going good. Why 26 week? Because if you look at 6 months, 6 month has 4 week each month, but after 4 week also there is 2 to 3 day. So of course 4 week into 6 is 24. But what about these 2-3 day? This 2-3 day, if you multiply with 6, that will add up to 2 more week. So total is 26 week. Now let's come to the second confusing question. What is the best time of doing RBS in pregnancy? See, at 12 week if you do, this will detect 12 week, detect previous pregnancy, previous diabetes in mother. It is not helping us to know gestational diabetes. It is just telling us whether the mother is diabetic already or not. And at 12 week, we detect by OGTT, oral glucose tolerance test. We give 75 gram of glucose to the mother. We take her blood sugar before it, and then after 75 gram of glucose intake, we ask her to come after 2 hours, and we take the blood again. So OGTT we do at 12 week for mother diabetes, not for gestational diabetes. Gestational diabetes is detected in second trimester. Correct answer is by Nitesh Kumar. No, Nitesh Kumar has answered for that. And Subham is asking me to discuss MTP Act. Love you, bro. Definitely I will discuss it. But focus here first. 12 week, we do RBS. No, 12 week, we do OGTT. RBS is ideally done in the second trimester between 24 to 28 week. So because it is 24 to 28 week, the best answer is 28 week. Because at 24 also we can miss some gestational diabetes. Gestational diabetes come in second trimester, so the answer is 28 week. Okay, so good that I added something in your knowledge. And if you don't know, now you know it. So very good. Ekam Ved Vidya had answered it also 28, and Patel Raj had also answered after 20. So you both were correct. Now before moving ahead, let's fulfill your demand because your wish is my command. So this is very important to know the MTP Act. Although it's in forensic also, but we can discuss it. First thing is that in the MTP Act, if you are doing MTP till 12-week period of gestation, then this is something which was earlier allowed by one doctor, still now it is allowed by one doctor. Now the government said till 20 week, we can do abortion without the consultation of second doctor. So this 12 week is now 20 week period of gestation. Okay, 20 week period of gestation. And if someone has failure of contraceptive, failure of contraceptive is something which is a common reason which people come and tell ki why you want to do abortion, because my contraceptive is failed. If failure of contraceptive has occurred, then by 20 week, they must have seen the growth of the abdomen. You cannot miss the pregnancy till 20 week if there is failure of contraception. So remember this point, failure of contraception up to 20 week only we can use this for this as a logic for a medical termination of pregnancy. So up to 20 week, first thing, no need of medical board. We need one doctor permission. One doctor, one registered medical practitioner, RMP doctor permission, who have practiced MTP and who have seen deliveries also, some fixed number and all. They can allow it, one doctor, 20 week, and failure of contraception up to 20 week only. Now let's talk about 22-24 week. In 22-24 week, we have three reasons. First is of course rape. Second is if there is incest. What is incest? Incest means some family member did sex and pregnancy happened. Okay, so that's incest, equivalent to rape, but I think it's incest is more brutal than rape, because at least they can put a blame, but here it's too complicated. But anyway, the third thing is of course congenital anomaly. So the question that they ask here is, in the congenital anomaly, in the three cases, we can do between 20 to 24 week, and it need two doctor permission. 20 to 24 week. The third point is, which they ask in exam, that for which reason we allow after 24 week. Which reason? So after 24 week, there is only one reason, no other reason. That is congenital anomaly. Why not rape? Because you will think that on humanitarian reason we should do. So this is something which we can do after 24 week. And if you are doing after 24 week, you need medical board permission. And this was the second question which came from this part, that this medical board permission is which people are there in the medical board, because we need to know about it in the PCPNDT Act also. PCPNDT is for preconception, prenatal diagnosis of sex, है ना? PCPNDT Act or MTP, both have the same medical board. And what are the people in the medical board? I hope you all know. I need not to discuss, but still, just because it asked, one, of course, option gynae will be there. There will be a pediatrician. There will be a radiologist. Plus, this is the part which we miss. There is also a nominated member. This nominated member is usually from some social organization or people part. And if there is difficulty in finding someone good from the social organization, we can use medical superintendent or CMO as a nominated member. But mostly we should have it from some social organization. So these four people are in medical board. Now there is one good question in PCPNDT Act. Let me ask that also. In NEET exam, only 2024 or 25, I'm missing, but that 24, this was the question. There is a 30-year pregnant female, gravida 4, para 3, with no abortion. She came to you for ultrasound, and you have done the ultrasound. Now, now if you have done the ultrasound, the question which they are asking is, what should you do? Should you do ultrasound and tell sex, detect sex, or should you do ultrasound and not detect sex? Because we never tell it to the patient. But of course we do ultrasound. But do we detect sex, or do we don't detect sex in this case? That was the question. Don't detect or determine sex. What is the answer? Because you are doing ultrasound and you know you will never tell it to the patient. But will you detect sex on ultrasound? Or will you don't detect sex on ultrasound? What will you do in this case? So to answer such question, we have to know the criteria for sex determination in PCPNDT Act. Then only we can answer it. And there, the criteria for sex determination is very simple. First criteria is that age of the mother should be more than 35 years. And here it is 30 years, not fulfilling this criteria. Second, third, and fourth criteria is that there should be history of one of the three things. Either there is history of 2 or more abortion, consecutive abortion. Consecutive मतलब एक के बाद एक, 2 से ज्यादा बच्चे अबॉर्ट हो गए हैं. 2 or more consecutive abortion, one after another abortion. Third criteria is there is history of तो पहले लिख दिया, history of toxic or radiological exposure. Okay, toxic drug someone has taken, like anti-cancer drug or something like that, or radiological exposure during pregnancy. Fourth is if there is history of congenital anomaly in other sibling or family member. Okay, history of congenital anomaly in family member or sibling. So these are the 2, 3, and 4 reason. The last, fifth reason of determining sex is if you have some humanitarian basis when the medical board allow it. So medical board can allow some other cases of PCPNDT also, but it should be approved by these 4 people: Obs Gynae, Pedia, Radio and nominated member. So here in our example question, the age was fixed, there was no abortion, and she is gravida for para 3. So there is actually uh, no history of congenital anomaly and all those things. So we will detect, we will do ultrasound, but we will don't detect sex on ultrasound. Never detect sex, because if you will detect sex, subconsciously you can release it. You can say कि बच्ची अच्छी है, बच्चा अच्छा है. And subconsciously doctor can miss it, the gender, by spelling it that the girl is good, the boy is good. And so we should not detect sex. That's what guidelines say. Not detect sex unless one of these 5 criteria are being fulfilled. So I hope this 2-part PCPNDT and MDT is crystal clear to all of you. We have all seen these logos already. So let's move ahead from the logos. We have discussed it. Okay, this logos we have discussed. This is the logo of NCD program, health in your hand. आपका हाथ, आपका स्वास्थ्य. What does it mean, health in your hand? It means don't smoke, don't drink, and health is in your hand. The question which comes from here is that which disease is not included in NPCDCS? So NPCDCS is for 4 disease: diabetes, heart disease yani cardiovascular disease, stroke, and CDCS, cancer. Cancer, stroke, heart disease, diabetes. 4 diseases are included. Cancer, cardiovascular disease, diabetes, and stroke. 4 are included in NPCDCS full form. But SLE is also included in this NCD disease in India recently. So it's the logo say NPCDCS, which has for cancer, diabetes, cardiovascular disease, and stroke. Next thing you should know is these are some of the one more thing which you should know. There is INAP program, India Newborn Action Program. This program was launched in Congress regime just when it was going away in 2014. And at that time, have you seen this newborn care corner at PHC? Have you seen this? All of you who have visited PHC, you must have seen newborn care corner. You have seen it, but you don't know it. Because this newborn care corner is just the warmer. In the Congress regime, they changed the name of warmer and named it newborn care corner. And therefore, without spending even 1 rupees, in one night, they opened 25,000 newborn care corner all over India. Okay, so changing name and fooling people is not the new work of BJP. Congress is also doing it for a long time. So they are almost the same type of thing. So do remember, there is 1 bed only under this INAP program at PHC. We call it newborn care corner. Then they say there is 6 to 8 bed will be at CHC, and we call it newborn stabilization center. Stabilization center. Then they say there should be 12 to 16 bed at district hospital, 12 to 16 bed district hospital, and district hospital we call it special newborn care unit, SNCU. So how to remember this confusing part? It's not so tough. First is, remember 1, 6, 12. This is the number of bed. 1 is at PHC, 6 to 8 is at CHC, and then after CHC we have district hospital. So 12 is at district hospital. Okay, in this INAP program. Now at PHC, first we try to give care. So it is newborn care corner. Care is here. Care. Suppose due to giving care, you are still not able to save the child. So then we try to stabilize the child. Stabilization is at CHC. And if you are unable to stabilize the child at CHC, then he need special newborn care. So this special newborn care center is at district hospital. So it's very simple. Just say it with me. 1612 PHC CHC district hospital. Care stabilization special care. 1612 PHC CHC district hospital. Care stabilization special care. And you can remember this INAP program. In the INAP program, the logo is not here. I request you to go through Google and see the logo. In the logo, you will find that there is a bed. And in that bed, a child is sleeping. And this is the child, suppose. And this is the child. His hand of the child. This is finger of the child. Looking like finger or not? Okay, this is also the hand. This is also the finger. 1, 2, 3, 4, 5. And the child is like this. Okay. So this child sleeping on the bed, this is INAP. India Newborn Action Program. We need more bed, only then we can give them the help. So this is INAP program where we are focusing on increasing bed in different hospital setups. Okay. This is Cheer Ayu Rashtriya Bal Swasthya Karyakram, and they keep asking a lot of questions from RBSK. Rashtriya Bal Swasthya. Bal means, and how will you take care of your bal? Tel laga ke? Which bal I am talking? Not this bal or this bal. Bal means children. So this program focus on up to 12 years, but it can screen other children also. In RBSK, what we do is Ayush doctor visit school, government school. Anganwadi worker see all the children who are less than 6 years. And ASA does home visit. So all these three, Ayush, Anganwadi and ASA, they are the one who all work under RBSK, and they screen children for 4D. Now, what is this 4D? First D is developmental anomaly. How will they ask question from here? They will ask which is not included in RBSK. So they can create some extra D. First is developmental anomaly or disability. This is what we forget. Developmental anomaly or disability. Second D is defect since birth. My case, defect since birth. Congenital anomaly. Third D is disease of childhood. बचपन की गलतियां नहीं, बीमारियां. Disease of childhood. And last D is deficiency disease, like vitamin A deficiency disease, anemia, and all those things. So these are the 4D for which they screen. After screening, what they have to do is screen children for 4D, and they have to refer to DEIC. What is DEIC? District Early Intervention Center. So under RBSK program, they will do the screening and then they will refer under DEIC, District Early Intervention Center. Okay. So let me see if I have put those questions here or not. If I have put those questions, I will show you directly. No, we have not those questions. So let me tell you those questions by drawing it to you. Okay, na? The question is, yes. Let me come back to our diagram part. Yes. The question is, yes, this is the question part. So, yeah, yes. Question they ask is, if Ayush doctor is going there in RBSK, they are going only with a stethoscope. And there are total 30 diseases which come under it. So they ask which disease not screened under Ayush, under RBSK. Which disease is not screened under RBSK? कौन सी बीमारी का पता आयुष डॉक्टर नहीं लगा पाएगा आरबीएसके में? और ये बड़ा आसान है आंसर करना. आपको बस ये सोचना है कि सिर्फ स्टेथोस्कोप से जो बीमारी पता चल सकती है या आंख से देख के नंगी आंखों से, वही इसमें स्क्रीन हो पाएगी. अगर किसी भी इंस्ट्रूमेंट की जरूरत है तो वो आरबीएसके के अंडर नहीं आएगा. इफ यू नीड एनी इंस्ट्रूमेंट टू डू द स्क्रीनिंग, then that will not come under it. You can only screen for those diseases which you can see by naked eye or by stethoscope. So the first created was congenital glaucoma, congenital cataract, congenital heart valve defect, or the fourth option was congenital glaucoma, cataract, heart wall defect, or congenital retinoblastoma, which do not come under RBSK. So, of course, cataract we can see from outside. Heart wall defect, government think that Ayush doctor can listen with the stethoscope. It's the same murmur and all, which if senior asks, did you listen? You have to say yes, when you do not listen actually. So government think he can find heart wall defect and cataract by using steth and eye. In retinoblastoma also, the eye has a opacity, whiteness, which you can see from outside. You can Google and see the image of retinoblastoma. It is white thing from outside you can see. But for congenital glaucoma, you need to measure the optic nerve thickness or the eye pressure, for which we need instrument. Only 10% cases have some ophthalmos, which you can see from outside. Rest cannot be detected easily without using instruments. So this disease do not come under RBSK. Similarly, one more time, they created one option that is it zinc deficiency, is it vitamin A deficiency, is it anemia, or is it vitamin D deficiency, which do not come under RBSK. So vitamin A we can see from outside by using Bitot spot. Bitot spot is, they can give you the image also, dark brown color thing on the, you can see in the eye, dry eye, that is Bitot spot, with dark brownish deposition. Anemia we see in bulbar conjunctiva or palpebral conjunctiva. This we put down and then we see, this is for anemia. So we are palpating and seeing. So anemia is seen in palpebral conjunctiva. When I want to know the jaundice, then I see directly in your eye. So jaundice is in bulbar, anemia is in palpebral. Vitamin D deficiency, this question has came in NEET exam 2023. It can have bow leg. Second problem with vitamin D deficiency, other than bow leg, dhanush jaisa paw ho jayega, aise tune, aise like this, and the child will walk like this. That's not with hand, with leg. Second thing in vitamin D deficiency is anterior frontal. Remember this point being asked. It closes at 18 months. But due to vitamin D deficiency, it will not close and the skull will be ping pong skull. So ping pong skull will be there. Delayed eruption of teeth will be there. Rachitic rosary will be there. Barrel shaped chest will be there. Metaphyseal widening will be there and bow shaped leg. So you can detect it easily from outside. Zinc deficiency you cannot find usually from naked eye. And there is a lot of question which came from zinc deficiency. We should definitely learn zinc deficiency. A lot of recent exam question. In INICT, they have asked that if you have zinc deficiency, you can develop hypogonadism. छोटे टट्टे हो जाएंगे. और क्या कभी आपने अपने टट्टे अपने दोस्त के टट्टों से नाप के देखा है कि बा भाई तेरे बड़े टट्टे हैं, गोटे बड़े हैं तेरे, क्या नापा है? Have you ever measured the testicle size of any of your friend or any of the patient? Never. We need a orchidometer to measure it. So it cannot be seen without instrument. Second is, and this was INICT question, do remember, that's why zinc intake is very important. Okay, I myself is also taking zinc this day, not to increase it further, but zinc has also a role in decreasing hypothyroidism effect and all those things. I'm at borderline for there, so I'm taking that. So do take zinc. If your thyroid is also, TSH is rising, then also zinc is useful. Second thing which came in the NEET exam is, if you have dryness around nose and mouth, this dryness around nose and mouth is the question in NEET exam. It can be also due to zinc, but what we prescribe here, just cold cream, not zinc. So this is again second problem. The third problem which has been asked in MCI exam is, if a person have delayed wound healing, that can also be due to zinc. So this also you have to focus. Fourth thing is, there will be premature delivery which can occur with zinc. Basically, if there is zinc deficiency, it will cause acrodermatitis enteropathica. So dermatitis means dry skin, and enteropathica means loose motion and all. Your intestine will not be able to absorb any other thing. So if zinc is less, which can be less due to constipation also, your hair will fall, dry skin will be there, and hypogonadism, delayed wound healing, dryness, all these things can occur. So that is why we all should take 3 to 4 liter water per day so that there is no constipation. And if constipation is not there, zinc can be absorbed from our intestine. And you can take 3-4 liter water only if you are taking morning breakfast. Never skip morning breakfast. That is a very wrong way of starting your day. Take your morning breakfast, and if you want to sleep, sleep after that, but take your morning breakfast. That will increase the water intake to 4 liter, which will relieve constipation, and then zinc deficiency will be less. Okay, chalo, so do this question. If they give you a logo where they are showing you kite, that is adolescent program, because government think कि adolescent ही पेंचे लड़ाते हैं, पतंग उड़ाते हैं. Adolescent are the one who play kite and try to make their knot jottled. So this is adolescent program logo, and when they will give it, they will not write it, they will just give the upper part. Okay, this is the hand of Prime Minister himself. And I remember Pradhan Mantri Surakshit Matritva Abhiyaan, on which day you will take the mother, Behno or Bhaiyo, no, sorry, Bhaiyo or Behno, on 9th of September. This is PM SMA, on which on 9th we give free investigation, which is free on every day of the month. Okay. This was old program by Congress, Rashtriya Swasth Bima Yojana. It's no more, so no need to read. But this 5 lakh program is PMJ or Ayushman Bharat, about which we have read that the insurance is 5 lakh per year per family of BPL category. And it is not BPL category, it is for economically weaker section family. Okay, so EWS family, 5 lakh insurance. This is PMJ. This program is Rashtriya Vayosri Yojana for old age. And there is one new thing which is done in PMJ. They can ask it also, that PMJ also include, previously it was only for economically weaker section, but now it also include more than 70-year Indian not covered by pension or insurance. If you are not getting some pension already, then all the people who are more than 70 years, they can also get 5 lakh health insurance under PMJ. So this is one new thing which is under PMJ. In the Rashtriya Vayosri Yojana, for more than 60-year BPL senior citizen only, we give free calipers, wheelchair and all. And this is only for BPL, Rashtriya assisted living device for BPL senior citizen. But why government has removed BPL word from the poster? So that all senior citizen will think that it is for all of us and they will vote. But it is only for BPL senior citizen that government gives some free thing like free caliper, wheelchair and all. Okay, do remember it. This is the question which came in 2024 NEET. And when I was showing this logo, the student said, sir, it has both BJP and Congress in it. The lotus with the hand, this is the National Leprosy Eradication Program, because we have already eliminated leprosy in 2005. So this is for eradication of leprosy. In 2005, we eradicated it. But in 2019, government report 1.97 lakh new case of leprosy. So 2 lakh case in 2019 and eliminated in 2005. Why? Because the government put a very weird criteria for elimination. We call the leprosy is eliminated when there is less than 1 case per 10,000. Do remember this criteria they ask. Less than 1 case per 10,000 population. Then we say leprosy is eliminated. Okay. So what is the current prevalence of leprosy in India? Currently it is 0.66 per 10,000. Because India has so much huge population. So when we become less than 1 per 10,000, we say we have eliminated it in 2005. There are 3 more questions which I want to discuss from leprosy, very important. But I think those questions can be there in the pattern also, but let's discuss it together. First question is, if you are taking leprosy drug, which drug of leprosy cause hyperpigmentation? Which drug of leprosy cause hyperpigmentation? Suppose you are taking leprosy drug, your patient is taking it, not you, and some patient, और एकदम patient काला हो गया, patient develops sudden very hyperpigmentation. So which drug cause this problem? Is it clofazimine? Is it prednisolone? Is it rifampicin? Is it dapsone? Which drug cause it? That is your first question. And please do answer it in the chat box. Question second is that what is the most sensitive indicator or best indicator, you can say most sensitive, just directly say best, है ना? So best indicator, what is happening? What is happening? Yes. The question is, what is the best indicator to tell about ASA detection work? About ASA leprosy detection. आशा सही से लेप्रेसी के केस गांव में खोज रही है कि नहीं, इसको किससे सबसे बेस्ट आपको पता चलेगा? यह है दूसरा क्वेश्चन। और तीसरा क्वेश्चन क्या है? विच इज नॉट एन इंपैक्ट इंडिकेटर फॉर लेप्रेसी प्रोग्राम। किससे पता नहीं चलता है कि लेप्रेसी प्रोग्राम सही से काम कर रहा है कि नहीं? नॉट एन इंपैक्ट इंडिकेटर ऑफ लेप्रेसी प्रोग्राम। तो ये तीनों क्वेश्चन आ चुके हैं, एक एक करके आंसर देते हैं, देखते हैं आप लोग के आंसर क्या है इसके ऊपर। लास्ट क्वेश्चन ये है कि किससे लेप्रेसी प्रोग्राम के बारे में घंटा कुछ भी पता नहीं चलता है। सेकंड क्वेश्चन ये है कि किससे पता चलता है कि आशा बेस्ट काम कर रही है। और पहला क्वेश्चन ये है कि कौन सा ड्रग लेप्रेसी में हाइपर पिगमेंटेशन करेगा। तो देखिए जरा आप लोग का हाइपर पिगमेंटेशन करने के लिए आप लोगों ने डैप्सोन का नाम लिया है, बट सही आंसर है क्लोफाजाइमीन। मैंने डैप्सोन पे ज्यादा जोर इसीलिए दिया था ताकि आप कंफ्यूज हो जाएं, और कंफ्यूज होंगे तो गलत आंसर देंगे, गलत आंसर देंगे तो उसको ज्यादा अच्छा याद रखेंगे, और अच्छा याद रखेंगे तो एग्जाम में सही होगा। इसलिए रूम में अगर आप क्वेश्चन बनाने बैठे हैं और 10 में से 1 सही हुआ तो आपको खुश होना चाहिए या दुखी होना चाहिए? रूम में बैठे हैं तो खुश होना चाहिए कि आपने 9 नई चीज सीखी। गलती से अगर आप गलती करने से नहीं डरेंगे तो उसको आप सीख करके एग्जाम में अच्छा करेंगे। इसीलिए मेरा आपसे रिक्वेस्ट है कि नीट के 5 साल के क्वेश्चन देख लो, गलती कितनी भी हो रही है उसको पूरा नीट का 5 साल देख लो। अगर आपने इफ यू हैव गॉन थ्रू नीट लास्ट 5 ईयर क्वेश्चन विदाउट वरिंग अबाउट योर मिस्टेक्स, you will really get a lot of benefit in FMG exam. Minimum 50 to 80 question will come from the topics or directly also from NEET last 5 year. So do not miss that NEET 5 year if you are going to give FMG exam. Please. One request which I say again and again to all of my students. That's the only one student, do that. So it's clofazimine, which not just cause hyperpigmentation. Clofazimine also have one more side effect. Hyperpigmentation and corneal opacity. No, not corneal opacity, cataract like opacification. So lens opacification. So it can cause cataract like thing, and it can also cause hyperpigmentation. Second point, what is the best indicator whether ASA is detecting or not leprosy cases or not? देखो, percentage of cases with grade 2 disability. मान लो एक गांव से आशा ने 100 केस डिटेक्ट किए, लेकिन उस 100 में से 95 ऑलरेडी उनका पांव लेप्रेसी से खराब हो चुका था। तो अगर 100 में से 95 का पांव खराब ही हो चुका था तब जाके पता लगा, तो आशा ने क्या घंटा पता लगाया? पता तब लगाना था जब लेप्रेसी ने पांव को खराब नहीं किया। तो जितना ज्यादा ग्रेड 2 डिसेबिलिटी आएगी, इसका मतलब उतना आशा कम काम कर रही है। What I was saying in Hindi was that in a village, suppose ASA detected 100 cases, but out of 100 cases, 95 had already grade 2 disability. So it means ASA is not detecting when she need to detect, she is detecting it after disability. It means she is not working well. So grade 2 disability will tell whether ASA is working well or not. And last thing, which is not an impact of leprosy program, not an impact indicator, is percentage of multibacillary cases. देखो, paucibacillary and multibacillary, these are just 2 stage. Paucibacillary means less than 5 patch or 5 patch. Multi means 6 patch or more. तो पॉसी और मल्टी बस बीमारी का स्टेज है, उससे हमें ये नहीं पता चलता है कि लेप्रेसी प्रोग्राम सही काम कर रहा है कि नहीं, है ना? क्योंकि ये बस इसका मतलब मल्टीबैसिलरी यानी 5 से 6 से ज्यादा पैच लेकर आए हैं, पॉसी यानी 5 से कम पैच लेकर आया है ना. पॉसी जस्ट मीन्स लेस देन 5 पैचेस, मल्टी जस्ट मीन्स मोर देन 6 or 6 पैचेस. So it is just a stage of illness. It do not tell about impact of leprosy program. Okay. So these are the 3 interesting and tough questions from this topic. I think you understood it. If not, feel free to ask it again. कि सर क्या पढ़ाया आपने नहीं clear हुआ. And now I hope you already know about leprosy treatment and all. I need not to go there. But let's just have a small discussion of this thing, paucibacillary and multibacillary, because they ask it in derma also, in pharma also, in PSM also, so we should know the difference. Of course, pauci means less than or equal to 5 skin patch, skin depigmented patch. Okay, and here more than or equal to 6. But main thing is paucibacillary, we give the treatment only for 6 months. अच्छा, डॉक्टर को शर्म वाला होना चाहिए या बेशरम होना चाहिए? If a patient will come, will you remove, and he came and removed all his shirt and pant but do not remove the underwear, will you remove his underwear for leprosy examination or not? चड्डी उतारोगे कि नहीं उतारोगे? Will you remove the underwear or not? So answer is you have to remove the underwear, because let's say he have 4 patch on the body and 2 patch are in the testicular area, inguinal area, है ना? And you did not remove underwear thinking, yeah, this is usual thing, I have seen it a lot, no need to remove underwear. You can miss those 2 patch, and due to missing it, thinking there is 4 patch, you will give treatment of only 6 months. But actual treatment, because he had 6 patch, should be of 12 months. So first mistake you did was you gave half treatment. Second thing is the follow-up which we do, the follow-up is for 2 years in paucibacillary, and follow-up is for 5 years in multibacillary. So it's not only that you detected it wrong and gave half treatment, but because you have done less follow-up, so now this patient can spread leprosy to other family member. So because of your not removing the underwear, you can spread it to other family member also. Okay. So याद रखना, जिसने की शर्म उसके फूटे कर्म. Always remove the underwear. Don't sigh. If there is a patient who is girl, you need a girl attendant. लेकिन मेल का तो कहीं उतार सकते हो, कोई इज्जत नहीं है ना. मेल पेशेंट remove it anywhere, but female need female attendant. So do remember to discuss it. I hope you know, if there is a skin depigmented patch plus loss of sensation plus thickened nerve, if you found these 3 things, thickened nerve, loss of sensation, skin pigmented, depigmented skin patch, then diagnosis of leprosy is confirmed. Best is to take the skin sample and do GIT smear. But if you cannot do GIT smear in tribal area, hilly area, just by these 3 things, you can diagnose it. And which nerve get thickened most common? Most common is ulnar, because you can find it outside. Second nerve which we usually see is auriculotemporal. That was one neat question in 2018. They asked it. They gave an image of behind the ear, and they asked which nerve is passing through ear here which get thickened in leprosy. So that was auriculotemporal nerve. One is ulnar nerve also. So we have read a lot about leprosy. Let's move ahead. Let's discuss about this is Mission Indradhanush. We have already discussed. This is old program. Now we have intensified Mission Indradhanush, which cover all the vaccine preventable diseases, not only 7. This is IDSP for reporting of cases. We report it from PSC to CSC to higher center, and reporting of outbreaks should be done within 24 hours. If you found any case of cholera and all, you will report it as soon as possible within 24 hours. Chalo. This is an area where question come again and again. Step surveillance. What is this? Suppose if I ask, in Brazil there is more high risk case of diabetes, or in India, what is your answer? I don't try to answer, because you don't know which has more high risk case for diabetes, Brazil or India. So if you want to know it, you have to do step surveillance. In step surveillance, what you will do is you will take 5,000 people randomly from Brazil and randomly from India. Then you will go to their house and you will ask 3 levels of question. That's why it is a step, because it has 3 levels of question. First question which you will ask is about their psychological factor. This is first level. Psychological factor can also be known as behavioral factors. Psychological is same as behavioral. So first try to understand why are we doing step surveillance. Step surveillance हम लोग इसलिए कर रहे हैं ताकि हम पता लगा सकें कि किस देश में डायबिटीज के हाई रिस्क केसेस ज्यादा हैं. We want to compare which country has more high risk cases of diabetes and hypertension. So basically, the purpose of step surveillance is to compare the high risk population for NCD. What is the purpose? Compare the high risk population for NCD. So first we ask psychological behavioral factor. What are the psychological behavioral factor? है ना, हम लोग पूछेंगे क्या तुम दारू पीते हो, क्या तुम सुट्टा पीते हो, तुम गांजा क्यों नहीं फूकते हो, है ना. We will ask about this all, smoking, alcohol, diet and all, of course, है ना. Smoking, diet, alcohol, these are the psychological thing. Of course, stress can also be there, but it's difficult to measure, so we don't ask. After psychological, we try to get physical. We ask physical factor. So the second component is physical factor. Don't get physical, just ask it. So what are the physical factor which can cause a high risk for diabetes and all? Of course, the physical factor can be BP, can be BMI, can be age. If age is more than 65 years, that's an independent risk factor. So these three are physical. Last is the hormonal or biological. So in hormonal or biological, India only measure random blood sugar. But developed country, US, UK, they also measure thyroid profile. They also measure, of course, random blood sugar and lipid profile they also measure. So from the step surveillance, one question has came in MCI exam 2 years back and one also in NEET exam. The question in NEET exam is, which is not a factor included in the step surveillance? Hormonal, biological, behavioral or therapeutic? So remember, in a step surveillance, therapeutic factor not included. Actually, if you see, based on lipid profile and thyroid profile, we can start the treatment also. And therapeutic means those investigation based on which we start treatment. So why I am saying therapeutic factor not included? Because the purpose of thyroid and lipid profile done here is not to start treatment. The purpose is to compare high risk case. So we are not starting treatment based on it. We are just comparing India has more high risk case of diabetes or Brazil. So therapeutic factor not included. Second question which was there came from this topic was, which test is not done? Acha, first tell me, how will you remember all the factor? Because they can change the option. So how will you remember all the factor? To remember all the factor, you can use the mnemonic BPS, BPH. It's not benign paroxysmal hyperplasia. दो बम पे एक हाथ, है ना. Make such a mnemonic which you never forget. Two bum, one hand. Two bum पे एक हाथ. दो bum पे एक हाथ. Two bum पे means on one hand. What are the 2B? Behavioral, biological. These are the 2B. What are the 2P? Physical, psychological. What is H? Hormonal. Two bum पे one hand. The question in MCI exam from this topic was, which test is not done under step surveillance? So the test we can remember by the mnemonic, one student suggested me BTR love, where L stand for lipid profile, R for RBS, T for thyroid profile, and B is for BP and BMI. So what are the tests which we do in step surveillance? BTR love, BP, BMI, thyroid profile, RBS, and lipid profile. Like that you can remember. Okay. So do remember this confusing area, but you can now, I think, do it well. Next question is, there is a student, Chiranjeevi Das. His full name is Chiranjeevi Das 1769. Very good. 69 lover is there. He said कि सर टट्टे नापे हैं मैंने दोस्त के. क्या बात है चिरंजीवी, सलाम है तुम्हारे इस जज्बे को. दोस्त के टट्टे नाप दिए, वाह क्या बात है, वेरी गुड, रिस्पेक्ट, वेरी गुड. Don't come near me, okay? Chalo, focus. I love you. Focus is, this is Beti Bachao, Beti Padhao. And this program is only for awareness. Awareness to decrease female feticide and to improve their female education. But it is just awareness program. No fund for female education, no fund for dowry control, just awareness behind truck and all, just awareness. You know? This is the question which can come, Niti Aayog question. First thing is, what is the full form of Niti Aayog, they ask. So Niti Aayog full form is National Institution. N is national, of course. I is institution. Main confusion is in T. So it is National Institute for Transforming India. Remember, T is for Transforming India. The second question which came from this part is that which organization it replaced. So it replaced National Planning Commission. See, from 1950 till 2014, when the Congress government was mainly there, they had the planning commission and it has all corrupt people of Congress in it. So when BJP came into power, they said, hey, all you corrupt people of Congress, go away. Now our corrupt people will work. And they replaced Niti Aayog, Planning Commission with Niti Aayog. So remember, Planning Commission replaced by Niti Aayog. Now a recent question came, what is the work of Niti Aayog? So the main work of Niti Aayog is that Niti Aayog is something which gives technical advices to government. And on which topic it gives technical advices? That how can we increase private partnership in government places? How can we do technical advices to government for capacity building? You know, these are big word. Actually, सरकारी चीजों को कैसे बेचा जाए, है ना? How to sell government thing to private. This is the main area of suggestion of Niti Aayog. So it gives technical advices to government for capacity building. Capacity building means training and how to make it capable of using more resources. So that's capacity building. So remember, it gives technical advices for capacity building and growth. Okay. But Niti Aayog do not give any suggestion about referral service complex and all. It just gives technical advices for to government for capacity building and growth using private partnership. Okay. So it is promoting private partnership in government organization, partnership, and giving technical advices. So it is basically, they call Niti Aayog as a think tank. They think and then they blast the government itself. Oh, sorry. They think and then they give the advice to the government that how we can have capacity building and upgradation of government system. Okay. So this is Niti Aayog. Do remember. Next question is, this is the, oh, I have written it, man. Shit. And it does not deal with referral service complex. It acts as think tank and give technical advices to government. Okay. Now, this was one life cycle of hydrated cyst, and they have asked, where is the adult form of hydrated cyst is there? So adult form is the one which have the sex part of the life cycle. So adult form characteristic is adult do sex. So the sexual stage or adult form is in dog. Remember, for hydrated cyst, it's not sip or human, it's the dog who have the adult form. So this question come in micro also. This is actually a combined area. That's why very important that human, they are usually the definitive main host. Main host means in which parasite do sex is the main host. But human act as intermediate host. Intermediate host means asexual cycle of parasite. If there is asexual cycle of parasite, then it is intermediate host. So human act as intermediate host. Intermediate ko, there is one more name for intermediate, facultative. So human act as facultative or intermediate host in three diseases. What are those three diseases? One is hydrated cyst, other is toxoplasmosis, and last is malaria. And in these three, they ask, who is the main host? Main host means in which the sexual part of life cycle occur. Main host means adult or sexual stage. So adult or sexual stage, we just read that in case of hydrated cyst, it is in dog. In case of toxoplasmosis, it is in cat. And we all know in case of malaria, it is in Plasmodium. Okay. So these are the three: dog, cat, Plasmodium, who have the adult or sexual stage. And there was an Indian doctor in Kolkata, Dr. Ronald Ross, who find that Plasmodium have the sexual stage. Mosquito have the sexual stage. So it should not be written Plasmodium here. I have written it wrong. It's who have the sexual stage. Sexual stage of Plasmodium is in mosquito. So mosquito have the sexual stage. This was detected by Ronald Ross. And Plasmodium caused the problem. Plasmodium is the pathogen. This was found by Charles Lavren. So Plasmodium problem, Lavren, and Ronald Ross found that mosquito is the main host. Remember, for these three, the main host is dog, cat, and mosquito. Next is this. Is life cycle of which disease? Is it plague? Is it leptospirosis? Or is it endemic typhus? This is a question for you. This life cycle is for plague, hydrated cyst, endemic typhus, or leptospirosis. What is the answer? So if you can see, can you answer it? Please do try to answer. If you can see the urine, rat urine, this rat urine definitely indicate leptospirosis. And leptospirosis go through rat urine. And there were two questions on the leptospirosis. One in last to last NEET exam, that if a patient have conjunctival suffusion, आंखें लाल हो गई हैं एकदम वैसे जैसे गांजा फूक के हो जाती है. Conjunctival suffusion, redness of eye just like after marijuana smoking, or plus calf muscle pain. This is a sure short sign of leptospirosis. Second question was, when leptospirosis occur after Kerala flood, then government distributed diethyl carbamazepine. Nahin, government distributed doxycycline. Doxycycline is used for chemoprophylaxis, for preventing other from leptospirosis. If there is a cholera, of course, rat urine and other urine are in the water, cholera and leptospirosis time. So we can give doxycycline for chemoprophylaxis in leptospirosis. The question was, along with doxycycline, which other thing was distributed? Was it malathion? Was it zinc phosphide? So a very good app has also answered malathion. But malathion is for mosquito killing. And the problem is occurring with rat. So malathion will not work here. The correct answer is doxycycline plus zinc phosphide. Why zinc phosphide? Because zinc phosphide is a rodenticide. And in the explanation, they have written also that it's a rodenticide, it's a rat killer. So if it is a rodenticide, it should be used, not malathion. So remember, zinc phosphide is the one which should be distributed for chemoprophylaxis in area which are affected by flood. Okay. If you talk about cholera, remember, for cholera, of course, one thing is how we diagnose the cholera by making the stool sample through either rectal swab or by putting the soft latex tube inside the rectal areas and then collecting the sample. It is carried by Venkat Raman medium or peptone, alkaline peptone water medium. And then this Alkaline peptone water or VR medium in which we store the sample is taken to the lab, where alkaline tellurite peptone help in enrichment, growth of cholera bacilli, and then we can grow it in TCBS agar medium. So next is alkaline tellurite peptone medium, peptone water for enrichment, and then there is TCBS agar media where we grow it. So cholera is also a common disease like leptospirosis during flood, but during Kerala and Mumbai flood, it was more common leptospirosis which was found. And of course, for cholera, chemoprophylaxis is not useful because it has been found that we need to give the chemoprophylaxis drug to 10,000 people, then only one case of cholera can be prevented. So it's very difficult to prevent cholera by giving medicine to all the people. Chemoprophylaxis is not indicated by WHO for cholera. One common question which they ask from this part is that if you have gone to flood affected areas, which vaccines should you give or which vaccines should not be given? Remember, no vaccine given to general population, no new vaccine. Of course, the vaccination of children will continue, but no new vaccine given during flood or during disaster. But 3 vaccine, which is remembered by TTC, tetanus, typhoid, cholera. These 3 vaccine only, tetanus, typhoid, cholera, can be given to health workforce. If you are part of health team like doctor and all, then you can get these 3 vaccine. But to general population, we never give any vaccine during disaster. To general population, no new vaccine is given. But to health team, we can give tetanus, typhoid, cholera vaccine. Okay. So I hope you will remember it. Next question is, next part we have to know is the life cycle of Japanese encephalitis. In case of JE, remember human are the dead end host, because if a Culex will bite me and then bite Nikhil who is with me in this room, then JE will not go from me to Nikhil because I am the dead end host. It will stop at me. Main question is, who is the reservoir? Reservoir means those who store it in the non-rainy season. So remember this point that ardid bud or heroin, these are the reservoir. जब बरसात का मौसम नहीं होता है तो इनके अंदर वो स्टोर रहता है, तो रिजर्वायर को ही कहते हैं मेंटेनेंस होस्ट. सो रिजर्वायर और मेंटेनेंस होस्ट इज ardid bud or heroin bud, human are dead end host, and pig are amplifier. तो मैं सोचता भी था कि पिग जेई वायरस के लिए गाता होगा कि मैं तेरा एम्पलीफायर हूं ना, है ना. पिग मस्ट बी सिंगिंग दिस सॉन्ग फॉर जेई वायरस की I am your amplifier. Yeah, so this is the amplifier. Human are dead end host, and this is reservoir. Do remember one question that when Culex transmit JE, it transmitted through transovarian transmission. It means from the genital part of Culex, it can go to the egg of Culex also. So transovarian transmission is by Culex, and pig and ardid bud are the main part of it. Pig is the amplifier, ardid bud is the reservoir or maintenance host. Okay, so these are the part which I was discussing from, of course, the health programs, the images and everything. But let's also do some more question. If a traveler is with fever, loose stool and abdominal pain on 4th day, what will you do on 4th day? So because he is loose stool, abdominal pain and all, he is having typhoid. And for typhoid, this was the NEET question last year. So that's why I have put it here, last to last year. For typhoid, I hope you know, we do BASU. B means blood investigation, which is done in 1st week. And here the patient came at 4 days, so we have to do blood. A means antibody or serum detection, which is done in 2nd week. So in 2nd week, antibody detection is done. Antibody detection means Vidal test. And in the Vidal test, we are using O and H. So remember, O is indicating, O is more important. O titer is more important because H indicate immunity. H indicate past infection, indicate immunity or past infection. Okay. These are the various antigen. O indicate immunity or past infection, so it's not so important. O antigen is more important. It is one which is showing. Then S is for stool culture, which we do in the 3rd week, and U is for urine culture, which we do in the 4th week. So like this, 3rd, 4th can be answered. Okay. For typhoid, what is the drug of choice? That is ciprofloxacin. They have not written it directly in part, but they have used the word fluoroquinolone is the drug of is the first drug when we talk about treatment. And if you want to give something for chemoprophylaxis, for preventing other people who are in contact with typhoid patient, chemoprophylaxis is also by the same drug, ciprofloxacin. So ciprofloxacin is the chemoprophylaxis and ciprofloxacin is the drug of choice here for typhoid. Now, on the 5th day, a patient have retroorbital pain, pain behind eye, bone pain, and headache, frontal headache. So if any patient have retroorbital pain, pain behind eye, frontal headache, and retroorbital pain, what is the diagnosis here? What the patient is suffering from? Remember, this is the clear-cut diagnosis of dengue. And if there is dengue, in dengue, on 5th day, which test we will do? This is the question. Remember my point. In dengue, for 1 to 4 days of fever, we do NS1 antigen test. समझो बड़ा आसान है समझना. पहले 4 दिन डेंगू का जो प्रोटीन है वो हमारे ब्लड में घूमता हुआ पाया जाएगा. 4 दिन के बाद वो डाइल्यूट होने लगेगा. तो 4 दिन के बाद एंटीजन यानी बाहर का फॉरेन मटेरियल कैसे पता लगेगा? नहीं पता लगेगा. Only up to first 4 days we can detect the NS1 antigen, which is the foreign particle and which is circulating in the blood. After 4 days, it will get dilute, so we cannot detect it. So what you will detect on 5th day? 5th day onward, we will use this detection of IgM antibody test. If they ask which test we do for chikungunya, which test we do for JE, which test, mostly the answer is IgM antibody test. Okay, this is a very common test done in many of the viral illnesses because our antibody is one thing which we can find out through this test. So remember, on 5th day, which test? 5th day, IgM antibody test. Up to 4 day, NS1 antigen test. These are the questions in recent NEET from this topic, so I am discussing it. Now, a question is from malaria treatment, which we should know. If there is a pregnant female with Vivax in infection, not injection, what is the drug of choice? Can you answer it? I wish you can answer it. Yes, very good. Some student answered NS1. No, that was IgM. For 5th day, IgM. What will you give here? Pregnant female with Vivax infection, drug of choice will be. See, one thing is artesunate is contraindicated in first trimester of pregnancy. In first trimester of pregnancy, what we give? We give quinine. And there's a very close friend of mine, Ankur Jain, who is biochemistry faculty at one of the good coaching institute. He used to teach double MD in psychiatry and biochemistry also. And we used to do this Chote Miya Bade Miya episode, and he used to tell me this mnemonic that in the first trimester we should keep the mother as queen. So which drug we will give in the first trimester? Quinine. But quinine is the one which is for Plasmodium falciparum. For Vivax, we have to use chloroquine. Chloroquine plus primaquine is again which is the thing which we cannot give, because this primaquine is contraindicated in pregnancy. It is also contraindicated in infant less than 1 year and contraindicated in G6PD deficiency. So remember, my dear friend, answer is chloroquine plus primaquine if it is not pregnant and Plasmodium vivax. If you remove pregnant and only Plasmodium vivax, then answer will be B. But because pregnant is there, answer is chloroquine. Why not artesunate? Because it is for falciparum plus artesunate is something which we don't give in the first trimester, and here trimester is not given, so we will not write that. Why not quinine? Because quinine is for falciparum. So the correct answer is A, chloroquine. It's a confusing one, but most of you, including Patel Raj, Mohit Kumar, Dr. Doom, Wabhav, Saurav Khan, and Suham Patel, all of you answered it. Very good. Now, I also want you to discuss a complex question here, which came in NEET PG last year. The question was, patient has mixed infection. Mixed infection means he has Vivax plus falciparum both. On second day, what is the treatment which you will give? So on second day, there were 4 options. I'm not going to create that, but just write the option. Because he has mixed infection, we treat mixed infection as falciparum. And in falciparum, the drug of choice is artesunate. So on second day, we will give tablet artesunate. But how much we give, that also they have asked. So and they have written 50 kg patient. So weight was 50 kg. Artesunate is 4 mg per kg. So 4 into 50. So how much artesunate we give? 50 mg 4 tablet on day 2. Plus, on day 2, we also give primaquine. Now, when we give primaquine, the dose of artesunate is 4 mg per kg. So it's simple. Multiply body weight with 4, that is artesunate. Dose of primaquine in Vivax is 0.25 mg per kg. And I hope you know, in Vivax, there is relapsing fever because it hide in liver and then come out in blood. Whenever it come out in blood, after some day, there is again a spike of fever. So the relapsing fever is in Vivax, and therefore, here primaquine is given for 14 days to kill it, and we have to give primaquine for 14 days here because it's a mixed infection and Vivax can go in the liver. Here artesunate is given according to falciparum, and artesunate is the drug of choice for falciparum. But in northeastern state, what is the drug of choice for northeastern states? In northeastern state, we give artemether plus lumefantrine. And they have asked in INICT 1 exam, what is the dose ratio of artemether plus lumefantrine? Just 2 years back. So the dose ratio is, if we give artemether 20 milligram, we will give lumefantrine 120 milligram. So the dose ratio between them is 1:6, artemether lumefantrine. And when we are giving primaquine, we have to give it according to Vivax 0.25 mg per kg. Kg is 50. So 50 into 0.25, if you will do, it will come 12.5. So 12.5 was written as 2.5 mg 5 tablet. So it become 12.5. Total dose is 12.5. So remember, that was the answer which was there in the NEET exam just in 2024. So we should know this day 2 treatment of mixed infection, and we should know we give artemether plus lumefantrine in northeastern state for falciparum. Let me add 3 more points here. First thing is, if there is there is RDT kit, which is histidine rich RDT kit. So the question in NEET exam was that this histidine rich RDT kit, does it detect falciparum, Vivax, or both? So when there is Plasmodium falciparum infection, it can cause renal failure, can cause cerebral malaria, patient can die and become hystery. So remember, histidine rich RDT kit, only Plasmodium falciparum detection is by RDT histidine kit. If we want to detect falciparum plus Vivax, we use optimal kit. So Plasmodium falciparum detection is by histidine rich RDT kit. Plasmodium Vivax plus falciparum by optimal kit. And in optimal kit, what is the enzyme which we have? Lactate dehydrogenase enzyme. Because they have asked the question from histidine, they can ask here also lactate dehydrogenase enzyme. Now, my question was, that let's say one of my friend, suppose Mr. Saurabh Khan, he went to Nagaland and to meet his girlfriend there. And when Saurabh was doing gulu 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 gulu, a mosquito came and bite in some part of Dr. Saurabh Khan. I don't know where. I will not tell where, but some part he bite. So now, if a patient is, suppose Dr. Saurabh Khan is from Delhi, and patient from Delhi went to Assam or Nagaland or anywhere, but mostly they use Assam, went to Assam and developed falciparum. So, what is the drug which we will give? Which drug will you give? What is the drug of choice? Because he is going to Assam, and in Assam we don't use artesunate, we use artemether. So what is the drug we give? Artemether plus lumefantrine in dose ratio of 1:6. Now suppose Dr. Shoaib Khan did so well guli guli that the girl came to Delhi to meet her, and now that girl, patient from Assam, came to Delhi and developed falciparum. So now which drug has to be given? Again, the same drug, artemether, will be given, because if she is coming from Assam, she might be carrying the resistant strain. So in any question, if you found the name of northeastern state, whether coming or going doesn't matter, drug of choice will become artemether plus lumefantrine. Okay, so these are the question which I wanted to discuss here from this part. Let's also discuss this TB program some question. 24 March is celebrated as TB Day in India, and India target was to eliminate TB by 2025. The target which is for SDG, those are the same target in TB program. So whatever is 2030 target, that is same 2025 target. You only have to remember these 2 points. Very easy actually. See, first thing is zero catastrophic expenditure, so it should be zero. क्या होता है कैटेस्ट्रॉफिक एक्सपेंडिचर? इतना पैसा खर्च हो कि चड्डी फट जाए, है ना? So much of money expenses that if the person is from lower socioeconomic class, his underwear will rupture, means he will become very poor. If I am from middle class, suppose, and I develop TB, and due to TB expenses, my socioeconomic status decrease one level. From middle class, I become lower middle. That is catastrophic expenditure, and it should be zero. Second point is, what is easy to reduce in TB? Death is easy to reduce, or new case is easy to reduce? Remember, new case of TB is mostly due to malnutrition and immunocompromised condition, mostly due to malnutrition. And you know, malnutrition is not easy to decrease. So death we can decrease easily by giving good hospital. So for mortality decrease, the target is 90%. For new case decrease, the target is 80%. Just remember this, 90-80. Death 90, new case by 80. Same target is for SDG, 90 and 80. If you talk about in TB, which they will never ask, then this target become 95 and 90. But mainly focus 90-80. Death by 90 and new case decrease by 80. 90-80. Death 90, new case 80. Second point is, the government of India is putting this TB health visitor, one TB health visitor per lakh population. Of course, he will be doing which type of surveillance? He will be going in the slum area and taking the sputum sample from the poor people of slum. So health team is going and searching. It is active case detection. Remember, we discussed this point. And active case detection is for hidden case. So for hidden cases, he will do this detection. This is one new work done. Second thing is, we the doctors, you all people, you are the one who are the provider of TB drug. So for you people, government had said, if any patient will come with HIV, corona or diabetes, you have to ask about 4 symptoms. है ना? What are the 4 symptoms? First question you will ask is, रात में पसीने छूटते हैं क्या? You will ask about night sweating. Second question you will ask is, कपड़े ढीले हो गए हैं क्या? Do you have significant weight loss? And we actually ask this question not with the same expression, but we do ask these two questions. Night sweating, significant weight loss. Then we ask, क्या आपके बबलगम में खून है? Hemoptysis, है ना? Blood in sputum. And last question, क्या आपकी खांसी 2 हफ्ते से ज्यादा है? Do you have cough for more than 2 weeks? So we ask this 4 questions, and if any one of the 4 is positive, we directly send patient sample for CB-NAT. So this was the question which came in MCI exam 2.5 years back, that in a case of HIV, what is the first investigation which you will write? So if the patient have HIV, first investigation will be CB-NAT. There are 5 scenarios where we don't do ZN smear, we directly do CB-NAT. What are those 5 scenarios you have to remember? First is corona, HIV, and then diabetes. These 3 we already remember. Diabetes, COVID, HIV, directly CB-NAT. 2 more are, one is previously treated TB. Because if the TB is previously treated, he can have resistant type of TB. And this is the benefit of CB-NAT. It not only detect the bacteria, it also detect rifampicin resistance. So that's why we will directly do CB-NAT to check whether he have resistant, rifampicin resistant or not. And last case is pediatric TB suspect. Why? Because you know kids. बच्चों को बोलोगे कि थूक दो, मुद देंगे, मुद दो, थूक देंगे. And when you ask the child to urinate, he will spit. When you ask him to spit, he will urinate. So it's very difficult to collect pediatric sample. Sometimes we have to do gastric lavage to collect 1 ml, 2 ml sputum sample. So if the sample is collected with so difficulty, why to waste it on ZN smear? Why not directly do CB-NAT? So remember, in 5 we directly do CB-NAT: HIV, diabetes, corona, pediatric, and previously treated TB. Now one question which keep coming again and again is that we do 2 sputum sample. I hope you all know. First is the spot, we level it as capital B, capital A. Next is early morning, we measure it at capital B. And anyone came positive, we start treatment under lab confirmed. But the question they ask is that patient with 2 ZN smear negative report, but X-ray suggestive of TB. You did ZN smear 2 times, both came negative, but X-ray have TB symptom. So what is the next test you will do? 2 times PYQ of NEET exam. The next test which we do is CB-NAT, not start treatment under clinically confirmed. No, we will send the patient for CB-NAT. If ZN smear is coming negative again and again 2 times and X-ray has some suggestion, then we will send the patient for CB-NAT. Okay. Now, there is a lot to be taught in PSM, and PSM revision can never be finished in 4 hours. But my time has ended, and I can take one more session of 4 hours. I'm still not sure whether I will be able to finish PSM in that next 4 or not, but I will create a new type of compiling PDF, and I will take one more session of 4 hours in which I will try to finish the remaining of the topic. But my dear friend, always remember, it's always more fruitful if you do PYQ practice yourself, not through videos, and don't keep revising theory just again and again. By doing question only, your recall ability will develop. And the exam are never testing your intelligence or smartness. They are just testing that under exam pressure, can you recall or not? And if you are not doing question by yourself, you will not be able to recall. So don't be scared of doing mistake. Keep doing minimum 100 to 200 question, 300 question also at your home. PYQ question mostly, because those are the topic from which question come. And if your senior is telling PYQ don't come, they are bullshitting with you. And they are telling the false thing. Why senior say such thing? Because in exam, when PYQ come, we do it quickly. When new question come, we get stuck there. So after coming out from exam, when somebody asks, did PYQ come? They will answer no, because they did easily. They were stuck in the hard question. So they will say all the question are new and hard. But ask it from those who had done well and passed well. They will tell you that yes, previous year question do come, especially NEET PG is very important to do, because in FMG session occur in 2 exams. So after 1 exam, no one recall, and after 2nd exam, you are tired and go for party, and after party, who can recall? So in FMG, every time when recall occur, you must be seeing in the chat that the students say, what are you teaching? This did not came. Because in FMG, we can only get the topic, not the real language. But in NEET PG, exam occur in one session, and even teachers like me sometimes go and give the exam. So we get the exact language. So if you want to know the exact language of exam, practice NEET PG, not FMG PYQ. Practice NEET PG. Second thing is, FMG and NEET PG are both prepared by the same board. So their question do get exchanged. So do not, please, this is one request as a friend, as a brother, as a teacher, whatever you see, please do last 5-year NEET PG, PYQ and revise. Please do it and revise it. This is very important to do and revise. It will help you in clearing this exam in this attempt only. And don't be stressed out just because in this exams, PYQ also you are revising theory. It's not that your time is getting wasted there. In the topic, you are reading the theory also. So do this 5-year of NEET also. I know you have done FMG, but also do NEET. This will really boost your score. If you are getting 110, 20 now, you will start getting 50, 60 if you would do just 5-year of NEET with topic. But remember, NEET PYQ revision with topic, not just mugging up the question. That Donald is there, so hepatitis will be answered. No, and just understand the whole topic and you will get it cleared. So I will take one more session. If you have any question, any query, any suggestion, feel free to share it with me on my WhatsApp number or on PW Meded Telegram group also. You can ask the question and you can connect with me there also. So thank you so much for this session. I'm ending my session here because one more teacher session is scheduled after me. But I will take one more session of 4 hours within this week. Okay, I will plan it and will let you know. So love you all, and I will definitely send the annotated PDF in this. That will be shared with you, and I don't know how, but it will be shared with you. And my number is there. If you do not get it, you can always connect with me. Thank you so much. One question is from Vaibhav, sir. Delayed immunization and open vial policy ka bata do. Why not, Vaibhav? You are a very sincere friend. You are answering since the beginning time. I will anyway fulfill any of your demand. Your wish is my command. First is open vial policy. This is very common area of question. Open vial policy, I hope you know that you open some vaccine vial, but even after opening, for next 4 weeks, you can use it if you stored it adequately between 2 to 8 degrees Celsius. Main question is which vaccine we can use up to 4 weeks, which we have to throw. And Park clearly write that there are 8 vaccines which follow open vial policy. So either you remember the 8 or you just say it with me and remember them in short form. Say it with me. Hep B, PCV, all tetanus, all polio. Say it. Hep B, PCV, all tetanus, all polio. These are the 4 which follow open vial policy. When I say Hep B, PCV, this is clear. All tetanus include pentavalent. It include DPT, it include DT, and it include TT. So this is all tetanus. And all polio means 2 things, OPV and IPV, FIPV, not FUCT, it's fractional IPV. So these are the vaccine which follow open vial policy. The question which came in INICT and then repeated in NEET was that in a session you have pentavalent and MMR both opened, which you will keep in the next session, which you will throw. Pentavalent we can keep because pentavalent is the one which is following open vial policy. Keep up to 4 weeks if stored between 2 to 8 degrees Celsius. So pentavalent we keep and rest all we throw. One very good teacher said ki rotavirus also follow open vial policy. No, never. Only these are written, and Park has clearly written rota do not follow open vial policy. Actually, they are talking with US UK guideline, and we have to follow Indian guideline which is given in Park. So focus here on Park, and remember pentavalent rotavirus do not follow open vial policy. Okay, that's a wrong information shared. So this is one thing, open vial. Second thing you want to know, delayed immunization. Okay, yes. I can discuss that topic also. What do you mean by delayed immunization? Delayed immunization has three type of question actually. First question is कि a child took 5 vaccines at 6 weeks. What are the 5 vaccines which we give at 6 weeks? OPV rota penta, FIPV PCV. OPV rota penta, FIPV PCV. These are the 5 we give. And this 5 vaccine, OPV rota penta, we continue at 6, 10, 14, 3 times. And at 6 week, 10 week, 14 week, we give OPV rota penta. 6, 10, 14. We will discuss the immunization topic in detail separately on the second session, where I will discuss it again, the vaccination schedule. So 6, 10, 14 we give OPD rota penta, and at 6 and 14, 2 we give FIPV PCV. So FIPV PCV 6, 14 और तुम्हें जानते हो 14 के बाद 9 महीना. So 6, 14, 9 महीना पे 6, 14 and 9 month we give FIPV PCV. FIPV PCV is not given at 10 week. Okay. Now a child took 5 vaccine at 6 week and came back after 5 months. So he is coming after 5 months. That means he is now 6.5 months of age. Next, what will you do? First thing is option A, will you restart from first? B, will you give rota plus penta plus OPV, all three which we give at 10? C, will you give penta and OPV only, not rota? Or D, will you give 9-month vaccine? Will you ask to come at 9 month? है ना, बोलोगे लिबी. है ना, now you have missed, asked to come at 9 month. What will you do next? Because he had missed or delayed the vaccination here. So here, do remember, what is the answer? I am expecting your answer in the chat box. Please do reply. Do remember one thing about rotavirus. Rotavirus not given after 6 months. And here the child is coming at 6.5 months. So we will give penta and OPV, but we will not give rota. Because Park has also written it, rotavirus not given after 6 months. So what we will give penta and OPV only. And remember this point, that if child came back within 1 year of last dose, है ना? Don't restart. If the child came within 1 year, like in 5 months he came back, then we don't restart. We continue with the remaining dose, whatever it is. Like here, we continue with OPV and penta. We don't give rota because we don't give rota after 6 months. Remember this one more point here, and then I will ask you one more question about delayed immunization. The point is BCG, then penta, FIPV, and rota. All these 4 not given after 1 year of age. So if the child is more than 1 year of age and came at 2 year, 3 year, and he has more than 1 year of age, you will not give BCG, penta, FIPV, rota. Rota you will not give after 6 months also. So after 1 year also you cannot give it. Remember, these 4 we don't give. If the child come with delayed immunization, we will not give these 4. So now how they will ask question from this topic? They will ask question like this, that a child of 1.5 year came with no history of vaccination. Directly jungle se nikal ke aa gaya, hula ho, and it directly came from forest. There is no history of vaccination in past. Okay, so what will you give? This child of 1.5 year came with no history of vaccination, have 7 kg weight. So the weight is 7 kg. What will you give in this child? Option A, give BCG. Option B, give vitamin A 1 lakh international unit. Option C, give vitamin A 2 lakh international unit. Or option D, give FIPV. What is the answer? See, first thing is for sure, and C is not the answer. C means let's see. I am waiting for you to give answer also. Dekhna zara. Okay. First thing is sure कि BCG, FIPV, Rota, Penta, these four can never be given because age is more than 1 year. So option A and D is gone. Okay. Answer can only be 1 lakh or 2 lakh. What is the correct answer? 1 lakh or 2 lakh? What will you give? The class is confused. Krishnakant is Patel Raj, Jack Rose, Vaibhav, Gauri, Saha, Bachcha Yadav, Subham Patel, all are giving an answer. Shyam Patalia is also giving the answer. The correct answer is definitely given by Vaibhav and Krishnakant, and now Parul Patel also. B. Give 1 lakh, not 2 lakh. We give 2 lakh after 1 year, but only if the weight of the child is more than 8 kg. Weight is 7 kg. So if weight is 7 kg, we give 1 lakh international unit vitamin A. 2 lakh we give only if the weight is more than 8 kg. Okay. So remember, for 2 lakh, weight should be more than 8 kg or equal to 8 kg. If it is less than 8 kg, we just give 1 lakh. So the correct answer is B. It was a confusing question, but I hope it will help you. Yes. So do not hesitate to ask your question to me, and I will take the session of the remaining topic within a week of more 4 hours. And then I will also try to guess the expected question by some expected question one series where I will try to guess the question for your upcoming FMG exam, which I am doing for last 4 or 5 years, and I am sure that these are the topics through which question will come. So usually those topics are being covered again and again, and it's very easy to guess. Whatever come in last 5 years of NEET, 2-3 years of INICT, and 2-3 years of FMG, they will take the question mostly from those topics. So do that question for sure. Revise those recent year question for sure. Love you all. Thank you so much. Hasta la vista. Dasvidania. Baka baka. We'll meet soon. Okay. Thank you so much. Thank you. Love you all. Enjoy the journey. Okay. Bye.
Hello students, a very good afternoon. We have an FMG exam right around the corner. Hello everyone. And this is going to be a rapid fire session, one short session where we are going to discuss all the MCQs and all the pointers that the examiners are very fond of asking. Right, so I have designed this workbook in such a way that majority of the pediatrics is done. As far as pediatrics is considered, the FMG exam, they're very straightforward. They rarely do any tough questions. If any tough question they give out of NRP that we are going to discuss in a lot of detail. Right, so the session would be in such a format that firstly we will discuss the general pediatrics, which is the major chunk of pediatrics, and after that we will cover neonatology and subsequently systemic pediatrics. In neonatology, one important topic that I would like all of you to read and revise before the exam is NRP, neonatal resuscitation protocol, because examiners are very fond of asking that, right? Hello Parul, hello Sham Suzaman. So without further ado, let's start. So firstly, general pediatrics. In general pediatrics, one question, short. This session would be around 2 to 2.5 hours maximum. I'll try to wrap this up as soon as possible for you, make this as simplified and as short for you. Right, so growth curves, let's start. So we have 4 curves over here. What are these? These are growth curves, also known as Scammon curves. Scammon curves, right? Different tissues in our body, different tissues, अलग अलग टाइप के टिश्यूज हमारी बॉडी में अलग अलग रेट से ग्रो करते हैं, राइट? तो उन्हीं को डिपिक्ट करता है कि ग्रोथ कर्व, स्कैमन कर्व्स, राइट? दीज कर्व्स डिपिक्ट different growth rates of different tissues in our body. So let's look at this graph A. What is this graph A telling me? This graph A is telling me that this tissue grows maximum 90% in the first 2 years of life. Thereafter, there is little to no growth. What is this? This is nothing but your head, your brain growth. Maximum happens during brain or neural growth. Maximal happens during the first 2 years of life. Thereafter, there is little to no growth. Let's look at this curve B. What is happening over here? Firstly, this tissue is growing very rapidly. Then there is almost a stagnation. Then again, around 10 to 12 years of age, there is rapid growth. So what is this? This is nothing but somatic growth, our bodily growth. In the initial years of life, the weight triples, doubles, right? And thereafter there is a stagnation phase, and then when you reach puberty, again there is growth spurt. So this is somatic growth. And what is this shape? This is sigmoid shape. So remember, sigmoid growth curve is for somatic growth curve or skeleton growth curve, right? Let's look at C. What is C? C, little or no growth till 10 to 12 years of age, and then there is sudden rapid growth. What is this? This is for sexual or gonadal growth, right? Pre-puberty, there is no gonadal growth. After that, there is, so this is depicting gonadal growth. And lastly, we have this where you see there is a peak in between 4 to 8 years of age. Before that, there is no such tissue. After that, also no such tissue. This is for lymphoid, right? So very favorite question of examiner. They can also ask one-liner type, that sigmoid shape growth curve is seen in somatic growth, or they give you a picture and ask you which growth is for which tissue, or they can also give match the following type of question. So this growth curve is very important, right? Let's move to the normal growth pattern. Firstly, let's talk about weight of the baby. So what is the average weight at birth term in India? Can anyone tell me? What is the average birth at weight, birth weight of a term baby in India? It's nothing but 3 kgs. And as soon as the baby is born, just after that, the baby does not gain weight. initially there is loss of weight. This is known as physiological weight loss. And how much weight loss is there? Up to 10% weight loss is there. This happens in the first 7 days of life. First 7 days of life. And they ask, when is the birth weight regained? Birth weight regained by day 10. Day 10. So 10% loss regained by day 10. Right? So there is a ready reckoner that they are very fond of asking in the exam. Yes, Harsh Rawat is correct. Gautam is also correct. So birth weight, ready reckoner. So if say birth weight is X of a child, then when will it double? Sorry, it will double at 5 months of age, triple at triple at 1 year of age, 4 times at 2 years of age, 5 times at 3 years of age, 6 times at 5 years of age, and 7 times at 7 years of age. Right? So this is a ready reckoner that they can ask you in the exam. When the weight doubles, when the weight triples, when the weight becomes 4 times, 5 times, 6 times, 7 times. Very easy to remember. Right? After weight, now let's talk about length. What is the average length of a newborn? It is 50 centimeter. 50 centimeter. So at birth, it is 50 centimeter. In the first year of life, there is gain of about 25 centimeters. So by the end of 1 year, what would be the height or length of the baby? It is 75 centimeter. Then in the next year, there is gain again of around 10 to 15 centimeters. So what would be the length at 2 years of age? It would be 85 to 90 centimeters. And thereafter 6 centimeter every year till puberty. And after puberty, you see that the males can grow up till 10 centimeter per year and females 8 centimeter per year. Right? So if you add 6 centimeter, that would be around 96 centimeter. So these are all the things or values that you have to remember. Then comes these MCQs that the examiner is fond of asking. So tell me, weight doubles by how many months? Weight doubles by 5 months of age. Weight triples by we discussed weight triples by no one. Weight triples by 1 year of age. Now let's talk about height. Height or length doubles and triples by, yes, the weight doubles, the length doubles by doubles by 4 years of age and triples by 12 years of age. Yes, Harsh is correct. Gautam is also correct. Another question that the examiner is fond of asking. A child is half the adult height at what age? Half the adult height at what age? The answer is 18 months. 18 months or 2 years. 18 months to 2 years. 18 to 24 months. Right? So these are the one-liners that the examiner is fond of asking. Let's move to the next parameter, that is head circumference. So what is the normal head circumference at birth? The normal is around 33 to 34 centimeters. And how the head circumference grows? In the first 3 months of the life. In the first 3 months, it is how many centimeters per month? Can anyone tell me how many centimeters per month? Anyone? How many centimeters per month? Be interactive, be rapid fire. How many centimeters per month there is increase? Initially, there is 2 centimeter per month. Then thereafter, there is 1 centimeter per month. And thereafter 6 months to 12 months, it is 0.5 centimeter per month. So what would be the increase over here? 2 into 3, that is 6 centimeter. Then 1 into 3, that is 3 centimeter. Then 0.5 into 6, that is again 3 centimeter. So 6 plus 3 plus 3, that is 12 centimeter. So gain in 12 centimeter in the first year of life. Another question, MCQ one-liner that they ask, what is the head circumference at birth as compared to the adult head circumference? So remember, head circumference at birth is 60% of the adult head circumference. And remember, in the Scammon growth curve, we told that by the end of second year of life, 90% of the growth has taken place. So 90% of the adult head circumference is achieved at 2 years of life. 2 years of life, right? Let's move to these one-liners again. What are the periods of growth? So I have divided this into antenatal, postnatal, and adolescent period. So antenatal, before the birth. When do you call this productive conception as fertilized ovum or zygote? Till 2 weeks. Till 2 weeks. So 0 to 2 weeks is zygote. Then third week onwards till 8 weeks is embryo. Fetus is 9 weeks onwards till birth. Right? After birth comes the postnatal period, but there is an in-between phase, perinatal period, that starts from 22 weeks of life till 7 days of life. 22 weeks of gestation till 7 days of life. Now comes the postnatal period. Neonate. What is a neonate? What is a neonate? What is a neonate? Tell me, what is a neonate? Neonate, the first 28 days of life, right? The first 28 days of life is a neonate. Early neonate are the first 7 days, 1 to 7 days, and late is 7 days onwards till 28 days. Then comes infant. Infant is a child less than 1 year of age. So no, every infant is not neonate, but every neonate is an infant. Right? There is a period in between post neonate, that is from 28 days till 1 year of age. 1 year of age. Toddler. Who is a toddler? Who is toddler? 1 to 3. T for toddler, T for 3. Preschool is 3 to 6. S means 6. So school going starts with 6 to 12 years of age. Then comes the adolescent period. This is 10 to 20 years of age. It is further divided into early adolescence, mid adolescence, and late adolescence. So early adolescence is 10 to 13 years. 14 to 16 is mid, and 17 to 20 is late adolescence. Late adolescence. We just discussed different parameters for growth assessment. Broadly, we divide them into age-dependent parameters and age-independent parameters. So what were the age-dependent parameters? Weight, length, head circumference. All of these are age-dependent, right? 3 kg for a newborn is fine, but if I say 3 kg for a 1-year-old child, that is not fine. So weight is something that is age-dependent. Same goes for height and length. Same goes for head circumference. What are the age-independent parameters? Age-independent parameters, 2 you have to remember. First is MUAC. What is this MUAC? MUAC is mid-upper arm circumference. Mid-upper arm circumference. And the second is SFT. What is SFT? It is skin fold thickness. Skin fold thickness. With that, let's come to what the examiner has given the image. So they give some instruments. Firstly, I have 2 instruments. These 2 instruments are for checking the weight of the child. So look at the first instrument, instrument A. What is this called? Can you see this S-shaped hook? This is nothing but spring balance. Spring balance. Look at this. What is this? Second, this is a beam scale. Beam scale. So apart from those electronic weight machines, we have these two that the examiner is fond of asking. First, remember hook machine. This is a spring balance. And then we have a horizontally lying scale. This is a beam scale or beam balance. Then we have these two instruments to measure the length and height. Firstly, what is length? What is height? Why are they different? So what is length? I make the child lie down and then measure head to toe. This is the length. And what is height? I make the child stand up straight and then measure head to toe. This is height. So till what age you are going to check length, and after that you are going to check height. At the age of 1 year, the child is able to stand. But we don't take height. We take length till 2 years of age. Why? Because there is physiological bowing of legs and I can get a error in the actual length or height of the child. So till 2 years of age, I am going to use this device. What is this device? What is this device? There is a horizontal plank. There is a headpiece which is stationary and then foot piece is mobile. So what is this? This is nothing but infantometer. Infantometer. Right? Infantometer. Till what age you are going to use this infantometer? You are going to use this infantometer till 2 years of age. 2 years of age. Right? And what about this device? What is this device? Option B. What is this? The child is standing and then I have this scale behind and I'm taking head to toe. What is this? This is nothing but a stadiometer. Stadiometer, right? Stadiometer. Yes. Everyone here is right. Parul is right. Gautam is right. This is nothing but a stadiometer. Just remember, till 2 years, you are going to use this infantometer. This infantometer is used because there is physiological bowing of legs. The name has infant, but remember, it is used till 2 years of age. 2 years of age. Then look at the second picture. We have mid upper arm circumference measuring tape. What is this tape called? This colorful tape. This colorful tape is known as Shakir's tape. Shakir's tape. Right? So this Shakir's tape, can anyone tell me what are the three zones? So red, yellow, green. Red is less than 11.5 centimeter. Yellow is 11.5 to 12.5 centimeter. And green is after 12.5 centimeter. So red means this child has severe malnutrition. Yellow means this child has malnutrition. And green means there is normal nutrition. Normal nutrition. So this is used as a screening tool by which we can assess malnutrition in our population. Moving to the next instrument. What is this instrument? Can you notice this instrument? What is this? This is nothing but Harpendon's caliper. Harpendon's caliper. Used to measure skin fold thickness. Normally it is 10 or more than 10 mm. If it is less than 6, it denotes severe malnutrition. Severe malnutrition. Where do you check this skin fold thickness at? The most common site that we use is your triceps. After that, you can also use in the subscapular region, in the interscapular region. Right? So this is all about your skin fold thickness. Now let's move to the next topic, puberty and adolescence. So adolescence we have just learned. What is adolescence? Adolescence is nothing but an age group, 10 to 20 years of age group, right? In which we have discussed early adolescence, mid adolescence, late adolescence. But what is puberty? How is puberty different from adolescence? So puberty is appearance of secondary sexual characters, whereas adolescence is just an age group. Adolescence is just an age group, right? So they ask the sequence of appearance of these signs or physiological changes of puberty. So very easy to remember, TPM. Very easy to remember, TPM. What is TPM? In females, firstly there is T, that is thelarche, that is enlargement of the breast tissue. So it is the first sign, thelarche. Then comes pubarche. What does pubarche means? Appearance of the pubic hair. And then we have M, that is menarche. Menarche, that is onset of menses. Onset of menses. Then comes male. In male also the mnemonic is TPM. What is T over here? Here we have testicular enlargement. Testicular enlargement. P is again pubarche. Pubarche. And penile growth. And lastly, M is for manly, that there will be appearance of beard, facial hair, voice changes. Coming to the MCQs that the examiner asks. Firstly, what is the first biochemical marker or biochemical evidence of puberty? That is nothing but GnRH pulse. GnRH pulse. But if they say what is the best marker, which hormone would be the best marker? Remember, LH over FSH. LH over FSH. If FSH is there in the options, LH is not there, mark FSH. Otherwise, LH is the best. Staging of puberty is called as Tanner staging. Tanner's or SMR staging. Then they ask about growth spurt and which staging there is spurt. Firstly, growth spurt in females happens in stage 3 and in males it happens in stage 4. Right, so these are the major MCQs that they ask and the sequence that they ask. Now briefly let's go through the staging, the Tanner staging or the sexual maturity rating staging. Right, so firstly we are going to discuss males. So firstly we have 5 stages, 1 to 5. As we go down from 1 to 5, the puberty changes become more and more adult like. So first would always be a pre-pubertal stage and last would always be adult like, right? So first pubertal and fifth is adult like. In stage 2, what happens? Firstly, there will be increase in the testicular volume. So there will be increase in testicular volume. I hope you all have the workbook, right? You all have the workbook, right? Okay, so increase in the testicular volume. The prepubertal size is less than 4 ml. And once it crosses the 4 ml, it means the puberty has started. Pubic hair is very sparse. You have sparse pubic hair. In stage 3, now pubic hair starts coarsening. Pubic hair starts coarsening or curling. And there is also increase in the penile length. In 4th stage, now you see the growth spurt. And also now, apart from the length, there will be increase in the penile girth. And lastly, we have now the pubertal adult type in stage 4. So what is the difference between stage 4 and 5, they ask? In stage 4, there will be no pubic hair over the thighs. Here, there will be pubic hair over thighs also. And lastly, the adult total volume they ask, testicular volume they ask, which is 25 ml. So 2 volumes you have to remember. First is the 4 ml, which is the cutoff for the onset of puberty, and the adult one, that is 25 ml. Right? So any confusion over here? I hope no confusion. Another MCQ that they ask is about scrotum. So if they ask scrotum reddening, that starts happening in stage 2. But if they ask scrotal darkening, that happens at stage 4. Stage 4. Okay. So after males, let's now move down to females. Same. First would be your prepubertal, and last would be your adult like. And difference in between fourth and fifth would be the same, that here the pubic hair are all over except the thighs. Here you will have thigh hair also. So let's start. After stage 1, that is the prepubertal, comes stage 2. In stage 2, there will be appearance of a breast bud, and the pubic hair over here are sparse. In stage 3, growth spurt happens, and the pubic hair now starts coarsening and curling. Coarsening and curling. In stage 4, the pubic hair now are adult type except the medial thigh, and there is formation of secondary mound. Secondary mound. You understand what is secondary mound? So primary mound would be like this, breast tissue. What is secondary mound? Now there will be definition of the nipples and areola. Definition of nipple and areola. This is secondary mound. We have covered the normal growth and growth part, along with that puberty and adolescence. Now let's start with short stature assessment. So what is the definition of short stature? How do you define short stature? Short stature is defined as the height for age and sex. Height for age and sex less than -2 standard definition. Standard definition. Right? -2 standard deviation. What is the target height? I am short because my parents are short. So what is the target height concept? Target height concept is that mid-parental height. Mid-parental height. That is mother's height, father's height divided by 2. Mid-parental height, and we do plus minus 6.5 centimeter depending upon whether it is a boy or a girl. In cases of boy, you are going to add. In cases of girl, you are going to subtract. This is the target height concept. Then comes physiological versus pathological short stature. So pathological short stature, you all know what is pathological short stature. Whenever there is some underlying pathology and because of that there is short stature, that is pathological. But what is important for us over here is physiological short stature, because two important causes of physiological short stature examiners are very fond of asking. What are these? CDGP, that is constitutional delay in growth and puberty, and the second is your physiological short. Second is your familial short stature. Familial short stature. Familial short stature. So what is this familial short stature and CDGP? So familial, very easy to understand. Short stature is running in families. Parents are short, that's why the child is short. So here in history, you will see that parents have short height, short parents. And the final height obviously of this child would be short. Puberty comes at normal time in this child. Height age, that is height for that age. Height age definitely would be less. Bone age here would be normal. What would be the relationship between height age, chronological age and bone age? So definitely the height age is less than the chronological age of this child. But bone age is adequate. So bone age is equal to the chronological age. So this would be the relationship. So this is all about the familial short stature. Now let's talk about CDGP. What would be the history over here? The name itself says constitutional delay in growth and puberty. So here what happens? The parents' final height is normal, but they catch up late. So as compared to their peers, they are going to be short. But one fine summer holidays in 10th or 11th standard, they will catch up height. So here I will have history of delay in puberty. Delay in puberty in parents. Delay in puberty in parents. Here the final height is going to be normal. Puberty is delayed. Height age is delayed. Bone age is also delayed. So here both bone age and height age corresponds, and both of them are less than the chronological age. I hope you all know this concept of bone age, height age, chronological age at this point of time, because the exam is very near. Right, so this is about physiological short stature. Now let's discuss about a very important ratio, that is upper segment, lower segment ratio. So what is upper segment? What is lower segment? So if I make a child stand like this, what is upper segment? From the head, top of the head, till pubic symphysis, this is the upper segment. And the remaining would be the lower segment. So if I take the total height and subtract upper segment, I will get lower segment. Right, so what is the normal upper segment, lower segment ratio at birth? Normally, it is 1.7:1. That means my upper segment is big and my lower segment is short. And as the child grows, limb grow, that means the lower segment grow. So this ratio will come down. So at 3 years of age, it will be 1.3:1. At 6 years of age, it will be 1.1:1. At 10 years of age, it will be 1:1. And thereafter, after 10 years of age, the adult ratio is achieved, that is 0.9:1, also known as 1:1.1. Right, so this is your upper segment, lower segment ratio. Now why this ratio is important, that we need to know, because this ratio can tell me whether the child has a proportionate short stature or disproportionate short stature. If the upper segment lower segment ratio is appropriate for that age, so this is proportionately small bacha, this is a proportionate short stature. But if there is some abnormality, either the upper segment lower segment ratio is high for that age or upper segment lower segment ratio is low for that age, that means this is some disproportion. There is some disproportionate short stature. So let's discuss this disproportionate short stature. So increased upper segment lower segment ratio first. So normally we have discussed what are the values. If I say at 3 years of age, the upper segment lower segment ratio is 1:4:1, 1.4:1. That means my upper segment lower segment ratio is high for that age. That means the upper segment is big, trunk is big, limbs are small. So this is short limb dwarfism, short limb dwarfism. Here you have to consider only 3 possibilities. What are the 3 possibilities? First, rickets. Second, achondroplasia. Third is congenital hypothyroidism. So these 3 conditions, if anyone wakes you up in the sleep, you should be able to recall these 3. Please rectify them. 3 conditions where there is increased upper segment lower segment ratio, short limb dwarfism. Rickets, achondroplasia, and congenital hypothyroidism. Then comes the second, that is decreased upper segment lower segment ratio. Decreased upper segment lower segment ratio means the trunk is short, the limbs are normal, so short trunk dwarfism. So mainly your trunk is made up of your spine. So all the conditions where the spine is affected, my trunk will stay short. So all the vertebral anomalies, pot spine, that is tuberculosis of the spine, mucopolysaccharidosis, storage disorders, spondyloepiphyseal dysplasia. So these are the conditions that you need to remember as far as your disproportionate short stature is considered. Okay, so any doubt till now? we are done with the growth aspects. Now let's start with development part. Development. Quickly, we are going to wrap up the development part, right? You all have studied thoroughly about the milestones, growth. So we are just going to revise it over here. We're not going to go into depth, right? Just ऊपर से फटाफट हम रिवाइज करेंगे जैसे आपको एग्जाम से पहले रिवाइज करना है. So firstly, let's talk about the gross motor milestones. At 3 months, what happens at 3 months? There is head control. Head control is achieved at 3 months of age. Then the child will learn to sit. So sit with support comes at 6 months. In between there will be roll over. 8 months the child is going to sit without support. At 9 months the child will stand with support. At 10 months creeping starts. And also cruising with furniture is also there. On the first birthday, the child will stand without support. Then at 15, the child will walk without support. And 18 months, the child will be now running. 18 साल के होते सबको भागना दौड़ना होता है. So there 18 months पे भी यही होता है. Starts running and also starts exploring. So explores your drawers. At 2 years of age, now the child will play around, jump, walk backward, climb the furniture. So jumping, climbing furniture, all of these nutritious things come. At 3 years of age, now the child will ride a 3-tire cycle, that is tricycle. At 4 years of age, now the child will hop or skip. Right? At 4 years of age, the child will hops or skips, but this hopping and skipping would be on one foot. And finally, at 5 years of age, this hopping and skipping would be on both the feet, 2 feet. Right, so this is about the gross motor milestone. And gross motor milestone, stairs milestone is very important. Remember, firstly the child will use both the feet on each step, right? Put both the feet on one step, then to another step, then another step. So firstly the child goes up like this and down like this. So firstly 2 feet on one step, upstairs and downstairs. This comes at 2 years of age. Then the child will use 1 feet per step. This child learns first going upstairs, which happens at 3 years of age. And then 1 foot per step downstairs, that comes at 4 years of age. So remember, going up the child learns earlier, coming down later. After gross motor, let's talk about the fine motor milestones. Fine motors are the use of these fine muscles of the hands. So firstly, it comes grasping of toy and rattle, that comes at around 3 to 4 months of age. So grasping toy or rattle, this comes at 4 months of age. Then mouthing also comes over here, mouthing. Then at 5 months, the child is going to have bidextrous reach. Bidextrous, that means the child is going to hold the object with both the hands. Then unidextrous reach. Unidextrous means using one hand to hold the object, unidextrous reach. Then comes pincer grasp. What is pincer grasp? Holding the object by the opposition of thumb and fingers. So firstly there is pincer grasp, which is immature. That means the holding would be in thumb and the accessory finger would also be there. So firstly comes the immature pincer grasp. And then at 12 months there will be mature pincer grasp. So if the examiner asks when does pincer grasp comes, so you are going to answer 9 months only, because immature comes by then. But if the examiner asks mature pincer grasp, then the answer is going to be 12 months. Then at 15 months the child can scribble, hold the pencil and scribble. After scribbling, some drawing skills will come. So firstly comes line. So at 2 years of age, the child will make this line, that's this pointed line. At 3 years of age, the child is going to make this circle. At 4 years of age, cross or plus sign the child is going to make. At 4.5 years, the child is going to make this rectangle, triangle. At 5 years, then 6 or 7 years, the child will make this diamond, cylinder at 9 years, and a cube at 11 years of age. 11 years of age. So this is the different drawing skills that the child is going to achieve as per age. In fine motor skill, one important skill is that we do every day, dressing and undressing. Which is easier? Undressing is easier, right? So firstly, the child learns to undress with help, then dress with help, and thereafter dressing and undressing without help. So undressing with help comes at 2 years of age. Dressing with help comes 3 years of age, and finally dressing and undressing without any help comes at 5 years of age. In dressing and undressing also, the most intricate function is buttoning and unbuttoning. Again, unbuttoning comes first. Unbuttoning comes at 3 years of age, and buttoning comes at 4 years of age. Okay, now let's start with the social milestones. 2 months. What happens at 2 months? There is social smile. Social smile that happens at 2 months. After 3 months, the child now recognizes the mother. So mother regard is going to be there. After mother regard, there is 6 months, that is mirror play. Now the child recognizes self also. So the child now recognizes mother, recognizes self. At 6 to 7 months comes stranger anxiety. At 9 months, a very important milestone, there is object permanence. And also here the child waves bye-bye. Right? Then comes 1 year, 12 months. What is this? What happens at 12 months of age? Imitation and mimicry. The child acts out imitation and mimicry. Domestic mimicry comes at 18 months. Domestic mimicry. That means whatever the mother is doing at home, the household chores, the child will try to copy that. Then at 3 years of age, the child is able to tell 3 things. What are the 3 things? Age, sex, that is the gender, and name. Name, age, gender, these 3 things the child can tell. Also at this time, handedness comes. At 4 years of age, the child has right to left discrimination. In social milestones, a very important section is the interaction and playing. So at 15 months, the child hugs the parents and plays with the parents. 18 months, the child kisses the parents. After that, the child has stranger anxiety. So after 18 months, the child also develops stranger anxiety. The child develops separation anxiety. 2 to 2.5 years, there will be parallel play. At 3 years, there is cooperative play. Lastly, at 4 years, there will be role play or your group play. Right? So lastly comes the language milestones. So firstly, cooing. Cooing comes at 2 months of age. Laughing out loud at 4 months of age. Monosyllables, ma, ba, da. These comes at 6 months of age, monosyllables. Bisyllables come at 9 months of age, mama, papa, dada. And the first real word of the child comes at 12 months of age. So the first real word comes at 12 months. So you must have asked your parents that what was my first word. Mostly they say mama, papa, dada, all of these. But these are nothing but bisyllables. You don't know the meaning of these words. First meaningful, first real word comes at 12 months of age. After that, the child's vocabulary will increase. At 4 to 6 months, the child will have around 4 to 6 words in his vocabulary. Right? 4 to 6 words in his vocabulary. At 18 months, it will increase to about 8 to 10 words, 8 to 10 words. By the end of 2 years, now the child will have expanded vocabulary, 50 to 100 words, and the child would also be now forming sentences. Forming sentences. And these sentences are actually two-word sentences. Khana do, pani do, give water, give food, two-word sentences. At 3 years of age, the child will now use pronouns. I, me, you, main, tum, aap. Right? I, me, you. At 4 years of age, now the child will turn into a full storyteller. There will be storytelling, poem recitation. Also, how does the story start? Once upon a time. So now the child, through his speech, will also tell about the past tense. So past events also the child can tell now. What about future? Future comes at 5 years. So future tense comes at 5 years of age. And also here the child will be asking about the meaning of words. Meaning of words. So with that, we cover our developmental milestones, the gross motor, fine motor, social and language milestones. Right, then comes some special milestones. In special milestones, we have vision and hearing. So vision, very easy. What do we do for vision testing? We take a red dangling ring and show the child that ring. This ring has to be 8 to 10 inches away from the child. Newborn can follow this till 45 degrees. By the end of 1 month, the child can follow till 90 degrees, and by the end of 3 months, 180 degree. Binocular vision comes at 4 months of age. Right, 4 months of age. With that, we have covered the normal growth and development. Now let's move to the next topic of general pediatrics, that is your vitamins and minerals. Again, this is an overlap topic between biochemistry and pediatrics, but a very important topic, especially for your FMG exam, because FMG exam, if you check over the past 10 years, 15 years, not even a single paper goes by where they don't ask about vitamin deficiencies. Right, so now let's start with these micronutrients. Vitamins, we all know two types of vitamins are there. There are water soluble vitamin and fat soluble vitamin. What are the water soluble vitamins? These are very easy: B complex and C, vitamin C. And the fat soluble vitamins are A, D, E and K. A, D, E and K. So let's go one by one about these deficiencies. Let's start with the water soluble ones first. B1. B1, also known as thiamine. What does thiamine deficiency causes? It causes beriberi. We have wet beriberi and dry beriberi. In wet beriberi, which system is involved? Wet beriberi, cardiac tissue is involved. Dry beriberi, nervous tissues are involved. And in alcoholics, this thiamine deficiency, alcoholics also, this thiamine deficiency has taken place. So what is that called? It is called Wernicke-Korsakoff syndrome. The mnemonic to remember the Wernicke-Korsakoff syndrome that happens in alcoholics is GOA. GOA. What is G? G stands for global confusion. Global confusion. What is O? O is ophthalmoplegia. Ophthalmoplegia. What is A? Ataxia. Ataxia. Right? So GOA, Wernicke-Korsakoff syndrome. Then we have B2. B2 is riboflavin. Riboflavin. So name itself has ribo red. Right? Why? What happens in this riboflavin deficiency? Red things will happen. So there is. Can you see little vessels growing into the cornea? This is neovascularization of the cornea. Neovascularization of cornea. Also cheilitis, glossitis. Can you see at the angle of the mouth, glossitis, cheilitis, and the tongue is also magenta colored tongue. Then after B2, let's talk about B3, that is niacin. B3, that is niacin. So what happens due to niacin deficiency? A very important disease for your exam. Niacin deficiency is cause pellagra. Pellagra. Right? What happens in pellagra? It is also known as the 3D disease. Why it is called a 3D disease? 3Ds happen. What are these 3Ds? 3Ds, what are these 3Ds? First D is for diarrhea. Diarrhea. Then we have dermatitis. Then we have dementia. Dementia. And sometimes the fourth D is also included, that is death. That is death. Right, and this typical rash that you see over here, what is this is known as? A photosensitive rash. This is Casals necklace. Casals necklace. This also happens in pellagra. Niacin deficiency. After B3, there is nothing as B4. We have B5. So B5, what is the name? Name is pantothenic acid. Pantothenic acid. So pant, you take the pant and wear it from the foot. So what will happen in pantothenic acid deficiency, B5 deficiency? Burning foot syndrome happens. Burning foot syndrome. So very painful foot. So it is also known as nutritional melalgia. Nutritional melalgia. Nutritional melalgia. After B5, we have B6, that is pyridoxine. Pyridoxine deficiency, one important thing that you need to remember is it causes neonatal seizures. Neonatal seizures. Neonatal seizures. Then we have B7. What is B7 called as? Biotin. Biotin supplements girls take for their hair, nails, everything, right? So biotin deficiency causes alopecia, dermatitis. B9, there is nothing as B8. We have B9 now, folic acid or folate. We all know folic acid deficiency causes which type of anemia? Megaloblastic anemia. And if mother is deficient in folic acid, it can cause neural tube defects in the child. So neural tube defects and megaloblastic anemia are the two important deficiencies that you need to know. Then we have B12, that is cobalamin. B12 deficiency also causes megaloblastic anemia. Megaloblastic anemia. Megaloblastic anemia. Another important term associated with B12 deficiency, what is that? SACD, subacute combined degeneration. And remember, in radio you must have seen the inverted V sign, that is also seen in the subacute combined degeneration. Then we have vitamin C, that is ascorbic acid. Vitamin C, very important for the collagen synthesis. So what will happen? There will be bleeding in the joints. Skin, you will see different manifestations. What are the different manifestations that you're going to see in the skin? Different manifestations in the skin. Can anyone tell me? Vitamin C deficiency, what are the different manifestations? Scurvy. You will see perifollicular hemorrhage, curly hair, and in joints, there will be joint bleed. And this is a typical X-ray that you see. You see ring epiphysis, Weinberg signs, corbetic zone, trauma-filled zone, subperiosteal hemorrhage. Let's talk about the fat-soluble vitamins. Fat-soluble vitamins, firstly comes vitamin A deficiency. Vitamin A deficiency, you all understand Vitamin A is very important for your vision. So the deficiency causes night blindness, right? In skin there will be dryness. Can you tell me what would be the first symptom over here? First symptom over here. First eye symptom and first eye sign. Both are two different things. Symptom means something that the patient tells you. Sign is something that you pick up. So what is the first symptom? First symptom, eye symptom. The first eye symptom that the patient will tell you is night blindness. Night blindness. And what is the first eye sign? First sign that you appreciate is conjunctival cirrhosis. Conjunctival cirrhosis. There is WHO classification. Yes, everyone over here is right. Night blindness. Then WHO classification comes. In WHO classification, firstly, let's start. Firstly, we have cirrhosis, conjunctival cirrhosis. So X1A is conjunctival cirrhosis. Then we have corneal cirrhosis. Sorry, conjunctival cirrhosis. X1A is conjunctival cirrhosis. X1B is bite dot spots. Most of you have already answered bite dot spot in this image. Can you see this flaky structure over the cornea, over the eye? This is nothing but bite dot spot. X2 is now corneal cirrhosis. Corneal cirrhosis. X3 would be now ulceration, corneal ulceration. If this ulceration is involving less than 1/3 of the cornea, it is known as X3A. And if it involves more than 1/3 of the cornea, it is known as X3B. Then we have scarring and fundal changes. Fundal changes. So this is all about the vitamin A deficiency. Now comes vitamin D, important. What is the first sign of the vitamin D deficiency? Rickets. First sign is craniotabes. Craniotabes. Ping pong skull. Craniotabes, ping pong skull. In chest, what all things you see in the chest? In chest, you see rachitic rosary, beading, rachitic rosary. And Harrison sulcus. Harrison sulcus. In lower limb, what do you see? You see bowing of the legs. Bowing of the legs. This is the typical X-ray. What do you see in X-ray? You see three things: cupping, splaying, and fraying. Cupping, splaying, fraying. Lab investigations of vitamin D deficiency. Vitamin D is very important for calcium absorption. So calcium here would be low. Phosphate again low. Whenever calcium is low in our body, these calcium sensing receptors over the parathyroid gets activated and there will be release of this parathyroid hormone, so it would be high. This parathyroid hormone will cause release of the calcium from the bones and ALP would increase. As a result of this, my calcium levels can also normalize. So these are the values over here. If they ask which is the most important or most valuable lab marker over here, that would be ALP. If the ALP is not high, this is not vitamin D deficiency. Think of something else. We all know the treatment of vitamin D deficiency rickets. We have supplementation. We can give high dose or low dose. High dose would be 60,000 international units per week for 10 weeks, and low dose, which is preferred, that is 6,000 international units per day for 3 months. We check for the response to this treatment. If the response to the treatment is there, what you will see? You will see a white line of calcification. A white line of calcification would be seen. Right, so response to the treatment would be your white line of calcification. White line of calcification. white line of calcification. Any doubt till now? All of these are facts that you need to remember. Nothing to really make a concept around. Right? So we have done vitamin A, vitamin D. Now we have E and K. Vitamin E, tocopherol, very important. What are the manifestations that you will see over here? You will see hematological as well as neurological. Hemolytic anemia is one of the hematological manifestations in the deficiency of vitamin E, and neurological, you see spinocerebellar ataxia. Spinocerebellar ataxia. Then we have vitamin K. Vitamin K deficiency will cause bleeding because it is very important for the hydroxylation of clotting factors. So you will see hemorrhagic disease of newborn and bleeding manifestation in cases of vitamin K deficiency. Right? So let's start with the malnutrition topic per se. So malnutrition, what do you understand by malnutrition? So malnutrition, whenever we think of a very cachexic child that is deprived of nutrition. But remember, malnutrition means both. It could be either undernutrition or it could be overnutrition also. Right? But in India, overnutrition is not a big problem, under is. That's why malnutrition and undernutrition is referred to as synonymously. So in malnutrition, what is important for you are these guidelines or definitions or criterias. So broad line, remember anything that is plus minus 2, beyond plus minus 2 standard deviation is going to be abnormal. Right? So if my height is less than minus 2 standard deviation, that means it is short. If it is more than plus 2 standard deviation, that means it's tall. Right? So anything beyond plus minus 2 standard deviation is going to be abnormal. And anything beyond plus minus 3 standard deviation would be severely abnormal. Severely abnormal. Right? So with this concept, let's go around. So the first criteria is weight for height in between minus 2 to minus 3 standard deviation. That means the weight for height is less. That means this child is wasted. So this is nothing but wasting. If this weight for height is less than minus 3 standard deviation, it is severe wasting. Severe wasting. Right? Similarly, if I say weight for height above plus 2 standard deviation, but less than plus 3 standard deviation, that means the weight is on the higher side. That means something abnormal is there, but not beyond plus 3 standard deviation. So this is nothing but a overweight child. If it goes beyond plus 3 standard deviation, it will be an obese child. After weight, now let's talk about height. If the height is less than minus 2 standard deviation, we discussed it is known as short stature. So minus 2 to minus 3, this would be a short child, a stunted child. So this is known as stunting. If it is very less than minus 3 standard deviation, this is known as severe stunting. Severe stunting. Right, so these are the definitions that you need to remember before your exam. Now comes the difference between acute and chronic malnutrition. What is acute? For a very short period of time, the child is deprived of nutrients. It could be due to some high demand pathology or could be some acute insult. But what is chronic malnutrition? That for over a long period of time, the child is deprived of nutrition. Right? So if for a short period of time, the nutrients are not given properly, so weight of the child will be reduced but not the height. But if there is a chronic malnutrition scenario, then the height would also be affected. So remember, in acute malnutrition, weight for age definitely would be less. Height for age would be normal. Weight for height, obviously height is normal, but the weight has decreased, so weight for height would be decreased. What about chronic malnutrition? In chronic malnutrition, the weight for age decrease, height also decrease. Now both weight and height both are decrease. So weight for height can sometimes be normal, because both proportionately have decreased, can be normal. So what the examiner asks, what is common to both these acute as well as chronic malnutrition? So what is common? This is common. Weight for age is common. Then they ask, what is the best marker for acute malnutrition? Best marker is this. Weight for height is the best marker. And what would be the best marker for chronic malnutrition? This. Height for age. Height for age. So remember these three MCQs, which is common to both. Weight for age is common to both. Height for age is a good marker for chronic malnutrition, and weight for height is the best marker for acute malnutrition. Right? After this, let's talk about the extreme forms of malnutrition, the age-old favorite question of examiners. Can you see these two bachas? Bacha A, bacha B. What bacha A has, which extreme form of malnutrition? Marasmus or kwashiorkor? Very mara hua bacha, skin and bones baby. This is marasmus. And what about the B bacha? This is kwashiorkor. In which bacha the appetite would be good? Marasmus child will have good appetite. Look at him sitting very widely alert. If you offer him food, he will have it very voraciously. If a normal child at this age can eat 2 chapatis, he will eat 4 chapatis, 5 chapatis. Very voracious appetite. On the other hand, kwashiorkor child, B child, though he's looking very chubby, very puffy, but look how he's lying down very listlessly. The appetite is gone. If you offer the food, the child won't eat food. So which of these has a good prognosis? Marasmus child has a good prognosis. Kwashiorkor child has a poor prognosis. Now let's just make a table differentiating the both. Firstly, wasting. Where do you see wasting? Marasmus or kwashiorkor? Both of them has wasting, but Marasmus child, the mara hua child, has a visible wasting. So you will see a visible, severe visible wasting. Severe visible wasting. On the other hand, in kwashiorkor also wasting is there, but because of the edema, the wasting is masked. If we talk about the general status, I told you how was the marasmus child sitting. The child was very alert, right? Very alert child. And how was the appearance in general? Very cachexia child, right? Skin and bones baby. On the other hand, kwashiorkor child was very dull, listless. And how was the appearance? It was a chubby baby. This is known as what baby? Fat sugar baby. The appetite here is good, in fact, very voracious. In kwashiorkor, the appetite has decreased. The age at onset, mainly marasmus can happen anytime. Kwashiorkor usually is seen after 1 year of age when the diet has changed. Diet has changed from predominantly to high calorie but low protein diet. So mainly the deficiency over here is the calorie deficiency. Here main deficiency is the protein deficiency. The prognosis in marasmus is good or better. Here the prognosis is poor. Then we have skin and hair changes. Skin and hair changes mainly can be seen in both, but more appreciated in kwashiorkor case. Liver, we see a shrunken liver in cases of marasmus and a fatty liver in cases of kwashiorkor. So what are the skin and hair changes? Three skin and hair changes you need to remember. Flaky paint dermatosis, flag sign in the hair, and crazy pavement appearance. Right? After this, let's talk about SAM. What is the SAM baby? Severe acute malnutrition, SAM. So for SAM, any one of the following criteria should be there. Anyone, remember, anyone. What are these? Anyone. First says there is severe wasting. That means weight for height less than -3 standard deviation. Second is MUAC less than 11.5 centimeter. And third would be bipedal edema. bipedal edema. Rule out other causes, nutritional edema would be included in SAM. So any one out of these three, if there, it is known as SAM. With that, we complete the general pediatrics. Now let's talk about some of the genetic syndrome. If there is any doubt till now, we can go over and have a look at again. If not, we will continue with genetics. Please tell me, shall we continue or not? Shall we start? Okay, so Down syndrome. Down syndrome, what is Down syndrome? Trisomy 21. Trisomy 21 is Down syndrome. Definitely it is associated with maternal age. 95% of the cases, there is advanced maternal age association, because what happens with advanced maternal age, there is chances of non-disjunction during the meiotic division. So coming straight away to the questions and the features that they ask in the exam. What do you see in this picture? What finding I have shown in this? What is this? Single transverse crease. What is this called as? This is known as the simian crease. Simian crease. Single transverse crease. Apart from that, what are the features? You can see an epicanthal fold over here. Epicanthal fold over here. Upward slant of the palpebral fissure. Low set ears. A very flat facial profile. The nasal bone is very short. Transverse crease we have seen in the hands. Apart from that, the tone of this child is very low. There is hypotonia, protruding tongue, and umbilical hernia. These are all the physical appearance things that you see. What the examiners ask is the associations with Down syndrome. Firstly, let's talk about the cardiovascular associations. The most common cardiovascular manifestation associated with Down syndrome is endocardial cushion defects. Endocardial cushion defects, right? Endocardial cushion defects. What about GIT? GIT, you see duodenal atresia, annular pancreas, In hematological, you see ALL, AML, leukemias, ALL more than AML. And in AML, the most common is M7 variety, that is acute megakaryocytic leukemia. Then we have endocrine issues. These children are more associated with congenital hypothyroidism. They have a risk of congenital hypothyroidism. In skeleton problems, what they have? Neck problems, right? Atlantoaxial dislocations. And remember, neurological problem, they have a low IQ. Here, mental retardation is universal. Right? Coming to next topic over here in Down syndromes is antenatal screening. After the features and the association, antenatal screening. In first trimester, we do dual test. In second trimester, we do triple test. So what is dual test? What are the markers of dual test? We have beta HCG and PAP-A. Also in ultrasound, we can look for nuchal translucency, nuchal thickness, nasal bone, NT-NB scan. In second trimester, we do triple test. The parameters that we check for are again beta HCG, unconjugated estriol, and alpha fetoprotein. Now, what they ask, which of these marker increase, which of these marker decrease? So very easy to remember. Two markers increase. What are these two markers? Increase inhibin, I for inhibin, and H for high, so beta HCG high. So these two are increased, rest all are decreased. So here in dual test, HCG would be high, PAP-A would be low. Here HCG would be high, others would be low. Quadruple test is nothing but your beta HCG triple test plus inhibin. After Down syndrome. Now let's talk about Turner and Noonan syndrome. Turner and Noonan syndrome. So Turner, you all know what is this Turner? It is monosomy X. Monosomy X. Right? So this would be XO. Then we have Noonan syndrome. Noonan syndrome, whether it is a chromosome number problem or some qualitative problem, genetic problem, it is actually a genetic problem. Here it is autosomal dominant. There is defect in this gene PTPN11 gene. Right? Here, because the Y chromosome is absent, this child is going to be female only. Here it could be a female also, male also, both. In Turner syndrome, the IQ is normal. Here the IQ is low. Here the gonads are defected. You have streak ovaries or infertility. But here they're fertile, but there could be some sort of subfertility also, decreased fertility also. Then comes associations. They are associated with some heart defects. So remember, in Turner syndrome, you are going to see left-sided heart defects. What do you have in left side? Left atrium, left ventricle, aorta. So here you have bicuspid aortic valve, coarctation of aorta. On the other hand, in Noonan syndrome, you see right-sided heart defects. In right side, what do you have? You have right atrium, right ventricles, pulmonary vein, pulmonary artery, right? So there will be pulmonary stenosis, pulmonary stenosis. So these are the major features. I know you all know what are these clinical features that you see over here. Important ones are webbed neck, widely spaced nipple and wide carrying angle. Right? All of these are the important features of Turner syndrome. Now let's move to the next, Dijot syndrome. What is this? This is a microdeletion syndrome. There is deletion over chromosome 22. So this, due to this deletion, what happens? There is problem in development of third and fourth pharyngeal arch. Third and fourth pharyngeal arch defect. So all of the structures that are derived from this third and fourth pharyngeal arch, thymus, parathyroid, they won't be there. They would be defective. So what do you see over here? The mnemonic is catch 22. C starts for cardiac issues. What do you see? The most common cardiac defect that we see over here is conotruncal defects like TOF. So you see conotruncal defects like TOF. Then we have abnormal faces. T stands for your thymic problem, thymic aplasia. C is cleft lip, cleft palate. Cleft lip and cleft palate. H is for hypocalcemia. And 22 is nothing but 22q11 deletion. 22q11 deletion. Right, so this is about Dijot syndrome. After genetics, now let's start with your neonatology. So neonatology, we are going to start with three important respiratory problems in newborns. So whenever we talk about newborns, you need to know a set of issues. First issue happening in preterms. Second issue mostly happening in term babies, then post-term babies. So firstly, let's talk about preterms. In preterms, two important things are there: apnea of prematurity and respiratory distress syndrome. So we are going to discuss respiratory distress syndrome over here. So what happens in preterms? There is deficiency of the mature surfactant, deficiency of mature surfactant. So what will happen due to the deficiency of this mature surfactant? The alveoli will collapse. What do you see over here? You see a white out lung, white out lung. The treatment includes prevention by giving antenatal steroids, and treatment here would be giving initially CPAP. If CPAP failure is there, you give surfactant by Ensure technique. Ensure technique. Then we have a problem in term babies that are born by a cesarean section. So normally if the delivery is happening through the vagina, vaginal delivery, there is squeezing of the baby's chest through the vaginal canal. But if there is cesarean section, what will happen? There will be some retained fluid in the lungs, and because of that, the child would be having some sort of respiratory distress. There you see tachypnea. This usually settles on its own as the fluid will get resorbed sooner or later. So that's why this is known as transient tachypnea of newborn. So why this transient tachypnea of newborn is happening? This is happening because of the retention of lung fluid. Retention of lung fluid. Retention of lung fluid. Here you see on X-ray fluid in the horizontal fissure. Fluid in the horizontal fissure. And the treatment here is nothing. It resolves on its own. It resolves in 72 hours. Right? Only supportive treatment is to be given. Then comes the problem of the post-term baby, meconium aspiration syndrome. So if the child is in any stress, or if it is a post-term baby, the child can pass meconium into the amniotic fluid, and this meconium can be aspirated down. If this meconium aspirated blocks the complete airway, there will be collapse. If it blocks partially, there will be hyperinflation due to the ball valve mechanism. And thirdly, it can cause chemical pneumonitis. Right? So three things you will see. Here you will see collapse in some areas, segmental collapse. You will see hyperinflation in certain areas, and pneumonitis like picture. Here also supportive treatment has to be given. Let's move down to the images of these three. Let's look at the first image over here. What do you see? What do you see? Can you look at the lungs? The lungs are appearing white, right? The lungs are appearing white. The airway, the major airway, they appear black. This is known as air bronchogram appearance and whiteout lung. Then let's look at the next picture. Can you see fluid in the horizontal fissure? This is nothing but TTNB, TTNB. Now let's look at this picture. Can you see collapse of this segment over here? Hyperinflation over here. This is nothing but meconium aspiration syndrome. So this is about the respiratory distress disorders in newborn. To quantify this distress, we have two scores. The first score is for the preterms. Preterms means chota bacha. So the name score is very big. This score is known as your Silverman-Anderson score. Silverman-Anderson score. 5 components of the score: upper chest retractions, lower chest retractions, xiphoid retractions, nasal flaring, grunting. In 0, nothing would be there. Nothing would be there. No chest retractions, no xiphoid retractions, no nasal flaring, no grunting. 1, what will happen? Let's look at these retractions first. Lower chest and xiphoid. In 1, there will be mild retractions, and in 2, there will be severe retractions. Nasal flaring also similar, mild, severe. Let's talk about grunting. What is the grunt? It is expiration against the partially closed glottis. So if you hear grunting only with the help of stethoscope, then it is 1. But if you don't need the stethoscope, you can hear the grunt with the naked ear. This is known as 2, naked ear. Then lastly, let's talk about upper chest retractions. What happens normally? Normally there is synchronous movement of the chest and the abdomen while breathing. Right? So if there is synchronous movement, this is 0. But if there is lag on inspiration, 1. If there is seesaw breathing, 2. Right? So this is about Silverman-Anderson score. So the maximum score here would be 10, minimum would be 0. I'll be just back in 5 minutes. So we are back. Let's resume. So we were discussing respiratory distress score, and we discussed the respiratory distress score that we employ in preterm, Silverman-Anderson score. Very easy: upper chest retractions, lower chest retractions, epiphyseal retractions, nasal flaring, and grunting. Right? Now let's start with the score of terms, that is the Downey score. Right? So in Downey score, the mnemonic to remember the Downey score is very easy. Right? The Downey score, very easy. What is the mnemonic? Grace. Grace. G is for grunting. R is for retractions. A is for the air entry. C is cyanosis. And R is respiratory rate. So, firstly, grunting and retractions is very similar to the Silverman-Anderson score. If there is no grunting, 0. If you are able to hear the grunt with steth, 1. If naked ear, then 2. Then comes retractions. If there are no retractions, 0. If mild, 1. If severe, severe, 2. Then comes cyanosis. If there is no cyanosis, 0. If there is cyanosis on room air and as soon as you give oxygen, the cyanosis disappears, it is 1. So cyanosis on room air is 1. If cyanosis is there despite giving 40% of oxygen, then it is 2. Then comes respiratory rate. You know the normal respiratory rate of a newborn is 40 to 60. So if the respiratory rate is 60 or less than 60, 0. If it is 60 to 80, 1. Above 80, 2. And lastly, we have air entry. If bilaterally the air entry is equally present, 0. If the air entry is decreased, 1. If the air entry is absent, 2. Absent, 2. Right, so this is all about your distress scores. Now let's move to a very important topic, neonatal sepsis. Neonatal sepsis, that is sepsis in the neonatal age group. What is the most common cause? Which bacteria is the most common cause? So in India, the most common cause is Klebsiella. Klebsiella. Right, and over the world, the most common is group B streptococcus. Group B streptococcus. What are the risk factors for this sepsis? If we talk about early onset sepsis, that is the sepsis that is happening within 72 hours of life. That means here the reason of sepsis is through the mother. So here if there is prolonged labor more than 24 hours, that is a sign. This prolonged rupture of the membranes, again more than 24 hours, that is the risk factor. If there is spontaneous prematurity, that is a risk factor. If the mother has chorioamnionitis, that is a risk factor. If there is birth asphyxia, that is a risk factor. If there are multiple PV exams, it is said more than 3 sterile PVs or a single unclean PV is a risk factor. Then comes late onset sepsis, that is after 72 hours. So mostly here the source of infection is the surrounding. So poor hygiene, poor cord care, bottle feeding, all of these would be the reason of late onset sepsis. Here in late onset sepsis, the gold standard investigation would be your blood culture. Obviously, it is an infection scenario, so gold standard is your blood culture. Apart from that, we do, but blood culture, you all know, takes 3 to 4 days to come, report to come. Meanwhile, we do a screening test that is known as sepsis screen. What are the components of sepsis screen? We have 4 components: absolute neutrophil count, ANC, IT ratio, that is immature to total neutrophil count, right? And then we have CRP and micro ESR. So what is considered abnormal? If ANC is less than 1800 per microliter, that is abnormal. If CRP is more than 1 nanogram per deciliter, abnormal. Micro ESR more than 15 mm per hour, abnormal. IT ratio more than 0.2, abnormal. CRP more than 1 nanogram per ml, abnormal, right? So this is about sepsis screen. We need at least 2 out of these 4 to label it as positive. So what would be the treatment over here? It is infection scenario. We give IV antibiotics. The first line treatment here is ampicillin and gentamicin. If the features of meningitis are there, we give cefotaxime. And what would be the duration? If its sepsis screen came positive but the blood culture was sterile, we give it for 7 days, 1 week. If blood culture is positive, 14 days or 2 weeks. And if there is meningitis, then 21 days or 3 weeks. So remember, 1 week, 2 week, 3 week. When we are talking about neonatal sepsis, a very important infection, that is NEC, necrotizing enterocolitis, is to be here. And in NEC, what is important for you is Bell staging. In Bell staging, we have 3 stages, stage 1, 2 and 3. As we go down, the severity would be increases, right? So in stage 1, what happens? There is blood in stools. Right? Stage 1A, stage 1B. If there is occult blood in stools, stage 1A. If there is gross blood, even mother can see the blood, gross blood, this is stage 1B. In imaging, you won't see much features. Then in stage 2, what happens? You see a typical triad that is known as a metabolic triad. What do you see over here? There is thrombocytopenia, low platelets, hyponatremia, and metabolic acidosis. This is the triad that you see. Here, the 2A, 2B is on the basis of imaging features. If you see gas trapped in between the lining of the intestine, that is pneumatosis intestinalis. It is known as stage 2A, pneumatosis intestinalis. Then we have 2B. Here, if the gas is trapped in between the portal vein, that is pneumatosis portalis. Lastly, we have stage 3, stage 3A, stage 3B. So remember, in stage 1, we have 1A, 1B on the basis of clinical feature. In stage 2, we had 2A, 2B on the basis of imaging feature. In stage 3, we have 3A on the basis of clinical feature of peritonitis. And stage 3B is on the basis of imaging feature, that is perforation, air under diaphragm. Right? So whatever I have written over here are the key points that they ask in the exam. So remember this Bell staging, NEC, very important. Lastly, now comes a very important topic, that is neonatal resuscitation. One by one, we'll go over the one-liners, basic concepts. You all know the basics of NRP here. From the exam point of view, we're just going to revise. So what is the most important step in neonatal resuscitation? We know ventilation. Ventilation is the core of NRP. So ventilation is the most important step. What is the golden 1 minute? Golden 1 minute says that the effective ventilation should start within 60 seconds or 1 minute of the birth. The initial steps have to be done within 60 seconds. What are the initial steps of resuscitation? You warm the baby. right? Position the baby, P. Position the airway of the baby. You dry the baby, you stimulate the baby. So remember pads. Position the airway, that means sniffing position, dry the baby and suction the baby and stimulate the baby. So this stimulation has to be very gentle stimulation. You just flicker the soles of the baby or ear of the baby. Don't do slapping and everything, right? Head position for the airway we all know is a sniffing position. Remember routine suctioning. Tracheal routine suctioning is now not done. Not done. Routine suctioning is now not done. What is the normal heart rate? What is the normal heart rate of a newborn? It will be 100 to 160 per minute. If the heart rate is less than how many per minute that you start positive pressure ventilation, if the heart rate is less than 100 per minute, you start positive pressure ventilation. If the heart rate is less than 60 after 30 seconds of effective positive pressure ventilation, then you start chest compression. What is the compression to ventilation ratio? It is 3:1. What is the site of compression? The site of compression, remember, is just below the nipple. Just below nipple. And how much depth should be there while compression? The depth has to be 1/3 of the AP diameter of the chest. What is the best indicator for effective ventilation? It is the increase in the heart rate. That is the best indicator. What is the oxygen concentration that you are going to give for term neonates? 21%. For preterms, 21 to 30%. If the baby has labored breathing but the heart rate is more than 100, then what will you do? You will start with CPAP of positive pressure ventilation. Now let's talk about drugs. We understood that less than 60 after 30 seconds of effective positive ventilation you have to start chest compression. Now after how many seconds of chest compression you have to now start epinephrine. If the heart rate is again less than 60 after 60 seconds of coordinated ventilation and compression, you start epinephrine. What is the preferred route? It is the IV route. Through umbilical venous catheter we give this. What is the dose? 1:10,000 dilution of epinephrine we give 0.2 ml per kg. If no IV access is there, then we give intraosseous or intratracheal route. If you have to choose one, choose intraosseous route. If nothing is working, we suspect either there is some bleed or there is some pneumothorax. So volume expander that we give in suspected bleed, we give normal saline. Now let's talk about some special situations. This is the older concept. Older concept says if a meconium stained liquor baby is having good activity, heart rate is more than 100, then it is a vigorous baby. So heart rate more than 100, good activity is vigorous. But if heart rate is less than 100 or there is poor activity, it is a non-vigorous. Initially, non-vigorous babies tracheal suctioning was also done, but now no routine suctioning is done. Now we have to follow the normal steps. Remember, if the child needs immediate resuscitation, we do not do delayed cord clamping. What is delayed cord clamping? If everything is fine, we delay for 60 seconds for the clamping so that additional blood goes to the baby. This prevents anemia in future. So remember, delayed cord clamping is not done if the baby requires immediate resuscitation. With that, we covered the neonatology. Now, very few topics have been left. So let's start about the congenital infections, which is very favorite of your FMG. 3 infections we are going to discuss: toxoplasmosis, congenital rubella syndrome, and congenital CMV. So firstly, congenital infection, we discussed toxoplasmosis. What do you see? Again, a typical triad. What is this? Firstly, you see chorioretinitis, calcification, these are diffuse calcification, and hydrocephalus. Congenital rubella syndrome, what is the triad? What is the heart defect? PDA, patent ductus arteriosus, sensory neural hearing loss, and cataracts. In CMV, what is the triad? CMV, remember the triad is also CMV. C is chorioretinitis, M is microcephaly. V is periventricular calcification. Ventricular calcification. So these are the three important congenital infections that you need to know. Now with systemic pediatrics, now let's start with GIT. So when we talk about GIT, one thing in pediatrics that you need to mug up is diarrheas. What is the most common cause of diarrhea in pediatrics? Is it bacterial or is it viral? It's viral. It's viral. Right? That's why we don't prescribe antibiotics in pediatric diarrheas. Firstly, we treat supportively. What is amongst the bacteria? What is the most common cause? E. coli. And if there is loose stools along with the blood, this is known as dysentery. And what is the most common cause of dysentery? It's Shigella. In the management of diarrheas, as the most common pediatric diarrheas are viral diarrheas, the management here is treating the dehydration and giving zinc. So let's start the assessment and management of dehydration. Firstly, you are going to assess the dehydration, whether it is no dehydration, some dehydration, or severe dehydration. Right? What will happen in no dehydration? There is no dehydration, right? So this child's consciousness would be normal. Thirst would be normal. If you offer water to this child will very calmly drink the water. The thirst is normal. What about the skin pinch? If you pinch the skin, it will recoil immediately. The skin pinch is also normal. The eyes would also look normal to you. Here the plan that we are going to use is plan A. Then we have some dehydration here. Some degree of dehydration has started. This child would be very irritable. Child has very irritable. If you offer water to this child, the child will very eagerly drink this water. So his thirst is increased. This child will drink eagerly. Here the skin pinch would be delayed. Eyes will look sunken. And the plan of treatment that we use is plan B. Plan B. Then we have severe dehydration. In severe dehydration, now the child has undergone severe degrees of dehydration. So now the child would be very lethargic, comatose. Thirst, because this child is lying down comatose. If you offer water to this child, the child won't be able to drink the water. Unable to drink water. Skin punch would be very delayed, very slow. Eyes would be very sunken. And the plan that we give here is plan C. Now one by one, let's discuss plan A, plan B, plan C. So plan A. Plan A is the child of no dehydration. That means there is no degree of dehydration. You just have to replace the ongoing losses. How do we replace the ongoing losses? We give 10 ml per kg for every loose stool. So if it is a 10 kg child, so I will tell the mother that with every loose stool, give 100 ml of ORS. Give 100 ml of ORS, right? The plan A includes oral rehydration by ORS, 10 ml per kg per loose stool. Then we have plan B. Here some degree of dehydration have started. So firstly, we have to rehydrate this baby. How do you rehydrate? This child can drink water, eagerly drink water. So here also I will give ORS orally. Firstly, I will rehydrate. Give 75 ml per kg of this ORS over 4 hours. Needless to say, we have to ensure the replacement of the losses, same 10 ml per kg, and maintenance fluid have to be given. In plan C, now the child has severe dehydration and is not able to drink water. So here the plan would be giving IV. IV, what do we give? We give RL. So RL, ringer lactate is given. If they say what is the best, so you will say RL with D5 followed by RL followed by NS. Here the rehydration is in 30-70 correction. Initially you give 30 ml per kg bolus and then remaining 70 ml per kg. Total 100 ml per kg. Right? If the child is small child, less than 1 year, then I will give slowly. Over 1 hour this 30 ml and over 5 hours this 70 ml. Total 6 hours. If the child is above 1 year, then I can give faster in 30 minutes, 30 ml per kg, and in 2.5 hours, that is half of that, you will give 70 ml. So total 3 hours. Needless to say, replacement of the losses and maintenance fluid have to be given. Okay, so what is this maintenance fluid? We all know we employ holiday cigar formula to calculate this maintenance fluid. What is maintenance fluid? Something that we all need on daily basis. That is dependent upon the weight. For the first 10 kg, the amount is to be given is 100 ml per kg. For the next 10 kgs, that is 11 to 20 kg, we give 50 ml per kg. And thereafter, for every kg, 20 ml per kg. 20 ml per kg. This is the daily maintenance requirement that we all need. So after GIT, let's now talk about pneumonia's respiratory system. Pneumonias, you need to know about IMNCI guidelines. Before going into IMNCI guidelines, we need to know two things. What are the danger signs and what is fast breathing? So what is fast breathing? Less than 2 months, more than 60 breaths per minute. 2 to 12 months, more than 50 breaths per minute. And after 12 months, more than 40 breaths per minute. And what are the danger signs? Danger signs, if there is stridor in an otherwise calm child, if there is severe respiratory distress signs, severe retractions, if the saturation is less than 95% on room air, if there is inability to drink water, child is very lethargic, these are all danger signs. If the child has convulsions, all of these are danger signs. So now let's understand this IMNCI guidelines. IMNCI divides pneumonia into no pneumonias, pneumonia and severe pneumonia. No pneumonia means the child just have cold cough. So only cold cough would be there. No respiratory distress, no retractions. Here the treatment would be nothing, just supportive, soothing treatment you have to give. No antibiotic has to be given. If there is mild wheeze, you can give salbutamol. In pneumonia, what happens along with this cough, cold, fever, you're going to have signs of respiratory distress. That means there could be either increase in the respiratory rate, fast breathing, or retractions. Here you have to give antibiotics, but here you give oral antibiotics, oral amoxicillin for 5 days, right? And explain the danger signs to the caregiver. If any danger sign happens, then you have to follow up accordingly. In severe pneumonia, now you will have danger signs. If any of the danger sign is there, this is severe pneumonia. Here you have to refer to the higher center, give the first dose of IV antibiotic and refer to higher center. This is IMNCI guideline. Remember, in these severe pneumonias, you have to give first shot of antibiotic and then refer. If they ask which antibiotic, simple, you give ampicillin and gentamicin, give the first dose and then refer. In respiratory system, apart from pneumonia, one important topic for your FMG exam is cystic fibrosis. What is the inheritance of cystic fibrosis? It is an autosomal recessive condition, or autosomal dominant condition. What about cystic fibrosis? Now tell me, rapid fire. It'll go slow. Some topics are left now. What is cystic fibrosis? Is it a autosomal dominant condition or an autosomal recessive condition? If recessive, in which population you are going to see this cystic fibrosis? This is an autosomal recessive condition. It is an autosomal recessive condition. So you will see in population where there is consanguinity, right? And consanguineous marriage in Muslims, Jews, all of these consanguineous marriages take place. So here in these conditions you are going to see this. What is the most common, what is the chromosome location? Chromosome 7. You see this? Right? What is the most common mutation that you see? We see deletion of the phenylalanine at 508 position. Because of this CFTR protein, that is the chloride channel protein, it is not formed. And because of that, you have thick viscid secretions. You have salty skin. What is the most common pathogen that is affected in infancy and beyond? Remember, in infancy and childhood, Staph aureus is the most common pathogen. And in adulthood, it is Pseudomonas. Pseudomonas. What are the clinical features? I told you all the secretions would be very, very thick. So there would be thickening of the meconium, there will be meconium ileus, there will be pancreatic insufficiency, there will be rectal prolapse, liver involvement, male infertility. The diagnosis, we have a criteria. What is the criteria? You can either go for the gold standard test, that is the sweat chloride test. So the gold standard is measuring the sweat chloride levels. What is considered abnormal? If it is more than 60, that is considered abnormal. But this has to be in 2 or more than 2 separate occasions. Then we have genetic testing. 2 or more mutations if you have picked up, that is diagnosis of cystic fibrosis. Treatment, there is no specific treatment defined yet, but we have to just control the symptoms and prevent the complications. As the secretions are very thick, you'd give chest physiotherapy, postural drainage. We can also give some drugs to liquefy this thick secretions, Dornase alpha, hypertonic saline, antibiotics, prophylactic anti-pseudomonal antibiotics can be given, and pancreatic enzyme replacements like lipases, proteases, amylases with meals can also help. Some CFTR modulators, this in pharma you must have heard and read, Ivacaftor, Lumicaftor, these all are chloride channel potentiators. Then certain one-liners. They ask what is the earliest GI manifestations that you see in cystic fibrosis. The earliest one is meconium ileus. Meconium ileus. Earliest pulmonary pathogen is Staph aureus. The most characteristic pathogen is Pseudomonas. And most fatal one is that is associated with highest mortality is Burkholderia. Burkholderia. Right, so this is all about your cystic fibrosis. Now let's move down to CVS, cardiovascular system, congenital heart diseases. In congenital heart diseases, what is important is certain associations of this congenital heart diseases. Firstly, we are going to discuss some of the genetic conditions and the common associations that you see over here. Right, the first genetic disorder is Down syndrome. Remember Down syndrome? We read today only, discussed today only. What is the most common congenital association of congenital heart disease in Down syndrome? Yes, it is nothing but endocardial cushion defects. Endocardial cushion defects. Endocardial cushion defects. In Turner syndrome, we read left-sided heart. In Noonan, right-sided heart. Left-sided, bicuspid aortic valve, coarctation of aorta. Right-sided, pulmonary stenosis. Then we have Edward and Patau syndrome. What is Edward? Trisomy 18. What is Patau? Trisomy 13. What are the common associated CHDs over here? Ventricular septal defect. Then we have Dye-George syndrome. Dye-George syndrome, remember, catch 22. What was the common associated CHD over there? Conotruncal defects like TOF. Conotruncal defects. Then we have Williams syndrome, another microdeletion syndrome. Here the common association is supravalvular AS. Supravalvular aortic stenosis. Supravalvular AS. This was all about genetic syndromes and their commonly associated CHDs. The next important table is certain maternal conditions and the associated CHDs. So in certain maternal conditions, the risk of certain CHDs is high. So we are going to discuss that. Firstly, in GDM, if the mother has gestational diabetes, the baby is at higher chances of congenital heart disease. Which is the most common one that we encounter? Ventricular septal defect. And which is the most specific one? Transposition of great arteries, TGA. If the mother has rubella, baby can have congenital rubella syndrome. Here the most common CHD is PDA. Then we have alcohol consumption in the mother and phenytoin. That is fetal alcohol syndrome and fetal Hydantoin syndrome. In both of these conditions, VSD is the common associated CHD. If the mother has bipolar disorder and is taking lithium, which is the most common CHD over here? Epstein anomaly. Epstein anomaly. If mother has SLE and anti-Ro, anti-La antibodies, the baby has higher chances of developing heart blocks. Heart blocks. So there will be neonatal bradycardia. Neonatal bradycardia. Now let's discuss some of the X-rays here. X-rays over here. These are the X-rays of CHTs only that are very frequently asked in the exam. So first, what do you see over here? Figure of 8 appearance or snowman appearance. Where do you see this? We see this in TAPVC, supracardiac TAPVC. Then we have this boot-shaped heart. Where do you see this boot-shaped heart? Tetralogy of Fallot. Tetralogy means 4 components. What are these 4 components? We all understand there is pulmonary stenosis, ventricular septal defect, overriding aorta, and a right ventricular hypertrophy. These are the 4 tetralogy points. What is this box-shaped heart? What is box-shaped heart? Epstein anomaly associated with lithium consumption in the mother, Epstein anomaly. Then we have this egg on string appearance. This is seen in TGA. Right? Now let's end up this with pediatric epilepsy syndromes. Firstly, we have West syndrome. Where do you see West syndrome? What is the age group? Infancy, less than 1 year of age. What is the typical seizure type that you see over here? We see infantile spasms, salam spells. So remember a triad over here. First is the seizure. First part of the triad is the seizure. That is the infantile spasm. Second is a developmental finding. There is developmental regression. And third is the EEG finding. What is the typical EEG finding? You see a very chaotic pattern that is known as Hips arrhythmia. The treatment here is, drug of choice if they ask, it is ACTH or steroids. If both ACTH and steroids are given the option, please choose steroids. Sasta steroids, preferred in EAMS, so steroids. In cases of tuberous sclerosis with West syndrome, the drug of choice would be vigabatrin. Then we have Dravet syndrome. What is the age group? After 1 year of age. The onset is beyond infancy. What happens in Dravet syndrome? Initially, there will be febrile seizure. Then the child has seizure at low fever. Then afebrile seizures. And after 1 year of age, you see multiple types of seizures happening in this child. Here, the drug of choice is valproate. The newer drug over here is stiripentol. The new drug you need to remember in Dravet syndrome is stiripentol. Then we have LGS, Lennox-Gastaut syndrome. This happens after 2 years of age. What happens in Lennox-Gastaut? Again a triad. You will see seizure. There are multiple types of seizures that is happening, difficult to treat epilepsy. Developmental regression is there. And typical EEG finding, that is 2 to 3 Hertz spike and wave complex. Treatment here is again valproate. Then we have Jan syndrome or JME, juvenile myoclonic epilepsy, that you see in adolescent females. What happens in this adolescent females? Upon awakening, you will see myoclonic jerks upon awakening that are precipitated with sleep deprivation and alcohol consumption. Here the typical EEG is 4 to 6 polyspike wave complex. Here the drug of choice again is valproate. Other alternative is levetiracetam. Then we have absent seizures. Absent seizures, in which age group do you see absent seizures? In school-going children. Right, school-going children. You see this absent seizures where there are brief episodes of vacant staring look. And the typical EEG is 3 Hertz spike and wave. What is the drug of choice? Ethosuximide. But if ethosuximide is not in the option, choose valproate. Right? So this is about the pediatric epilepsy syndromes. With that, we can end the session now. This was a brief session. We took around 2 hours as expected. This was a rapid session. I know a lot of concepts are there if we go into depth, but at this stage, you just need to revise, and that's what we did over here. Right? All the best for your exam. I wish you all the very best. Pediatrics is a sure shot game in cases of FMG. They don't give any twisted questions. If any twisted questions are there, that are from NRP, and in NRP, I have discussed a lot of one liners with you, what they ask in the exam. With that, we can end the session. Thank you, everyone. बिल्कुल दिमाग नहीं लगाया मैंने
हाँ
Yes, good evening all. Shall we start forensic medicine and toxicology? Am I audible? Am I audible, guys? Hi, 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 hi. Hello, everyone. Am I audible? Yes, Dhananjay. Yes, Shubhakar. Good evening, all. Good evening. Shall we start forensic medicine? Yeah, forensic medicine, as you know, one of the very important subject and scoring subject. Usually there will be 10 questions, 8 to 10 questions, and all 10 questions usually from standard concepts. Very important subject. Okay, so let's start. Okay. Yes, Dhananjay. Okay, let's start. So this is a workbook that is provided. Okay, around 30-40 pages of notes. I just made entire workbook in a question answer session just to make the class interesting and to make interactive. So let's start. The first question, very commonly asked question, बार बार पूछते एग्जाम में, which of the following define offenses and punishment? Define offenses, like example rape, the punishment for rape, 63, 64. So BNS, BNSS, BSA and TOTA. The BNS is Bharatiya Nyaya Samhita, BNSS Bharatiya Nagarika Suraksha Samhita, BSA Bharatiya Sakshya Adhiniyama, TOTA is nothing but Organ Transplantation Act. So what would be the best answer? Can you try, guys? Yes, can you try? Try, you just keep answering, guys. Keep answering. All is a repeat question asked in FMGE in recent last 3 or 4 years. So let's make it interactive. Yes, come on, guys. Dhananjay and others. Yes, so answer is BNS. So very good. The answer is BNS. So try to remember, BNS define offenses. It also gives punishment. BNSS basically criminal procedure code that defines the criminal procedure. And BSA basically Bharatiya Sakshya Adhiniyama, that is for evidence. So let's see what are important questions that can be asked. So the one very commonly asked, 63 BNS. 63 matlab definition of rape. 64 punishment for rape. याद रखना पड़ेगा आपको. 66 rape and murder. 67 that is sexual intercourse by husband during separation without her consent. That is 67. 68 that is sexual intercourse by a person, usually an authority, with her consent by using his custodial power. That is basically 68. 70 that is gang rape. G70 that is basically gang rape. 71 repeat offender. 80 to 90 BNS, very commonly asked. Can anyone answer? What is 88, 89 and 90 BNS? Can anyone try? Come on, Dhananjay, what is the best answer? So the best answer for this is criminal abortion. Okay. So 88 criminal abortion with consent. 89 criminal abortion without consent. And 90 criminal abortion leading to death of the female. Very commonly asked in FMG. FMG question. Commonly asked. Yes, Gurisha, good. Good. All are answering. That's great. So 22. Again, repeat question in FMGE. Commonly asked. Last year question. What is 22 BNS? Can anyone answer? FMGE question. 22 BNS. So 22 is basically McNaughton's rule. McNaughton's rule. So आपको याद रखना पड़ेगा 22 BNS is criminal responsibility of insane person. That is the person suffering from illness, mental illness. It can be schizophrenia, bipolar disease, depression, can anything. So all these are very commonly asked. You need to revise. ठीक है? Yes, good. तो आगे देखते हैं. So this is very important table. Shall I move ahead, guys? Dhananjay and others. Shekhar Pratap. Yes, perjury is also asked. Menak Datta, very good. Perjury, commonly asked, that is 227 BNS and 229 BNS. So this is also again important question in FMGE. All of you try to understand. Perjury matlab, that is giving false evidence. The definition given by 227 BNS, the punishment given by 229 BNS. Okay, commonly asked. चलो ठीक है, आगे देखते हैं next question. And I have a question for you. Okay, husband having intercourse with the wife of age less than 18 years. The wife is juvenile. Amounts to rape if case is filed within 1 year. Is it true or false? Is it true or false? Yes, guys. Yes, come on, guys. Can you try this? Try. Yeah, Guru Kumar, yes, medical negligence 106 BNS. 116 grievous hurt. Again, this question will come in the upcoming slides. So, the answer is true. If the case is filed within 1 year, 1 साल के अंदर, if case is filed, then it is definitely rape. So, also this can be asked in your exam, that is true. ठीक है. And one more FMJ question, what do you mean by juvenile? So, juvenile means less than 18 year. याद रखना पड़ेगा आपको. Male or female less than 18 year. Very commonly asked in FMGE, that is juvenile. Balaparad, we say balaparad, that is less than 18. ठीक है, चलो. So the next question from mechanical asphyxia. As I discussed many times in my classes, 4 important topics. Hanging, strangulation, suffocation, drowning, very commonly asked. आपको पढ़ना ही पड़ेगा. Following is the surest sign of antemortem hanging. Antemortem मतलब the person was alive at the time of death. Options are dribbling of saliva, ligature mark, left edge sympathic, head bone fracture. Head bone fracture. चलो बताओ जल्दी बताओ guys. So the answer is dribbling of saliva. Dribbling of saliva is a feature of antemortem hanging. The feature of antemortem burn injury, soothe particles. The feature of antemortem drowning, that is basically cadaveric spasm. So 3 important question, FMG question. So antemortem hanging, याद रखना dribbling of saliva. Antemortem burn injury, याद रखना soothe particles. Antemortem drowning, that is basically cadaveric spasm. 3 important question, FMG पक्का question. ठीक है. Then ligature mark. So ligature mark is oblique in hanging. याद रखना पड़ेगा आपको. FMG question. Oblique. Transverse in ligature strangulation. Okay. So transverse in ligature strangulation. ठीक है. Oblique in hanging, transverse in ligature strangulation. One more important question. It can be transverse in hanging, especially in case of partial hanging. Repeat question from FMG. Okay, good. Chalo. Left edge sympathic, very important. Left edge sympathic means one eye is open, other eye is closed because of compression of cervical sympathetic chain. Repeat question FMG. Head bone fracture. Outward fracture is very common. Outward fracture is common. Outward fracture is hanging. Inward fracture is throttling. Both are important question. Commonly asked in the exam. चलो ठीक है. Good. चलो आगे देखते हैं. Look at this now. Can anyone identify what is this finding here? Look at this. The person, a hanging person, one eye is open, other eye is closed, and knot is on the same side. The eye is open. The eye is open. Pupil is dilated. What is this known as? Can anyone tell me what is this? What is this? Come on, guys. Commonly asked in the exam. So this is classical left facies sympathic. LFS. It is normally seen in 20 to 30% of the cases. But remember, it is not specific. It is because of compression of cervical sympathetic chain. CSC. आपको याद रखना पड़ेगा. CSC, cervical sympathetic chain. When compression of cervical sympathetic chain leads to left facies sympathic. Very important FMG question. बार पूछते एग्जाम में. ठीक है? Good. चलो. So this is what given in your notes. Just go through the notes, all of you guys. Ligature mark features, salivary dribbling, all these are features commonly asked. Hello. हाँ, नेक्स्ट क्वेश्चन, वेरी इंपॉर्टेंट क्वेश्चन, कॉमनली आस्क्ड इन द एग्जाम, आपको याद रखना पड़ेगा. मैनर ऑफ डेथ इन ऑटोइरोटिक हैंगिंग. Autoerotic hanging means that is hanging and death during masturbation or during sexual paraphilia, like example transvestism, petakism. So best answer suicidal, homicidal, accidental, judicial. बार बार पूछते एग्जाम में, याद रखना पड़ेगा. Autoerotic hanging commonly associated with sexual paraphilia. What is the best answer, guys? Come on, try guys. So suicide is not the answer. Homicide is known as lynching. FMGE question. Lynching, that is homicidal hanging. Judicial hanging, C2, C3 fracture. Hangman fracture, very commonly asked in FMGE. What is the best answer then? The answer is, all of you guys try to understand, the answer is accidental. It's common in males. It can be seen in females also. So this is very, very commonly asked. One more commonly asked in exam, harakiri. Harakiri is a suicidal stab wound. Harakiri. Harakiri is a suicidal stab wound. Commonly asked. Yes, guys. Okay. So this is classical case of autoerotic hanging. What we can see here, the person is naked and person is involved in masturbation in front of the mirror. Seminal stains are there. So this is classical Coatswarism or autoerotic hanging. Okay, good answer. Shekhar Pratap Singh, good. चलो आगे देखते हैं. Now look at this question. Try to identify what are types of hanging. Types of hanging very commonly asked depending upon the suspension of the body. If knot is there at the occiput, that is known as typical hanging. Knot either hoga right side left mandible, atypical hanging. If it is at the chin, judicial hanging bolte हैं हम लोग. What is this type of hanging depending upon the suspension? Commonly asked. Good, Menak Datta, that's great. So this is basically complete hanging and partial hanging. So complete hanging, total body is suspended. The weight of the person acts as a constricting force. Okay, weight of the person. So here it is weight of the person. Here it is weight of the head. Weight of the head acts as a constricting force. Both are very commonly asked. Okay, good. चलो, complete and partial hanging बार बार पूछते एग्जाम में, आपको पढ़ना ही पड़ेगा. Next comes is mechanical injuries. Very important FMGE question, guys. Injuries caused by blunt force except blunt force. So blunt force example, see this is the blunt force. Look at this blunt force, है ना? Head injury due to a bat. Look at this bat. And IPL is nearby, है ना? So blunt force injury, what are they? Blunt force injuries are abrasion, bruise, laceration. को पढ़ना ही पड़ेगा. Okay? Blunt force injury. Sharp force injuries are basically incised wound and stab wound. Incised wound and stab wound. ठीक है? Yes. याद रखना पड़ेगा आपको, बार बार पूछते एग्जाम में. ठीक है? So what are blunt force injuries? तो blunt force में आता है, एक होता है abrasion होता है एक, दूसरा होता है contusion, तीसरा है laceration. Laceration. Sharp force. Sharp force में दो टाइप है. इसमें होता है एक stab wound है, एक और है incised wound. Incised wound. ठीक है? चलो. Now can anyone answer what is the commonest type of injury in road traffic accident? In RTA, what is the commonest injury? Most common. Can anyone try? Can anyone try, guys? What is the most common injury? So most common injury is abrasion. Abrasion, and most common abrasion is graze abrasion. आपको याद रखना पड़ेगा, brush burn, graze abrasion, both are same. That is the commonest abrasion in road traffic accident. ठीक है? Then good, abrasion. So abrasion, again there are four types: graze abrasion, imprint abrasion, pressure abrasion and scratch abrasion. Scratch abrasion. So laceration, again there are 4 types: split laceration, cut laceration, tear laceration, stretch laceration, owl's laceration. Owl's laceration. The commonest one over the bony prominences, split laceration, commonly asked in the exam. Split laceration looks like a incised wound, incised looking laceration, commonly asked. Very important, आपको पढ़ना ही पड़ेगा, ठीक है? So there are 5 types are there. In avulsion you will see flaying. Avulsion में आपको मिलेगा flaying, मिलेगा आपको. Flaying मतलब detachment होगा, ठीक है? So this is also very commonly asked. ठीक है, चलो आगे देखते हैं. Now what are types of incised wound? Can anyone tell me what are types of incised wound? Dhananjay, what are the types of incised wound? Incised wound, come on, try, come on guys. So incised wound of 2 types: suicidal, it can be homicidal, accidental. So in suicidal you will see hesitation cuts, in homicidal you will see defense injuries, and accidental, so accidental nature. Stab wound, again 3 types: penetrating, perforating, and penetrating, and through and through wound. Through and through. So there are basically 3 types. 3 types. So this is again commonly asked. So in laceration you will see irregular margin. In case of incised wound you will see regular margin, commonly asked. So the best answer here is, that is stab wound. So the stab wound is caused by sharp weapon. Okay, चल आगे देखते हैं. So can anyone identify this image? What type of abrasion is visible there? Punctured, yeah, Menak Datta, punctured. Yes, you are right, punctured, that is. Punctured. That's great. So what is this actually? This is the case of road traffic accident. And during postmortem examination, what we found? Parallel lines. So parallel lines are there over the body. So what type of abrasion is this? This is very common in postmortem, very common in forensic medicine. What is this basically? And on the other hand, what you can see here, this is the case of road traffic accident. You can see the imprint of the weapon, imprint of the tire mark. What is this known as? Come on, try. So this is basically pattern abrasion. Pattern abrasion or imprint abrasion or impact abrasion, and this is graze abrasion. Graze abrasion. So both are very commonly asked in FMGE, commonly asked in your exam. बार बार पढ़ना पड़ेगा आपको, ठीक है? Good. चलो, so आगे देखते हैं. Next question. Now this is from the again mechanical injury. All are features of incised wound except incised wound. So incised wound is caused by sharp weapon. Margins are clean cut and averted, caused by the sharp weapon. Spindle shaped, presence of tissue bridging. Tissue bridging. Dhananjay, Shekhar Pratap Singh and others. What is the best answer for this? All are features of incised wound. So incised wound caused by sharp weapon and it has clean cut margin. Clean cut margin. So tissue bridging is seen in laceration. In case of laceration, not in case of incised wound. Good. Answer is D. That's great. So you can see here, this is a classical tissue bridging, irregular margin, and this is a tissue bridging. There can be blood vessel bridging, neuro bridging also. That is classical of laceration. Laceration caused by blunt object. तो blunt object होगा, margins irregular होगा. आपको क्या मिलेगा? Tissue bridges मिलेगा. ठीक है? बस हो गया. Chalo, look at this now. One more image from the mechanical injury. This is a case of homicide. This is the case of murder. क्या finding है? Can anyone tell me? What is this finding known as? Come on guys, what is this finding known as? Try. Very commonly asked in FMGE, INA, CET also. So this was a case of homicide. Homicide, murder for some issue, maybe, a financial issue, some revenge, some rivalry. I know. So what is this basically? So this is basically defense injury. Defense injury. So defense injury commonly have two types, active and passive. The active common site is palm. The passive common site is forearm, the back of the forearm. So when person tries to protect him by giving hand like this, so this is passive. When he will try to grab the weapon, then it is known as active. So active कहाँ पे होगा? Palm में होगा. In the web spaces. Passive कहाँ पे होगा? Over the dorsum of the hand or the dorsum of the forearm. तो बार बार पूछते एग्जाम में आपको पढ़ना ही पड़ेगा. ठीक है? Defense injury basically two types. ठीक है? Active and passive. चलो हो गया. So this is okay. Then now look at this and try to answer, guys. What are these two types? A क्या होता है और B क्या है? चलो identify. Let's see who can identify this. Look at this. This is a palm. Over the palmar surface, there is a defense injury. Look at this. On the back of the hand, there is a defense injury. What is this? A and B. A and B. Come on, try to answer. Try. Come on, guys. Try. Dhananjay, Shekhar, Pratap, and others. Okay. Swiggy Mood is telling Sajal, very good, beta, excellent answer. So A is basically active. So this is active. And this is passive. Passive. FMGE favorite question. Favorite of FMGE. Okay? Good answer. Good. Umme Sania. That's great. चल आगे देखते हैं next question. Next topic क्या है? So this is again very important question. Suicidal cutthroat or homicidal cutthroat differences commonly asked given in your book. So all are features of suicidal cutthroat injuries except लिखा है. So suicidal. Again, it depends on the right-handed person, left-handed person. Presence of tentative cuts. ठीक है? Yes, suicidal cuts are seen. Only one wound is deep. Rest all are superficial. Presence of cadaveric spasm. Very commonly seen. Presence of defense wound. Remember, defense wound commonly seen in murder, homicide. ठीक है? So not in the suicidal. So answer is basically D. Again, remember cadaveric spasm is antemortem. It's a differential diagnosis of rigor mortis. बार पूछते exam. Cadaveric spasm is the antemortem finding, contraction of the muscles of the forearm and the arm, selected voluntary muscles. That is the feature of antemortem phenomena. Rigor mortis is postmortem. Okay, good. That is great. Many answering. That's fine. ठीक है. So again, the differences between suicidal cutthroat and homicidal cutthroat that is given in the workbook. So I will provide you these notes after the class. Just go through this and try to memorize this and around 5-10 minutes, maximum 5 minutes to read this. Okay? Chalo, okay. Next question. Now. Next question from the firearm injury. बार पूछते एग्जाम में firearm. है ना? Firearm injury. ठीक है? What is contact entry wound, close entry wound, what is near entry wound and distant entry wound, bomb blast injury, commonly asked in the exam. So firearm injury. So what all the features of firearm entry wound? Entry wound लिखा है. Exit wound नहीं, entry wound. Except लिखा है. Abrasion collar is the feature of entry wound. ठीक है? Abrasion collar because of the spinning movement. Okay, spinning movement of the bullet. Averted margin seen in exit wound. Entry wound में क्या मिलेगा आपको? Inverted margin. Presence of blackening? Yes. It's because of the soot particle. Tattooing is because of the gunpowder. So what is the best answer? So the answer is B. So आपको याद रखना पड़ेगा, inverted margins are seen in entry wound, everted margins are seen in exit wound. Done, it is done. So commonly asked in the exam. Good answer, good. Swiggy mode and others. Now here one more question commonly asked in the exam is, so basically difference between entry wound and exit wound. Just go through these notes. Okay, yes, chalo. Blast injury. So blast injury can be air blast, underwater blast, solid blast. Secondary blast injury is caused by, repeat question, FMG repeat, blast injury. So blast because of the multi-directional wave. So it can affect your organs. So primary blast injury, secondary blast injury, tertiary, quaternary and quinary. So there are basically 5 types. So primary, secondary, tertiary and quaternary. So primary आपको याद रखना पड़ेगा, primary is because of the blast wave. What are the common organs affected? Eardrum, lungs, intestine. Okay, so tympanic membrane, lung, intestine. Secondary because of the flying projectiles. So flying projectile. Tertiary is because of victim displacement. And quaternary because of the structural damage. The quinary is because of the radiation. That is usually in the atomic blast. So there are basically 4 types. Secondary blast injury is caused by. So answer is no. A is not the answer. C is not the answer. D is not the answer. Answer is flying missiles. Okay? So answer is flying missiles. Many answered. That's great. So that's really nice. Good. चलो आगे देखते हैं next question. Okay. Now look at this. This is the injury known as secondary blast injury, known as Marshall injury, Marshall triad. चलो आगे देखते हैं. Then torture method. One more frequently asked in the exam, Menak Datta and others. Identify the torture method. Torture. Commonly asked in FMGE forensic medicine, INACT forensic medicine. What is this torture method known as? So there are 4 torture methods are there. Can identify these torture methods? What is this torture method? That is suspension of body towards a beam. Then beating on the palm and soles. What is that known as? Standing on the leg, keeping some weight on the thighs leads to extreme pain. And what about this? Try to understand. This is very commonly asked. So this is parrot perch. This is dry submarine. It leads to suffocation and death. This is gotna. So gotna matlab the keeping a pole on the thigh and walking on that pole. So that leads to extreme degree of pain. बहुत दर्द होता है इसमें. ठीक है? So this is basically gotna. So phalanga. This is phalanga basically. So phalanga. All these are commonly asked in FMGE. याद रखना पड़ेगा आपको. याद रखना पड़ेगा. ठीक है? So gotna. ठीक है? Good. That's great. चलो. So after the class, just go through all the torture method. And before that, can I identify what is this torture method? This torture method. What we can see here, extreme degree of bruise is there. Contusion is there. So because of the extreme trauma, because of the torture. What is the probable torture method here? Look at this, try to answer. Try to answer, guys. What is this? So this is known as phalanga. What is this known as? Phalanga. So this is known as phalanga. Phalanga. Okay. Good answer. Many answer. That's great. So that's great. That's great. Chalo. Okay, this is also okay. So this is parrot perch. So try to memorize this. Parrot perch cause of death is positional asphyxia. Okay. So what is the cause of death here? Positional asphyxia. Positional asphyxia. Okay. Good. Okay, guys. Is it okay? Is it okay, guys? So yes or no? So we are going little fast because exam is nearby. It's a marathon session, not the regular lecture. So that's why. Say yes or no, guys. Cause of death is positional asphyxia. Good. Next. So after the class, just go through these methods. Phalanga, telephono, wet submarine, dry submarine, parrot perch, cattle prod, commonly as cattle prod, chapua, gotna, sham execution, dunking, and declaration of Tokyo. The declaration of Tokyo related to the torture. So this is also once asked in the exam, in FMGE exam. So all these are commonly asked. Yes, good. So then one question very commonly asked from the burn injuries, either from rule of 9 or from heat stroke or heat syncope or heat burn, that is basically a scald burn also. So true about heat stroke. See, whenever question asks stroke matlab involvement of cerebrum, that is hypothalamus. So hypothalamus controls body temperature. As you know, anterior hypothalamus controls heat, posterior hypothalamus controls cold. Impaired consciousness, presence of sweating, cerebral dysfunction, core temperature more than 41. So yes, come on guys. Impaired consciousness, that is seen, that is true. Presence of sweating, no. Sweating is absent in heat stroke. Cerebral dysfunction, that is also correct. Core temperature more than 41, that is also correct. So answer is B. So B is the best answer. The basic difference between heat stroke and heat syncope is the presence and absence of the sweating. So absence of sweating in case of heat stroke as well as sunstroke. In heat stroke and sunstroke, you will see that is postmortem caloricity. Postmortem caloricity. That is rise in the body temperature for about 2 to 3 hours after death. One of the causes is sunstroke. Yes, good. Then one more very commonly asked question, rule of 9. So as you know, rule of 9 basically used for estimation of the burn injury and also for the treatment, basically for the Parkland formula. And also it shows the survival. Okay. So a 30-year-old married female presented with the burn injury. So this is basically a case of dowry death. So dowry death. So dowry death, that is 80 BNS. Autopsy is conducted by magistrate. That comes under 196 BNSs. Within 7 years of marriage. The punishment is 7 years to life imprisonment. So involving entire abdomen, that means 18. Both lower limbs, that is 18 plus 18. So kitna hoga? So the answer is basically 54. So 54 is the answer. A is the correct answer. So आपको याद रखना पड़ेगा rule of 9. Okay. So rule of 9, head and neck area 9%. Arm is 9%. Trunk and front and back, that is 18%. Genital area 1%. And leg, that is around 18%. So this is commonly asked in the exam. Can anyone tell me what is the rule that is used in children? What is the rule that is used in children? What is the rule used in scattered bone injury? Scattered bone injury. Both are FMGE question. FMGE question. Come on guys, come on, try. So in children we use LB formula. And in scattered bone we use Palmer rule. So both are commonly asked. So 1 palm is equal to 1%. 1 patient palm is equal to 1%. LB formula used in children's. So both are frequently asked. Okay? Good. Good. That's great. Then comes is postmortem artifacts. See, postmortem artifacts are non-specific. It can be heat rupture, it can be heat lacerations, it can be heat hematoma, heat fractures and all. Specific finding in antemortem burn. Antemortem matlab person was alive. Heat hematoma, that is a basically artifact, that is non-specific finding. Non-specific. The heat hematoma, so you will see Swiss cheese appearance. Heat fracture, so commonly seen over the temporoparietal area, non-specific. Pugilistic attitude, that is because of the coagulation of protein. Line of redness, so line of redness, sign of inflammation matlab antemortem. So the answer is D. So answer is D. But remember, the best feature is soothe particles. Soothe particles in the lungs and in the trachea. And in the trachea, that is the feature of trachea. चलो आगे देखते हैं. Good, many answers. So what is this finding? Can anyone tell me what is this finding here? Look at this and try to answer. Come on guys, try. What is the picture here? What is the finding here? So this is basically pugilistic attitude. So pugilistic attitude can be antemortem, it can be postmortem. When temperature more than 70 degrees Celsius, that leads to this pugilistic attitude because of coagulation of proteins. So this is also known as Boxer's attitude. So commonly asked. Defense attitude, Boxer's attitude, that is a correct answer. Vipin Sharma, that's great. Okay, good. Now look at this again, bone injury. A case of accidental bone injury. What is the finding here? Can anyone identify? What are the finding here? Can you see the ohm here? That is the tattoo mark. Remember, tattoo can be identified by looking at the tattoo or by looking at the lymph node. So what is this finding? 1 and 2. So 1, that is shows blisters. Blisters. So blister consists of proteins. Is a feature of antemortem burn injury. Blisters consist of only air. Then it is a feature of postmortem blister. So blisters consist of proteins. Antemortem. And this is a blister and this is a line of redness. So line of redness, soothe particle and blister, they are the features of antemortem bone injury along with the carboxyhemoglobin. Okay? Yes, good. Good, many answering, that's really nice. So tattoo, just remember the question asked in FMGE, lymph node. आगे देखते हैं. Now the one more question about the tattoo. So tattoo can give you some idea about the religion. It can also give an idea about the personality. It also can give idea about the identification. Now look at this bluebird sign. The bluebird sign tattoo over the web finger between the two finger, thumb and the ring finger. or the index finger. What is this basically known as? So this is basically a tattoo. So tattoo is a feature of identification. Bluebird sign. Bluebird sign is a feature of homosexuality. Homosexuality. Okay, homosexual. So sodomy, the question can be asked. Sodomy matlab anal intercourse, है ना? Sodomy. Again, very commonly asked in the exam. The passive agent in sodomy. What is the name given to that? Passive agent in sodomy. क्या बोलते हैं इसको? Passive agent in sodomy known as. ठीक है, Manak Datta and others. Active agent is basically pedophilia. Passive agent in sodomy, asked in FMGE. So the answer is basically catamite. So catamite is passive agent. So this question was asked in university exam. In one of the university exam, one student wrote about the cat and mite. In detail about the cat, types of cat and the mite, scrub typhus and all. Catamite in forensic medicine, basically it is the passive agent in sodomy. Okay, so try to memorize this. So Manak Datta, that's great. Good. Yes, good. Now again, one more question asked. Female homosexuality. Female homosexuality. Female homo. So what is the active agent known as? Active agent को क्या बोलते हैं? Passive agent को हम क्या बोलते हैं? Both are very commonly asked. Female homosexuality known as lesbianism. It is not punishable in India. But question asked in exam, female homosexuality, active agent को हम क्या बोलते हैं? ठीक है? तो active agent को हम बोलते हैं डाइक. पैसिव हम बोलते हैं फेमे. FMGE क्वेश्चन. ठीक है? फेमे. ठीक है? ट्राइबैडिज्म, लेस्बियनिज्म. आगे देखते हैं. वन मोर क्वेश्चन. ठीक है. Satyriasis. One more question asked. Satyriasis. The satyriasis means excessive impulsive sexual behavior in males. Opposite in females. Excessive sexual behavior, irresistible sexual behavior in females known as nymphomania. So both are commonly asked. Nymphomania, that is in females. Okay, that is in females. याद रखना पड़ेगा आपको. Satyriasis and nymphomania. Yes guys, hope you understanding, getting my point guys. All are repeat questions. All are repeat questions. ठीक है, आगे देखते हैं. Now look at this. Now I am in शव परीक्षा room. I am in the postmortem room. But look at the lungs here. In the lungs I can see black particles there. What is this known as? What is the importance of this? Can you identify this? Yes, Guru Kumar, Dinesh. क्या है बताओ. Now I am in autopsy room. So I am examining dead body. As you know, thanatology, postmortem changes. तो लंग में क्या फाइंडिंग है? लंग में डार्क पार्टिकल्स है. कार्बोक्सी hemoglobin in the blood. Antemortem bone injury. What is this basically? Come on, try this. Try. So these are basically known as soot particle. Soot particles. Soot particles are feature of antemortem bone injury. Antemortem bone. ठीक है, गुड. Now, Vishnaki spots are seen in stomach, not in the lungs. Wish spots that are seen in the stomach, not in the lungs. This is basically lung. ये lung है, ठीक है, ठीक है, good. चल आगे देखते हैं. Now one more very important question. Cause of death in below case of postmortem staining. Now look at this. Now I am in Shav Pariksha room. The postmortem staining color is cherry red color. Look at this. Normal color is brown color. The here color is cherry red color because of the carboxyhemoglobin, which is known as silent death. Silent death in case of burn injury. Now, can anyone tell me what is this known as and what is the probable cause of death? बार बार पूछते एग्जाम में. So this is basically carbon monoxide poison. So कार्बन मोनोऑक्साइड में आपको चेरी रेड मिलेगा. क्या कलर है? चेरी रेड कलर है. तो चेरी फ्रूट आपको पता है, चेरी फ्रूट कलर है. तो हाइड्रोजन सल्फाइड यू विल गेट ग्रीन कलर. येलो फास्फोरस येलो कलर. ओपीएम में क्या होगा? ब्लैक कलर होगा. ओपीएम में क्या है? ब्लैक कलर होगा. नाउ वन मोर क्वेश्चन हियर. What is this finding? What is this area known as? What is this area? Good. What is this area? Come on, try this. So this is postmortem staining showing regular margin, and here on the back at the site of compressed area postmortem staining is absent. इसको हम क्या बोलते हैं? चलो बताओ जल्दी. क्या है? क्या है? जल्दी बताओ. Come on, try this. So this is basically known as contact flattening or contact pallor. So आपको याद रखना पड़ेगा contact pallor, that is the area of no postmortem staining. It's the area of compression. दूसरा, this postmortem staining has regular margin. Regular margins. In case of postmortem staining, it is regular margin. In case of contusion, it has irregular margin. So this is again commonly asked in the exam. Pressure area. Very good. Good answer. Good. So many the answering. That's really nice. That's great. So after the class, just go through this important table. Phosphorus yellow, carbon monoxide cherry red, nitrate chocolate or copper brown, hydrogen cyanide pink or bright red, refrigeration bright pink, opium black, hydrogen sulfide green, clostridium leads to greenish or bronze. Okay, commonly asked in the exam. Can anyone tell me what is the syndrome caused by yellow phosphorus? Yellow phosphorus can lead to a syndrome, especially acute yellow phosphorus poison. The phosphorus is known as Diwali poison. So because of the ingestion of the yellow phosphorus, so the stool become some vapors will come from the stool. इसको हम क्या बोलते हैं? Can anyone tell me? Commonly asked. So this is known as smoking stool syndrome. आपको याद रखना पड़ेगा smoking stool syndrome. Smoking stool syndrome, that is basically a acute condition in which the vapors of phosphorus are coming from the stool. Smoking stool syndrome. Stool मतलब yellow, dirty fellow, that is basically yellow phosphorus. ठीक है? Phosija, again that is also asked in the exam. ठीक है, बढ़िया. ठीक है, आगे देखते हैं. Rape is defined under section dash BNS. As you know, rape is a heinous crime. It's a heinous crime. It is a punishable offense, life imprisonment or death sentence. If it is gang rape and death and murder, rape and murder, death sentence. Rape defined under what BNS? 63, 64, 80, 116. All four are important. So the rape definition given by 63. So rape can be penetration, insertion, manipulation, application of the mouth. That is 63. 64 क्या है? Punishment है. 80 क्या है? 80 है dowry death. Dowry death. So 116 grievous hurt. 116 grievous hurt. मतलब सीरियस हर्ट. 116 मतलब सीरियस हर्ट, घोर आघात करना, सीरियस इंजुरी करना, सो सीरियस चोट, इसको बेसिकली 116. तो 80 में क्या है? दहेज डेथ, डाउरी डेथ. 64 दैट इज द बेसिकली पनिशमेंट फॉर रेप. पनिशमेंट फॉर रेप, डाउरी 80. याद रखना पड़ेगा आपको. ठीक है, गुड. नाउ देयर इज अ क्वेश्चन. So touching labia majora. Touching labia majora. Is it rape or not a rape? So there is a condition, there is no penetration, but touching labia majora. Is it rape or not a rape? Can anyone tell me? Yes, never. Very पूरा completed notes है आपको चलेगा. ठीक है, एनफ है, एनफ. ठीक है. कैन एनीवन टेल मी टचिंग लेबिया मेजर इज इट रेप और नॉट ए रेप? यस, सो इट इज अ रेप. आपको याद रखना पड़ेगा एफएमजी क्वेश्चन. सो कंप्लीट पेनिट्रेशन इज नॉट नीडेड, इवन टचिंग द लेबिया मेजोरा कैन बी रेप. सो दिस इज अगेन कॉमनली आस्क्ड. एक और आपको याद रखना पड़ेगा 194 BNSS and 196 BNSS. एक और याद रखना पड़ेगा 52 BNSS. 52 BNSS. All the three FMG repeats. 194 क्या है? पुलिस इंक्वेस्ट. 196 मैजिस्ट्रेट इंक्वेस्ट. 52 BNSS examination of accused of rape. And 184 BNSS that is victim examination. तो बार बार पूछते एग्जाम में, आपको पढ़ना ही पड़ेगा. याद रखना 194 पुलिस इंक्वेस्ट, 196 मैजिस्ट्रेट इंक्वेस्ट, 52 अक्यूज एग्जामिनेशन, अक्यूज ऑफ रेप. विक्टिम एग्जामिनेशन क्या है? 184. ठीक है, ठीक है, चलो बढ़िया. ठीक है, दिनेश and others. So Manak Datta, good. Manak Datta is writing few points here there. That's great of you, Manak Datta. So this is more than sufficient बेटा. फोरेंसिक के लिए ये more than sufficient है. आपको पढ़ना ही पड़ेगा. ये सब नोट्स क्लास के बाद go through this notes sufficient है. ठीक है, almost everything is covered. Important questions. ठीक है. So grievous hurt. How many classes are there in grievous hurt? Can anyone tell me? How many classes are there in grievous hurt? 8 clauses. 8 clauses है. इसमें एक चेंज है, याद रखना. 20 days, प्रीवियसली 20 days था, अभी क्या है? 15 days. 15 days of inability to do ordinary pursuit. That is 15 days, not 20 days. There are 8 clauses are there. तो emasculation and others. ठीक है, याद रखना पड़ेगा. ठीक है, बढ़िया. ठीक है. Again, the classification of sexual offenses. So natural. तो natural मतलब pino-vaginal intercourse. इसमें आता है rape, incest, adultery. Rape, incest, adultery. Unnatural, sodomy, buccal coitus, bestiality, lesbianism. Buccal coitus means oral sex. Bestiality means with the animals. Sexual perversion, sadism, that is giving pain. Masochism, taking pain. Necrophilia, that is sexual intercourse with the dead. Fetichism, with the inanimate objects like petticoat and all. Transvestism, cross-dressing. Exhibitionism, showing genitals in the public place. Masturbation in public place, that is, and proteurism known as treacherism. And lastly, undinism. All these are important one. You just go through this. Next, linked offenses: stalking, voyeurism, sexual harassment, trafficking, indecent assault. So this is the broad classification of sexual offenses proper. Can anyone tell me हाँ अभी तक पूछा नहीं है, सो पूछ सकते हैं, ठीक है। सो नाउ माय क्वेश्चन, इंसेस्ट क्या फनिशेबल है? क्या इंसेस्ट फनिशेबल है? इंसेस्ट मतलब सेक्सुअल इंटरकोर्स बिटवीन रिलेटिव्स, बिटवीन फादर एंड डॉटर, फादर एंड डॉटर। कैन एनीवन टेल मी व्हाट इज दिस नाउन एज? मदर एंड सन, mother and son, brother and sister. Can anyone tell me what is the name given to this? Can anyone tell me what is the name given to these? इसको क्या बोलते हैं हम? Father and daughter. Once asked in exam, FMG exam. Father and daughter. इसको बोलते हैं Electra complex. Electra complex. Mother and son, Oedipus complex. Brother and sister, known as Pharaonic complex. Pharaonic. And it is not punishable in India. Not punishable. Not punishable. याद रखना पड़ेगा. Incest is not defined and not punishable. Punishable नहीं है, ठीक है? Good. ठीक है, बढ़िया हो गया. Now, bestiality, that is with the animals, commonly asked. ठीक है? Good. Now look at this. This is one of the interesting image. गोर आघात करना, section 116 BNS, मतलब grievous hurt. So grievous hurt कहाँ पे लिखा है? 116 में लिखा है. सिंपल हर्ट कहां पे लिखा है? 114 में लिखा है, ठीक है? याद रखना पड़ेगा आपको सिंपल हर्ट. तो सिंपल हर्ट 114 BNS. All of you write in the chat box. Simple hurt is equal to 114, grievous hurt is equal to 116. So there are 8 clauses are there: emasculation, permanent privation of sight of either eye, permanent privation of hearing, all this. There are 8 clauses are there. Just remember this line 116 एक बार पूछा गया है, ठीक है? So yes, ठीक है. Good, Manak Datta and others. Bestiality not in BNS, ठीक है? बढ़िया, वो भी चलेगा. गोर आघात करना, ठीक है, बढ़िया. Yes, any doubt in this? Any doubt? Dhananjay and others, Vipin Sharma, Dinesh. So after the class, just go through this 8 clauses. 8 clauses are there: emasculation, permanent privation of sight of either eye, permanent privation of hearing of either ear, privation of any member or joint, destruction, impairing the power of any member or joint, disfiguration of head or face, fracture, dislocation of bone or tooth, any hurt which endangers life, and severe bodily pain for 15 days. कितना लिखा है? 15 days लिखा है, 20 days नहीं. पहले आईपीसी में थे 20 days. इन न्यू क्लॉज 116 में लिखा है 15 days, मतलब 2 weeks है, ठीक है? बढ़िया विपिन शर्मा, ठीक है, बढ़िया हो गया. आगे देखते हैं. हाँ, look at this. Identify the sexual perversion given below. So here you can see the husband and wife, or the boyfriend and the girlfriend. So the husband is getting pain. He is getting pain just to get the sexual pleasure. So taking pain, इसको क्या बोलते हैं हम लोग? Taking pain. Giving pain. So taking pain, इसको बोलते हैं masochism. Giving pain is known as sadism. So the combination known as bondage. And this masochism can be associated with autoerotic death. एक इंपॉर्टेंट क्वेश्चन है, ठीक है? देन ट्रांसवेस्टिज्म मतलब क्रॉस ड्रेसिंग. इसको हम बोलते हैं सिसवेस्टिज्म ऑल्सो बोलते हैं इसको इयोनिज्म. को हम बोलते हैं इयोनिज्म. Fetichism by inanimate objects. inanimate objects. Yes, good. So this is again commonly asked in the exam. So बढ़िया हो गया. Next. Now look at this and try to identify. Look at this male here. He is wearing a female dress, acting like a female. है ना? Acting like a female. And by doing that he gets the sexual pleasure. इसको sexual pleasure मिल जाता है. ठीक है? दूसरा स्लाइड है, इसमें दूसरा इमेज है. इसमें देखो पूरा कलेक्शन है. तो इसमें है इनएनिमेट ऑब्जेक्ट्स है, फेमिनिन ऑब्जेक्ट्स है, साड़ी होगा, पेटिकोट होगा, अंडर गारमेंट्स होगा, अंडर क्लोथ्स होगा. तो व्हाट इज दिस बेसिकली? देयर आर टू इमेजेस. कैन यू ट्राई टू आंसर? ठीक है. इनएनिमेट ऑब्जेक्ट्स. ठीक है ना? गुड. सो मैनेकदत्ता इज टेलिंग सर सिस्वेस्टिज्म. ठीक है, सिस्वेस्टिज्म ही हो सकता है, क्रॉस ड्रेसिंग भी है, और इसको बोलते हैं हम ट्रांसवेस्टिज्म. एंड दिस इज बेसिकली पेटिकिज्म. तो पेटिकिज्म बोलते इसको. गुड. सो दिस इज अगेन द लिस्ट ऑफ सेक्सुअल परवर्जन. आपको पता होना पड़ेगा. सैडिज्म, मैसोकिज्म, बॉन्डेज, पेटिकिज्म, प्रोटेवरिज्म इज आल्सो कॉमनली आस्क्ड. प्रोटेवरिज्म मतलब टचरिज्म. ठीक है. एक्सिबिशनिज्म. Exhibitionism is that is showing the genitals. What are types of exhibitionism? Can anyone tell me what are types of exhibitionism? So there are basically three types are there. What are three types of exhibitionism? Come on, try this exhibitionism. एक होता है mooning मतलब showing buttocks in the public place with an intention. Running naked इसको बोलते हैं streaking. Then flashing. There is a fourth type. Can anyone tell me fourth type? Okay. ठीक है. एक और है. I think those who attended my class before can answer this. I think we can make out. Come on guys, come on, try the fourth type. Anasirma, इसको बोलते हैं anasirma. Okay, अनासिरमा. ठीक है, बढ़िया. ओके, हो गया. नेक्स्ट. नाउ इंटरेस्टिंग पिक्चर है, तो आपके लिए एक इंटरेस्टिंग सवाल है. आपने देखा होगा, वेरी फेमस मूवी है, अजय देवगन है, श्रेया, एंड सो इन दिस मूवी द विलन विल रिकॉर्ड the private act of the female and he will do blackmailing. Very famous movie, दृश्यम मूवी. इसको हम क्या बोलते हैं बताओ? Sexual perversion by taking image, by taking video of the female. What is that known as? Is it punishable or not punishable? क्या है बताओ ये? So yes, good. Try this. So this is classical. So basically voyeurism. इसको बोलते हैं हम लोग voyeurism. So why secretly installed hidden camera in a bathroom of his female tenant. Without her knowledge, the camera captured images of X while she was using bathroom, where she had a reasonable expectation of privacy. What is this known as? So 63 क्या था? रेप है. डेफिनेशन ऑफ रेप. सो 301 नेक्रोफिलिया. आपको याद रखना पड़ेगा. 301 इज नेक्रोफिलिया, नेक्रोफेजिया. 77 है पीपिंग टॉम, also known as voyeurism. So this is again commonly asked in the exam. 77 है. Voyeurism means taking image. Okay. Stalking मतलब 78. पीछा करना, फॉलो करना. 78. ठीक है. Yes. Yeah, this was asked, Dinesh. Yeah, this question was asked. So voyeurism is asked. Good, Dinesh. Good. Good. Chalo, आगे हो गया. So all of you guys, are you enjoying forensic class? Are you enjoying forensic class with the images and all in between? Yes, guys, say yes or no. Yes or no. Yes, come on, guys. Let's take 1 minute break, guys. Are you enjoying forensic class? You know, blunt force injury I discussed, abrasion, bruise, laceration. What are sharp force injuries? We discussed, that is basically stab wound and incised wound. And I hope you are enjoying classes. So yes, guys. Good. Okay, got it. That's great, guys. That's great. आगे देखते हैं. चलो. हाँ, look at this again. This question, very interesting question, guys. The question is: a 29-year-old female brings her boyfriend. So this is basically girlfriend and boyfriend story है. To a couple therapist doctor, she is uncomfortable with his behavior. Behavior abnormal था. क्या abnormal है? देखते हैं. She found him clutching her feet all the time. So he always insists to see her feet during sexual intercourse. Okay. So what is this known as? So he insists on being able to see her feet while they engage in sexual act. So this is abnormal. This is not exhibitionism, not masochism, not transvestism. इसको बोलते हैं हम लोग fetichism. Fetichism. The commonest fetichism is food fetish. Food fetish is the commonest one. Food fetish or bra fetish, inner garments fetish. All these are types of fetichism. Collecting inanimate object by looking at some object which is of less genital focus of interest. That is basically known as fetichism. B is the correct answer. Good. ये हो गया. So now this is one more important question. Commonly asked, बार-बार पूछते एग्जाम में, आपको याद रखना पड़ेगा. Teekman test, Takayama test, Barberio test, and Florence test. All are very important. So Teekman basically Hemin crystals, and this is basically for blood. Takayama is also for the blood, pink feathery crystals, so hemochromogen crystals. So Teekman and Takayama, they are the test for the blood stain. So how to remember? Takayama, Takamama. Mama is pink mama. Okay, so all of you write in the chat box. Takayama is equal to pink mama. Pink mama, आपको पता होगा, pink mama favorite of everyone. So pink मतलब basically blood stain. And what are the crystals? They are pink feathery crystals. Teekman आपको याद रखना पड़ेगा. Teekman, brown man लिखा है ना, brown man. He is a brown man. ठीक है. Both are the test for the blood stain. एक और याद रखना पड़ेगा आपको, Barberio test. Barberio test is very commonly asked. So yellow needle shaped crystals. Yellow needle shaped crystals, that is Barber test. Barberio. Yellow dirty fellow. Yellow dirty fellow, Barberio test. We use spermine picrate. Basically, we use picric acid. Spermine picrate crystals. याद रखना पड़ेगा. Dark brown rhombic, Florence test. Florence. So Florence is for seminal stain. Barberio is also for seminal stain. Okay, good. Yes, Dinesh, you are good. Dinesh, very good. You are answering great. So Dinesh, Barberio asked many times. Barberio means that is basically yellow needle shaped crystals. Spermine picrate crystal, picric acid. Florence, that is choline iodide crystals. They are basically brown rhombic. All four are very, very important. Yes, huh? Takatak pink. Okay, Takatak pink color. That's great. That's great, Shaker. Pink mama, and all. You are enjoying. That's great. Okay, okay. Florence also. Okay, good. Hope you are answering. I hope you will remember Takayama, pink mama, brown man. Both are for the blood stain. Barbario for the seminal stain, and Florence is also for the seminal stain. Are you understanding, guys? Are you understanding? Are you enjoying forensic class? Yes or no? ठीक है, बढ़िया. Magnetic Florence, choline iodide crystals. चलो हो गया बस. ठीक है. Next question is from identification. Ossification center appears at 7 months. 7 months मतलब viability. That means the fetus can lead its own life. Lungs are mature. Whenever 7 months passed, the answer must be talus. So talus 7 months. Calcaneum 5 months. Upper end of tibia 10 months. Lower end of femur 9 months. So this is very commonly asked. Okay. So the answer is Shekhar Pratap Singh. That's great. So this is talus, correct answer. So 7 months is equal to 28 weeks. 28 weeks means viability. So viability in India 7 months. Full term baby, that is basically 9 months, lower end of femur. 10-month-old baby, a 10-month-old fetus, that is upper end of tibia. Okay, so good. Nephthia, that's great. ठीक है, बढ़िया, ये हो गया. तो आपको याद रखना पड़ेगा all this. ठीक है. So this is about the one question. Then one question from insanity. So as you know, forensic psychiatry is also very important. Like psychosis, neurosis, insight present, absent, types of delusion, types of impulse disorder, types of hallucinations, true insanity, feigned insanity, very commonly asked. Insanity मतलब psychosis. ठीक है, psychosis, पागल. Features of true insanity all except. So now look at this. This person is suffering from schizophrenia. Look at this, his clothes. So dirty clothes, dirty habits. So all because of the psychosis. In psychosis, insight is absent. So awareness about one's own illness is absent. So this is the classical psychosis. So the question is, all are features except. एक होता है gradual insight. Yes, that is true. So always schizophrenia, bipolar disease, depression, gradual onset. Second, trance of delusions. Yes. The most common delusion is delusion of persecution. The most common hallucination, third person hallucination. So are the features of psychosis. Insight is impaired. Insight matlab awareness. That is also absent. So fear of detection. So answer is C. So आपको याद रखना पड़ेगा. Fear of detection is commonly seen in feigned insanity, not in the true insanity. So what are the example of true insanity? Schizophrenia. हम बोलते हैं ना split personality, that is schizophrenia. Bipolar disease, BPD. Mania, depression, all these are basically example for true insanity. ठीक है, answer is C. That's great. हो गया बस. So after the class, just go through this differences, features of true insanity and the feigned insanity, and all the points are given. Okay. Next. All are example of psychosis except. Psychosis मतलब insight is absent. Except लिखा है schizophrenia, bipolar disease, mania, obsessive compulsive disorder. What is the best answer? Yes, Dhananjay and others. Schizophrenia, yes. Mania, yes. The answer is D. OCD, there are different types. Washers and checkers and all. In OCD, insight is present. When insight is present, इसको हम बोलते हैं neurosis. Neurosis. What are two types? Washers and checkers. Washers and checkers. Two very common. Okay, D is the correct answer. Great. Good. So psychosis, judgment, insight, personality, contact with reality, that is absent. Psychosis. In neurosis, it is present. Delusion, hallucinations, very common in basically psychosis, that is not present in neurosis. Examples लिखा है schizophrenia, delusional disorder, mood disorder, mania, depression and all. So phobia, disorder, conversion disorder, OCD, anxiety, all these are basically neurosis. Very very important FMGE question. आपको याद रखना पड़ेगा FMGE, commonly asked, very commonly asked. ठीक है? So next I have a question for you. So one of my favorite heroine, if you ask me, so Deepika Padukone, something for the just to make the subject interesting, don't mistake me. So Deepika Padukone, one of my favorite. So Deepika Padukone is in deep love with me, though I never met her. I think that she is in deep love with me. दीपिका पादुकोणे मुझसे बहुत प्यार करती है, हालांकि मैं उनसे कभी नहीं मिला. So ये what type of delusion is this? This is very common in females. Can anyone tell me what type of delusion is this? हर्ष कुमार, जल्दी बताओ क्या है, क्या हो सकता है? हाँ, वेरी गुड हर्ष कुमार, वेरी गुड. एरोटोमेनिया, इसको बोलते हम एरोटोमेनिया. एरोटोमेनिया is common in females. It is also known as D. Clermont syndrome. D. Clermont syndrome, एरोटोमेनिया. ठीक है, बार बार पूछते एग्जाम में. दीपिका पादुकोणे है, एरोटोमेनिया है ना, फोरेंसिक सर, जस्ट रिमेंबर दैट. ठीक है, बढ़िया. ओके हर्ष कुमार, दैट्स ग्रेट. एक और है आपके लिए, एक और है. आइडेंटिफाई द टाइप ऑफ डेल्यूजन है. हियर इज द बेगर एंड हियर इज माय फेवरेट डोनाल्ड ट्रंप. ओके, माय फेवरेट डोनाल्ड ट्रंप. Unfamiliar people are mistaken for someone you know. Unfamiliar people are mistaken someone you know. A beggar is mistaken for your boss. So he is my boss. Donald Trump is my boss. So okay, a beggar is mistaken for your boss. Okay, what is this delusion known as? That is unfamiliarity of the familiar person. Can anyone tell me what is this known as? Come on guys, try this. What is this known as? And one more is there. Someone you know is pursued as an imposter duplicate. He is my boss, I know he is my boss. I think he is not my boss. He is a duplicate of my boss, or someone in disguise of Donald Trump. So there are two types of delusion. What are these two types of delusion known as? Can anyone tell me what are these two types of delusion known as? Yes, very good, Vipin Sharma and others, very good. So the answer is very good. That is Capgras syndrome and Frigoli syndrome. Very commonly asked. When a familiar person is considered as a stranger, Capgras syndrome. When a stranger is considered as a familiar person, that is known as Frigoli. So both are disorder of delusional doubles, है ना. Capgras and Frigoli बार बार पूछे एग्जाम में, FMG एग्जाम में. ठीक है, Frigoli and Capgras. ठीक है, बढ़िया. Then cephalic index of skull is used to estimate. Cephalic index of skull is used to estimate. So what is the best answer? Best answer. Sorry. Now let's take this skull. So example, this skull is present in the crime scene. So crime scene. So this is real skull. Real skull which is found in the crime scene. Police person is asking whether it belongs to China, whether it belongs to India, whether it belongs to European, It is found in Goa. So in Goa, foreigners also visit, Indians also visit, Chinese also visit. My question is how to identify this skull belongs to India, belongs to US, belongs to Africa. What is that index known as? चलो जल्दी बताओ, what is the answer guys? So इसको हम बोलते हैं cephalic index. Cephalic index. Good. So cephalic index is equal to breadth of the skull divided by length of the skull multiplied by 100. Multiplied by 100. It is classified into dolichocephaly. Dolichocephaly, mesocephaly, mesocephaly, and brachycephaly. Brachycephaly. Some books gives hyperbrachycephaly also. Dolicho 70 to 75, 75 to 80, more than 80. So 70, 75, basically we say Aryans, and Africans. 75 to 80, Indians, Chinese, Europeans. More than 80, Mongolians. Mongolians. आपको याद रखना पड़ेगा, ठीक है? याद रखना पड़ेगा. Commonly asked. So if they ask you an exam, cephalic index is maximum in, your answer should be brachycephaly. Cephalic index is minimal in case of dolichocephaly. The same question asked, anteroposterior diameter is maximum in, AP diameter maximum in, maximum in. Can anyone tell me? AP. Come on guys. Anteroposterior diameter is maximum in. Yes guys, come on, try. Yes, come on guys. AP maximum in. So a bit difficult one, but you can try. AP diameter. AP diameter. This is AP diameter. AP diameter is maximum in dolicho. Dolicho. Question asked in the exam. Okay? Good. Now race, okay. Age. So age, we use Gustafsson method. Gustafsson method. Gustafsson method. There are 6 components of Gustafsson method. Very commonly asked in FMGE. The mnemonic is script. Okay. Secondary tinctin, cementum apposition, root resorption, attrition, periodontosis, transferency of root. Gustafsson method. Sex very commonly asked is the bar body. Bar body, Davidson body. Davidson body. Stature, one commonly asked question is Pearson formula. Pearson formula. All these are FMGE question. FMGE question commonly asked. Okay. Script. Badhiya. Next. All are features of male skull except. What are the features of male skull except? Male skull. Now look at this. Now this skull is found in the crime scene. Look at this now. This skull. All of you guys. The forehead is steeper. So can you concentrate, guys? Can you able to see the skull, the real skull? Real skull. Come on, guys. So this is the steeper forehead. Rectangular orbit. The bones are heavy. Muscle markings are heavy. So this is classical male skull. In male skull, all are very prominent. All are very prominent. Except frontal parietal eminence. Frontal parietal eminence is common in females. Okay? This is commonly asked in the exam. So now look at this again. I think you can make out. So all of you just say hi to our guest, Boni. Our Boni is here. Say hi to our Boni. Hi, hi. Yes, come on guys. Say hi to our Boni. Boni can help you in exam. Steeper forehead, style, steeper forehead. Male. Male. Okay. Hi to Boni. Right, hi Boni in chat box. Hi, hey Boni. Yeah. Or Boni can help you. And also the Boni you can see here. You can see the sutures also. Sutures. Sagittal suture, coronal suture, lambda suture, metopic suture and all. The best suture for age estimation is sagittal suture. Just remember, the best suture is sagittal suture for age estimation. Okay. Good. So this is again commonly asked. Rectangular orbits, that is true. Prominent supraorbit, that is also true. Forehead is steeper, that is also true. And this is false. This is false. So this is in case of female. Female. Badhiya. Okay. Okay. So this is again commonly asked in the exam. Now look at this. Now I am in the Shava Pariksha room. I have two skulls here. So recently in one of the crime scene, we found 6 skeleton somewhere in Karnataka. 6 skeleton. I think 3 males and 2 females and a dog skeleton. So this is how we examine. Look at this. This is A and B. Can identify what is this A and B? So in A, what we can make out: steeper forehead, rectangular orbit, mandible is obtuse angle. Mandible obtuse angle, heavy, and frontal parietal eminence is small. In B, you can see here round orbit, chin is somewhat pointed, more obtuse, and bony markings are less prominent. A and B. Can you tell me what is this A and B? So A basically male, B that is basically female. So female. तो आपको याद रखना पड़ेगा all these features. Difference between male and female skull. ठीक है, bust. Okay, good. So after the class, go through this differences between male and female skull. Very commonly asked in the exam. Okay. Then one question from male and female pelvis. Male and female pelvis. Female pelvis. In female pelvis, greater sciatic notch is deep and narrow. That is wrong. So in female, it is shallow and wide. That's why. Everted ischial tuberosity, yes. Inlet is round, yes. Subpubic angle 90 to 110, that is right. Subpubic angle in males around 75 to 90. It is 90 to 110 in females. So greater sciatic notch I said already. And inlet in males heart shaped. Inlet in males, that is basically heart shaped. So this is very important one. Very important one. Again, this is the notes given to you, FMGE notes. You just go through this. Difference between male and female pelvis. Very commonly asked. Okay. चलो आगे देखते हैं. Some professional death sentence is given by. Now 1 or 2 questions from basically from State Medical Council, National Medical Commission, NMC, as you know. So professional death sentence. So we call it as PDS. Professional death sentence. PDS means removal of name of the doctor from the register. It is usually done by State Medical Council. State Medical Council. So the answer is State Medical Council. So in this case of PDS, doctor has to contact NMC to EMRB, NMC along with Central Health Ministry. Central Health Ministry. This is again the question can be asked. So SMC, State Medical Council, like Delhi Medical Council, UP Medical Council, Karnataka Medical Council. So AMRB, Ethics and Medical Registration Board, is a part of the NMC. Doctor has to contact AMRB along with the consultation with Central Health Ministry. This is how it actually goes. Okay, SMC is the correct answer. Now, when I talk about this, I remember one very famous personality, very famous hero, Vijay Devarakonda. You must have seen a movie. You must have seen Kabir Singh and all. So, what is infamous conduct? Can anyone tell me what are infamous conduct? Infamous conduct. What are infamous conduct? Commonly asked. Infamous conduct. Yes, come on. Can you tell me one at least one infamous conduct? Arjun Reddy, 6 A's are there. 6 A's. A for abortion. A for abortion. So abortion without any medical indication. That is basically infamous conduct. It is also punishable under Medical Termination of Pregnancy Act, MTP Act. So A matlab kya hai? That is basically, yes. Second, A matlab alcohol. Alcohol. So treating the patient under the influence of alcohol. So alcohol पी के patient को treat करना. Infamous conduct. Addiction. Addiction. And doctor is addicted to heroin, bhang, ganja, alcohol, cigarette, then it is also infamous conduct. Then addiction हो गया. एक और बताओ. Yes, dichotomy, association. Yes, association. Association is also known as covering. Association with unqualified person known as covering. Then A for adultery. Having sexual intercourse with the female, especially a female patient, or rape and sexual offenses. Okay. Then taking gift, that is also, yes, taking gift. Taking gifts. Dichotomy, that is fee splitting. So in all this condition, a person gets warning. So once warning is there, then the next step is temporary cancellation of the license. If it is permanent, इसको हम बोलते हैं professional death sentence. ठीक है? So all this basically याद रखना पड़ेगा आपको. And medical negligence punishable under 106 BNS. So all of you write in the chat box. Medical negligence or any negligence is punishable under 106 BNS. So all of you write in the chat box 106 BNS. 106 BNS. Keep writing. 106 BNS. Just type 106. So dichotomy means fee splitting, taking commission, giving commission. That is known as, yes, Dhananjayam and others. Keep writing. That's great. Okay, I said, so in this case, PDS, professional death sentence. And if neglected, or if the doctor wants to complain or wants to appeal, he can appeal to EMRB. EMRB, this can be question in your exam. Okay, Gorisha, good. Now, all are true about civil negligence except civil negligence. There are two types of negligence: civil, criminal, contributory, corporate. There are 4 types, right? So the question is, all are true about civil negligence. Simple absence of care and kill, yes, that is true. Like not giving IV fluids in case of burn injury. So that is civil negligence. Or it can be criminal negligence also. Patient consent is a good defense. Patient consent is good defense. So taking consent is a good defense, definitely. Contributing is a good defense, that is also good defense. Punishment is compensation, that is also true. What is the best answer then? Simple absence of care and skill. So, what is the best answer, guys? True about civil negligence is also correct. Contributing is also correct. Patient negligence is also good defense. Not taking, okay. So, all are true. The answer is none. Answer is none in this. None is the answer. So, none is the answer. So, compensation correct answer, not the jail. Fact speaks for themselves. The fact speaks for themselves. A Latin word. So there are many Latin words. Asphyxia literal meaning is pulselessness. The literal meaning of forensic is marketplace. The fact speaks for themselves is known as res ipsa locator. Like example here, instrument in the patient abdomen after surgery. Retained instrument. A res ipsa locator speaks for medical negligence, civil negligence as well as criminal negligence. Novus actus interveniens, that is known as act of God, the new action between the two original actions. Gross negligence is the criminal negligence. Negligence contributed by doctor and patient known as contributory negligence. The best answer is ipsa locator. Res ipsa locator. आपको याद रखना पड़ेगा. Okay. So novus actus interveniens is also known as act of God. Act of God. Act of God. Okay. But next. Medical negligence is punishable under. So 106 BNS already we discussed. Now it is not there. Now it is amended. Medical negligence is not under 106. There is only the civil negligence. No more it is a criminal negligence. Okay? So can anyone tell me what is 88 BNS? 88 क्या है? Can anyone tell me? 88, 89, 90. याद रखना पड़ेगा. याद रखना पड़ेगा all the 3. Come on guys. FMGE question. 88 is criminal abortion with consent. With consent. Without consent, 89. If death occurs, then it is 90 BNS. 90. 88, 89, 90. Okay. Next one question from legal procedure. So legal procedure, one commonly asked in FMG is police inquest. The most common inquest is police inquest. Second most common inquest is magistrate inquest. So in India only we have police and magistrate. Only 2 types है. एक होता है police, दूसरा है that is basically magistrate. So most common inquest in India, that is the police inquest. 194 BNSS. Magistrate is 196. Medical examiner in US. Coroners was in India. Was in India. It is not there now. It was there in India. Coroners. Now, what are the indications of magistrate inquest? Can anyone tell me? What are the indications of magistrate inquest? There are some indications. Anyone tell me one by one? Yes, come on, try guys, try. Yes, try. What are indications for magistrate inquest? So magistrate is the best inquest, superior inquest, usually done by Tahsildar, not by the police officer, Tahsildar or AC, DC like that. So indications, one indication is exhumation, death in lockup death, or in case of police firing, death in psychiatric hospital, dowry death, death in jail also. Okay, so death in jail, remand home, all these are indications. Okay, good. So dowry death already I discussed, 80 BNS. So can anyone tell me what is the time limit for exhumation? What is the time limit for exhumation? Come on guys. What is the time limit for exhumation? So exhumation matlab digging out the dead body from the grave for second autopsy. So my question, what is the time limit? Time limit क्या है? जल्दी बताओ. DD मतलब क्या है? Dowry death. 80 BNS. No time limit. Very good. So exhumation, no time limit. No time limit. Okay. Good. ठीक है. Good. ठीक है. बढ़िया. Okay. Now one or two questions about the toxicology. Again, toxicology very vast. Everything given in the notes. True about ideal homicidal agent. Homicide मतलब murder. ठीक है? Homicide means murder. That means 103 BNS. 103 BNS. So murder has two components. Mens rea, actus reus. So guilty mind and guilty act. So ideal homicidal. Less toxic, unpleasant taste, signs and symptoms mimic like natural disease, costly by price. Okay, so good. So costly by price, no. Unpleasant, no. Less toxic, no. So answer is C is the answer. So like example you can see here, this is PAN. Can you tell me some ideal homicidal agent? So examples are arsenic, thallium, aconite. So just remember, the king of all poison, arsenic. The aconite is queen of all poison. And thallium is king of all king. King of kings. Sing is king. King of kings. So all of you just try to remember. King of all poison, arsenic. Queen of all poisoning, aconite. The king of all kings, thallium. And remember, arsenic resembles like cholera. Can anyone tell me what is the taste of aconite? What is the taste of aconite? Aconite, you know, cardiac poison, which causes cardiac arrhythmia and death. Very, very powerful poison. It leads to heart block and death. Mimics like a heart attack. My question is, what is the taste of aconite? What is the taste of aconite? कमान जल्दी जल्दी बताओ. Sweet in taste, very good. It is sweet in taste. Sweet taste है, याद रखना आपको, sweet in taste. So all these are commonly asked. Arsenic resemble like cholera. Cholera. Can anyone tell me metal fume fever is caused by? Metal fume fever is caused by. Metal fume fever. Commonly asked in FMGE. Also known as Monday fever. Also known as office fever. Factory fever. So it is caused by copper. है ना? Copper. Copper. Zinc. Zinc also. Sometimes zinc also. Okay. Yes. So that is very commonly asked in the exam. Metal fume fever. Zinc. Good. So again, that is notes is given. Ideal homicidal and ideal suicidal. तो दोनों आपको पढ़ना ही पड़ेगा. ठीक है, आगे देखते हैं. Following is an example for organochlorines. One more favorite of FMG. Organochlorines and organophosphorus. So organophosphorus, OP and OC. OP and OC. Commonly asked. Okay. So what is the best answer? Following is example for organochlorine. So organophosphates are classified into alkyl phosphates, aryl phosphates. Alkyl phosphate answer is malathion. Aryl phosphate example is parathion. Organochlorine's answer is DDT. So best answer is DDT. So Manak Datta, the answer is DDT. Good. So HETP, TEP and HEP, all these are basically organophosphorus compounds. So they inhibit acetylcholine esterase enzyme irreversibly. What is the drug of choice? Drug of choice is atropine. Atropine is the drug of choice. Good. So that is about this question. Okay, good. So you can see here alkyl phosphates are HETP, TEPP, OMPA, malathion, tricloran. Parathion, all these are basically aryl phosphates. DDT, BHC, aldrin, chlordane, dialdrin, endrin, paraquat, all these are basically organochlorines. So organochlorines inhibit neuroparalysis. Okay, they inhibit neuroparalysis. There is no specific antidote for organochlorine poisoning. Specific antidote nahi hai in case of organochlorines. Antidote is very specific in case of organophosphorus compound. The drug of choice is atropine. Atropine. Okay, good. Chalo, ho gaya. Next, all this treatment and all you must know. OP poison commonly asked in the exam. आपको पढ़ना ही पड़ेगा. Next heading, 1 or 2 questions about the snakes. All are features of poisonous snake except poisonous snakes. Poisonous. So poisonous snakes basically big four. Big four. Large belly scales. So triangular head. Nocturnal habit. Always rounded tail. Large belly, that is basically common cobra. Vipers and all. Triangular head, that is in case of vipers. Nocturnal habit, poisonous. The answer is always rounded. It is pointed in poisonous snakes. So always rounded hai na? Rounded, that can be in cobra, but pointed in general in case of poisonous snakes. So this is basically always rounded tail. That is the correct answer. Now look at this 4 important snakes commonly asked in the exam. Can you identify these 4 snakes, guys? A, B, C, D. A, B, C and D. So in A, what we can see, the hood. Hood is there. Spectacle mark is there. Spectacle mark is there. 15 milligram is a fatal dosage. Death occurs within 6 hours. In second, triangular head is there. Dark brown spots are in the back of the head. Back. Dark brown spots are there. In C, What you can see here, white wavy line is there and triangular head. In 4, steel black in color, transverse white band is there. One of the most poisonous snake. It resembles like stroke. We call it as cunning snake. इसको हम cunning snake बोलते हैं. So it is also known as very poisonous snake. Like a Kattappa character in Bahubali. So ABCD, Manakdatta and others. So this is basically common cobra. So big 4. We're talking about big 4. So the big 4, one is common cobra. One is common cobra. So in common cobra, you will see spectacle mark in the hood. The second one is a Russell's viper. Russell's viper. The scientific name is Dubai russelli. So vipers are hemotoxic. And this is star-scaled viper. Star-scaled viper. And this is common crate. So common crate. So most poisonous is common crate. The fatal dose is 3 to 6 milligram. 3 to 6 milligram. So okay. Now, so all of you guys, what is the treatment? What is the treatment in this snake bite? Big 4 snakes. As you know, ASV. Anti-snake venom. Polyvalent anti-snake venom. The dosage is same in adults as well as in children. The most common side effect is hypersensitivity. So there are no contraindications. So only treatment is ASV. And we have one approach known as right approach. Right approach. Right approach. Asked in exam. R matlab reassurance. I matlab immobilization. GH matlab get to the hospital. Tell the doctor about the emergence of symptoms. So right approach is applicable for the snake bite. So the snake bite we use right approach. So this is again commonly asked. Fatal dosage, fatal period given in the boxes. You can just go through that. The most toxic is the common crate. Remember, common crate is presynaptic. Common cobra is postsynaptic. Yes, good. Right approach. Good. So that is about the snakes. Burnt drop smell is felt in the poisoning. Again, favorite of FMGE exam. Burnt drop smell is felt in the poisoning with cannabis, hydrogen sulfide, cyanide, arsenic. Burnt drop smell. Can anyone try? Can anyone try, guys? Burnt drop smell. So arsenic, I remember garlic smell. Garlic. Cyanide, bitter almond. Hydrogen sulfide. What is the smell in hydrogen sulfide? What is the smell in hydrogen sulfide, guys? Commonly asked. Hydrogen sulfide. Hydrogen sulfide. Cannabis, burnt rope. Burnt rope. Can anyone tell me hydrogen sulfide, what is the smell? Hydrogen sulfide, commonly asked. So cannabis, we have preparations like ganja, charas, and bhang, mazoon, hashish oil. Hashish oil. Okay. So it consists of 9-tetrahydrocannabinol, THC. So the treatment is, so that is supportive treatment. Supportive treatment. Commonly asked in the exam. Okay. So yes, good. So yes, many answer. Hydrogen sulfide is rotten egg. So yes, very good. Rotten egg smell. Very good answer. So the answer given by Vipin Sharma. Yes, Vipin, very good answer. Vipin and Gorisha. Vipin, rotten egg. So arsenic, garlic, cannabis, burnt rope, alcohol, fruity, cyanide, bitter almond, hydrosulfide, rotten egg, chloral hydrate. Repeat question FMGE. Basically acrid PO. Naphthalene, mothball. Salicylate, that is menthol. Okay. So zinc phosphate, fishy. तो जिंक फॉस्फेट में हम हमें मिलता है फिशी स्मेल, है ना, फिशी स्मेल. So then, look at this. Just try to memorize. Rotten egg, spoiled egg, hydrogen sulfide, and garlic smell, arsenic and phosphorus. Arsenic and phosphorus. So arsenic is known as king of all poison. King of all poison. That's great. Next. Then after the class, just go through the poison and the antidote. Very commonly asked. So frequently asked. Acetaminophen and acetylcysteine, antidote. Nitrate and cyanide, we use amyl nitrate, sodium thiosulfate. Organophosphate, atropine and enzymes. Digoxin, digibind. Ethylene glycol, methanol, ethanol, very important. Fomepizole. Heroin, we use naloxone, nalmefene. Benzodiazepine, flumazenil. Datura poison, datura we use physostigmine, very important. Acute iron poison, deferoxamine. Acute arsenic poison, so we use dimercaprol and ball. Oxalic acid, calcium gluconate. Strychnine poison, short acting barbiturate. So very, very important table. FMGE exam. Okay, yes, very important table. Okay. Now can anyone tell me what is the contraindication of oxime? Oximes are contraindicated in. Oximes are contraindicated in. Repeat question FMG. Oximes are contraindicated in. They are used in organophosphorus poisoning, but they are contraindicated in case of carbamate poison. You know? So the answer is carbamate. Carbamate. FMG question. Good. Yes, Dhananjay. Okay, that's great. Dhananjay M. That's great. Great. So then speedball is heroin plus cocaine, phencyclidine, chloral hydrate, MDMA. So just remember, MDMA is amphetamine. It's a party drug. Party drug. Chloral hydrate known as dry wine. Phencyclidine known as angel dust. This is speedball. Speedball. Okay, so answer is heroin plus cocaine. Good. And remember, in heroin, so the drug of choice is naloxone. So what are the features of clinical features of heroin poison? What are the clinical features of heroin poison? What are the clinical features of cocaine poison? So this is FMG, repeat. So in heroin, what are the features? And in cocaine, what are the features? So in heroin, you will see coma, constricted pupil, and hypoxia. And hypoxia. Hypoxia because of the respiratory system depression. So in cocaine poison, cocaine, you will see dilation of the pupil, increased blood pressure, increased heart rate, stroke risk is very high. Okay, and you will see sweating. Sweating also. Sweating. The treatment is amyl nitrate. In case of cocaine poison, we use amyl nitrate. So this is, and chronic cocaine poison, you will see Magnan symptom. So frequently asked, Magnan symptom. So once this was asked in your FMGE, multiple scratch marks all over the body. The patient is suffering from dash type of withdrawal, cocaine withdrawal syndrome, Magnan symptom. Okay, it's a type of tactile hallucination like this, tactile hallucination. Okay, like this. Okay, guys, hope you are understanding. Dhananjay AM, good. Now, what are the features of alcohol withdrawal? Alcohol withdrawal syndrome, commonly asked. Alcohol withdrawal syndrome. What are they? What are the syndromes associated with alcohol? One by one. One by one. Come on, guys. Come on. So, in alcohol withdrawal syndrome, you will see delirium tremens. Delirium tremens. Okay. That is after 48 hours and 72 hours. That is withdrawal syndrome. Alcohol leads to vitamin B1 deficiency. So, alcohol leads to vitamin B1 deficiency. It leads to Wernicke encephalopathy. Wernicke encephalopathy. So, as you know, vitamin B1 is important for myelination. When myelination is affected, that leads to Wernicke encephalopathy. Then we have Korsakoff psychosis. Korsakoff psychosis. Korsakoff psychosis characterized by approximate answer. That is again because of vitamin B1 deficiency. Korsakoff syndrome. Okay. Then Marchia-Fava-Bignami syndrome. Alcoholic hallucinosis. So there are many syndromes associated with alcohol. Okay. Good. So can anyone tell me what are the features of Wernicke encephalopathy? So Wernicke, just remember Goa. Goa. So Goa matlab Wernicke. Wernicke matlab Goa. Goa matlab alcohol party. So global confusion, ophthalmoplegia, ataxia. I'll repeat again. Global confusion, ophthalmoplegia and ataxia. So this is about the alcohol. So this is the brown sugar. Then one more commonly asked question is cannabis. So cannabis. So what is the common side effect of cannabis? What is the common side effect of cannabis? So those who are taking cannabis for a long time, maybe 1 year, 2 year and all, so they get impulse of murder. So they keep on killing friends, keep on killing enemies. So aggressive behavior, intention of murdering people. What is that known as? So Manak Datta and others, what is that known as? Come on guys, come on guys. Cannabis. So in cannabis, you will see a motivational syndrome. A motivational syndrome. एक होता है ए मोटिवेशनल सिंड्रोम, मतलब स्टिमुलस ही नहीं होता, नो इंटेंशन, nothing in life. So a motivation syndrome. Then you will see run amok. ठीक है? So good answer, Dhananjay. That's great. And all these drugs. So taking all these drugs is punishable under NDPS Act. NDPS matlab not New Delhi Police Station. NDPS means Narcotic Drugs and Psychotropic Substances Act. So taking MDMA, chloral hydrate, phencyclidine, cocaine, any drug that is punishable under NDPS, most of the offences are non-bailable, cognizable and also non-compoundable. So very strict act, NDPS Act. Good. So immature syndrome, Koro syndrome, all these are basically important. Okay. So cocaine is very commonly asked. Phencyclidine, okay, all this common. Datura also can be asked. Datura. So Datura, just remember 9D manifestation. So and drug of choice is physostigmine. So Datura, the active principle is hyoscine, hyoscyamine, and traces of atropine. 9D manifestations. It's a road drug, or we can say it is used as a street drug, just for the robbery and all. Okay, good. Psychotic substances. Good. I hope you remember this. All of you clear? You want me to discuss again? Is it okay? Say yes or no. Say yes or no. So that's great. So this completes your the class. So almost all important topics are covered. So in a short time, around in around 2 hours. Okay. Hope you getting my point. Yes, guys. Yes, all of you guys, I have a question for you. What do you mean by juvenile? So last few minutes, guys. What do you mean by juvenile? Look at this pinky. We call it as juvenile. What do you mean by juvenile? And juvenile offences, so are offences against the juvenile, comes under an act. What is that act? Can anyone tell me? What is the act related to the offences against the juvenile, male or female, especially sexual offences? This can be asked in your exam, guys. So repeat question, commonly asked. So today we have pinky at last. So what do you mean by juvenile? FMGE question. What do you mean by juvenile? So what do you mean by POXO? Two important questions. Come on, guys. So juvenile means male or female less than 18. So less than 18 year, male or female. What is POXO? Protection of children from sexual offences. So when you have time, just go through this PSA, APSA, SA, ASA, and SH. PSA means penetrative sexual assault. APSA means aggravated penetrative sexual assault, and sexual harassment. This is very commonly asked in the exam. Okay, good. So Shekhar Singh, that's great. Okay, fine. So all of you say, what is the center that appears at 18 year? What is the center that fuses at 18 year? For example, this pinky, I say less than 18 year. So pinky, say hi pinky. So say my question is, this pinky is less than 18 year. How to confirm that her age is more than 18? How to confirm her age is more than 18? Any other center, guys? Any center? Any center that fuses at 18 year? Come on, guys, can you try? Center that fuses at 18 year. 18 year. So most of the long bones. Fuses at 18 year, especially ulna and radius. Ulna and radius. Just remember, so the best X-ray for 18 year is, that is a wrist joint, and also you can take the hip joint as well. So that is the best X-ray. So this yes, clavicle medial end also correct. POXO, that is also correct answer. So this completes your session. Thank you all. Thanks for your. Any doubt you can ask me. Any doubts? So any doubt in today's class, you can ask me, guys. For next 5 minutes, if you have any doubts, you can ask me. Yes, dyadic death means 2 or more people are dying. So good question from Menak Datta. Dyadic death. So dyadic death means 2 or more person, usually 2 persons, husband and wife, boyfriend and girlfriend. So they're dying at the same time by suicide. Like example, keeping a pole, keeping a beam, and ligature and dying. That is known as dyadic death, one of the method of suicide. Okay? Yes. So this completes your session. So last 1 minute. If you have any doubt, you can ask me. So wish you all the best for upcoming FMG exam. Go through the notes. Go through the all the FMG notes that is given to you. So forensic medicine, this is more than sufficient. Just again go through the notes, all the important questions and important tables. Revise once or twice. So many questions do come from this. Yes, thank you, Dinesh. Thank you all.